and these are the junctional areas, which are the neck, the axilla, and the inguinal area. So lastly is the application of a tourniquet. So a tourniquet can be applied about 2 to 3 inches above the wound. Do not place it over joints as it will not compress the blood vessel in that area. And you should be tightening the tourniquet until the bleeding stops. Okay. Once the tourniquet is applied, do not remove the tourniquet until professional uh, assessment can be done. So tourniquet can be applied to others or even to yourself. Okay, if you're injured, you can easily apply a tourniquet to yourself, and this can be applied over clothing, especially if uh, the area injured cannot be visibly seen. This is in one case in tactical combat casualty care, wherein the tourniquet is applied high and tight. You don't need to identify the area or the exact area is bleeding, but apply the tourniquet high enough so that it will control bleeding anywhere from the extremity down below. Application of this tourniquet usually hurt, and second tourniquet can be required to stop the bleeding. So if the first tourniquet was not successful, you can apply a second tourniquet more proximal than the first tourniquet. So the third video shows you how to apply a tourniquet. In this case, they will be applying a combat application tourniquet. So that is the combat application tourniquet, which is used by the military, approved by the Committee on Tactical Combat Casualty Care. So when you apply the tourniquet, it should be applied tightly, okay, and cross it over the Velcro. The next thing to do is to rotate the windlass rod. Ideally, you should not be rotating the windlass rod more than 2 times, 2 to 360 degrees. Okay, so once the windlass rod is tightened, it is anchored to a clip. The remaining strap is applied over the windlass rod, and a second strap is applied over a clip wherein the time of the application is being written, so that anywhere the patient goes, the people receiving the patient will know what time the tourniquet was applied. Okay, there are several tourniquet in the market, but what we have is the combat application tourniquet, and the second one here is the Special Operation Forces tourniquet, and the difference only is the windlass rod for the soft T is a metal, while the combat application tourniquet windlass rod is a plastic windlass rod. So there are other tourniquets in the market. This one, the SAM XT, is a junctional tourniquet, which can be used in the inguinal area. Okay. And these are the RMT and the TMT, which are being used by the emergency medical personnel. Okay. Those that were shown earlier were non-pneumatic limb tourniquets, but we also have pneumatic tourniquets. Okay. Other examples of junctional tourniquets are the combat ready clamp, the junctional emergency treatment tool, and the SAM junctional tourniquet. So as you can see, this circular thing are actually inflatable, which is directly applied on the inguinal area or the groin area where the bleeding is coming from. Then you have the pneumatic limb tourniquets, which are the Delphi and the tactical pneumatic tourniquet. So according to the National Center for Biotechnology Institute, muscle damage is nearly complete by 6 hours. Will likely require amputation, and numerous studies have been performed to determine the maximum duration of tourniquet use before complication. So the general conclusion is that tourniquet can be left in place for 2 hours with little risk of permanent ischemic injury. How about bleeding control in children? In all but the extremely young child, the same tourniquet used for adults can be used in children. And for infants or very small child, tourniquet is too big, so direct pressure in the wound as described previously will work in virtually all cases. For large deep wounds, wound packing can be performed in children, just in adults using the same technique as described previously. How about impaled objects? Impaled objects should not be removed. So if you apply a tourniquet, the tourniquet should be applied over the impaled object. About the loss of arm or leg, as mentioned above, there was the consensus is you can maintain the tourniquet for 2 hours without developing ischemic injury to the extremity. Definitely, the application of tourniquet will entail a lot of pain, so you should advise your victim or your patient that it is part and it is not because the tourniquet was not applied properly. Okay, improvised tourniquet. Although the Committee on Trauma advised the use of the combat application tourniquet, of course, in austere environment, we can always improvise tourniquets in the field. We can use a rubber band, handkerchief, a necktie, a belt. Okay, so this could not be overly emphasized in this scenario wherein one of our colleagues applied a belt on a woman whose arm was severely or amputated in a freak accident in an MRT station. Okay, so our colleague here is now actually a orthopedic resident, Dr. Handy. In an earthquake in 2019 in Porac, Pampanga, they have to apply a tourniquet to the thigh of a victim whose leg was pinned on a concrete beam. So they have to amputate the extremity after application of 2 tourniquets on the thigh. How about hospital use of tourniquets? Well, patients who arrive at the emergency room with life-threatening bleeding, if you have an available tourniquet on hand, don't hesitate to use that tourniquet. Okay. So even in operating rooms, our orthopedic surgeons use this pneumatic tourniquet during their surgery. As for the Committee on Trauma of the American College of Surgeons, they have approved equipment which is bleeding control, included in a bleeding control kit, which include hemostatic dressing, okay, a pen, gloves, and the tourniquet. Okay, these are placed strategically in areas like train stations, airports, malls, just like an AED or first aid kit, okay, which individual bystanders can easily get and apply it on a patient who has suffered a bleeding injury. So in summary, it is important that if you will respond to this patient, your personal safety is a priority. Next is alert someone and call for help, followed by identification of the bleeding area and control of the bleeding by applying direct pressure, wound packing, or a tourniquet. And lastly, before leaving that patient, you must wait for professional help to arrive to replace you. So this is the poster for the Stop the Bleed, which you can download in the Stop the Bleed website. So after this, it is you are encouraged to give this lecture to any organizations, even in your locality. Okay, can give this in your organizations like the Boy Scouts, the even the Lions Club. Okay, so we want you to propagate this Stop the Bleed program. This is like the uh, CPR, okay, wherein everybody should know CPR. So if everybody should know CPR, everybody should know how to stop the bleed. So lastly, the only thing more tragic than a death is a death that could have been prevented, and that is to stop the bleed. Thank you, Lance.
Sorry, I thought my mic is open. Thank you po, sir. May I check first for the questions from our residents? Mukhang wala pa po, sir. We can proceed now po with the cervical spine instability, sir. Thank you po.
Thank you. So good morning again. I will now be giving you the lecture on cervical spine stability. I have two objectives for this lecture. First is to identify, recognize, and protect patients with probable cervical spine instability. And second is to identify abnormalities on cervical spine films. For spine injury, we all know that 5% of patients with traumatic brain injury will have associated a spinal injury. And 25% of this patient with spine injury will have at least a mild traumatic brain injury. So most of the injuries in the spine occurs in the cervical area for the reason that this area is the most mobile, okay, and most exposed area of the cervical spine. And this includes about 55% of spine injuries. And the rest of the injuries are distributed equally in the thoracic, the lumbar, and the sacral area. Okay, 5% of patients arriving at the emergency department will develop progression of symptoms, either because of secondary to ischemia or progression of the spine edema, which can be also secondary to excessive manipulation or inadequate protection of the cervical spine. So according to the 9th edition of the ATLS, in a patient with the spine protected, evaluation of the spine and exclusion of spinal injury can be safely deferred during the primary survey, especially in the presence of systemic instability, such as hypotension and respiratory inadequacy, which are the life-threatening injuries which you should be identifying in the primary survey. So protection is primary and identification of spine injury is secondary. This is in the primary survey of the ATLS. However, there should be caution because there could also be possible adverse events with application of a cervical collar. So according to Sandstrom et al. In 2014, okay, patients with ankylosing spondylitis can suffer from a spine injury with hyperextension of the cervical spine during standard pre-hospital immobilization. Okay? And a tightly applied cervical spine can also increase intracranial pressure, okay, because of reducing the venous outflow from the brain. Okay. This is a rigid cervical collar, but we all know about this, but we should also know that this cervical collar are to be adjusted according to the physique of the patient. Okay, so we have this uh, buttons here to adjust the collar, whether the collar should be small, medium, large, or an XL size. And the way to measure it is from the mentum to the sternal manubrium of the patient. Okay, so it is not enough just to apply this collar. It should be properly applied by measuring the distance from this area and adjusting your collar. Again, according to Sundstrom et al., who gave us the possible adverse events of a collar, any form of immobilization is still superior to no immobilization at all. So the most effective immobilization methods seem to be the combination of a rigid collar with supportive blocks on a rigid spine board and straps. So the best protection that can be provided using a collar is with the supportive blocks and straps on a spine board. Now we go to cervical spine assessment. Spinal immobilization is a priority in a multi-system trauma, while spinal clearance is not. The spine should be assessed and cleared when appropriate, given the injury characteristics and the physiologic state of the patient. So imaging the spine does not take precedence over life-saving diagnostics and therapeutic procedures. So as discussed earlier by Dr. Ray Resurrection, in the primary survey, you only have two radiologic uh, procedures that are being done. That is the chest X-ray and a pelvic X-ray, which usually impacts you on the breathing and the circulation part of the primary survey. So even if you have uh, knowledge that the patient is being has a spinal cord injury, the only thing that you will do during the primary survey is to maintain that cervical collar and proceed to addressing life-threatening injuries. That is why your ABCD in the primary survey, C spine protection is concomitant with airway management. Okay. So if in cases where you need to intubate this patient, you might need to remove that cervical collar and provide an inline immobilization coming from another healthcare provider. Okay. So during the process of intubation, the second individual is providing immobilization and stability on the neck area. Once the patient is intubated, then you reapply your cervical collar. So cervical spine assessment starts after your primary survey. That means life-threatening injuries are identified and managed. Your patient has been stabilized, and you have reassessed your patient, and that patient remains to be stable after reassessment. Okay, given this scenario, we have a 30-year-old male who was pinned down by a car while riding a bicycle. Okay, he was brought by a bystander, awake, alert, conscious, and complaining of not complaining of any neck pain. So my first question to you is, will you request for a cervical spine X-ray for this patient? Okay, hold on to your answer. Let's see if you're correct. So cervical spine assessment should be entertained for mechanism of injuries like fall from an elevation of more than 3 feet or a 5 stairs fall, an axial load to the head, like for example, diving in a swimming pool with the head landing on the floor, motor vehicle crash high speed more than 100 kilometers per hour, which involves rollover and ejection from the vehicle, motorized recreational vehicle injuries, a pedestrian being struck by a vehicle, or a bicycle crash. There are several clinical screening decision tools that can be used. You have the Canadian Swiss Spine, the National Emergency X-Radiography Utilization Study, or the NEXUS. You have the Australian SpineX, the American Spinal Injury Association, or the ASIA, and the REMSAP. Okay, can see this in internet. Okay, so this is the algorithm for the Canadian spine rule. This is the algorithm for the Nexus, and this is the algorithm for the Wilderness medical safety. Okay. Although there are several which we can use, we will be discussing the Canadian spine rule. There are two options for patients who require radiographic evaluation of the cervical spine. So according to the ATLS 10th edition, in locations with available technology, the primary screening modality is a multi-detector CT from the occiput to T1 with a sagittal and coronal reconstruction. Okay. So ang premise doon is if the technology is available. So maybe if you will be admitted at the St. Luke's or the medical city, the primary screening modality will be a multi-detector CD. So where this technology is not available, plain radiographic films from the occiput to T1, including a lateral, anteroposterior, and an open mouth odontoid view, should be obtained. So the next question is, if we will be requesting, what are we going to request? So it was mentioned earlier that we should be requesting for the AP view, the lateral, and the open mouth view. Okay. Cervical spines, the cross-table lateral films usually excludes 85% of fractures, and the addition of the AP and odontoid views exclude most of the fractures. CT scan may be used instead of plain X-ray as mentioned above if the technology is available. But in addition to the three views, you may require to get a swimmer's view, or if the patient is already manifesting a neurologic deficit, you can go straight to magnetic resonance imaging or MRI. It is important to note that 10% of patients with C-spine fractures every second associated non-contiguous vertebral column fracture. So if you identify a C-spine fracture, look for another abnormality in the entirety of the spine. So a radiographic screening of the entire spine is required in this situation. These are the three views. You have the anteroposterior view, which gives you the view of the C3 and the C7. The lateral view gives you the C1 and the C7 view. And the open mouth view gives you a view of your C1 and your C2. Okay. These are the lines that you should be evaluating when examining a radiograph of the C-spine. Okay. First is the soft tissue line, which is the soft tissue anterior to the vertebral body. And this is the posterior aspect of your aerodigestive tract. Okay. What about the soft tissue line? So for the soft tissue line, usually between the soft tissue line and the anterior vertebral line, you will be able to accommodate a full vertebra at the level of C4, okay, and a half vertebra at the level of C3 and above. So at the level of C4, the soft tissue space should accommodate the entire vertebra, while at the level of C3, half of the vertebra should be accommodated. So other than that, if you were just able to accommodate half of vertebra at C4 or C3, there it may denote a problem. So the second line, which is the anterior vertebral line, runs along the anterior border of your vertebral body. Okay. And the third line is the anterior spinal line. So between the anterior vertebral line and your anterior spinal line, this will house your vertebral body. And this line should have smooth curves with no steps or discontinuity along its course. A step more than 3 millimeter is significant. Now we go to the fourth line, which is the posterior spinal line. So between the anterior spinal line and the posterior spinal line is the space which will accommodate your spinal cord. So the distance between the anterior spinal line and the posterior spinal line should be between 14 millimeters to 18 millimeters. Anything less than 14 millimeters or more than 18 millimeters is significant. And lastly is your spinous process line, which runs along the tip of your spinous process. Again, this spinous process line should run smoothly along its course. So if you will correlate these lines in a radiograph, this is how it looks like. How about the open mouth view? See, the open mouth view will give you a view of your dents, which should be in the center with equally distant space between the body of C1. Then you have the lateral view. This is the lateral view, which gives you the atlanto-dens interval or the ADI. This is a distance between the body of the C1 and the dens. Okay. So the distance between the atlanto-dens interval is less than 2.5 millimeter. So if the distance between that is more than 2.5 millimeter, there could be a problem with the C1, like in Jefferson's fracture. Now we go to cervical spine evaluation. So again, not to overemphasize, we do our evaluation after the primary survey wherein the patient has already been stabilized, okay, and remains to be stable. Now we go to spine evaluation. So for patients who are reliable and they may not have the 3 views. If they have a GCS of 15 and alert, they are not complaining of any neck tenderness or any neck pain. There should be no distracting pain and neurologic deficit. So what is a distracting pain? Like for example, in a patient who has an associated clavicular fracture, okay, the pain from the clavicular fracture can be a cause of a distracting pain, which will give you difficulty in assessing whether the patient really has a neck pain or is it because of the distracting pain. So if your patient who is a reliable patient doesn't manifest any of this, you can remove your cervical immobilization at this point. So reliable patients means there's no evidence of head injury, no psychiatric problem, no alcohol intoxication or substance abuse. How about for reliable patients with any of the following? So if your patient is reliable but complaining of neck pain, or in PE, there is neck tenderness and distracting pain, the best thing to do is maintain that cervical collar and request for the 3 views, your AP, lateral, and your open mouth view. So if the 3 views of the cervical spine X-rays are negative, but the patient is symptomatic for possible cervical spine injury, then you request for a dynamic view, a CT or an MRI. Okay. If your CT is negative, then you can remove your collar. However, if your CT has significant findings, you refer these patients to orthopedic or your neurosurgery service. If your 3 views are questionable or of the onset, you have a significant finding on the 3 radiographs, then immediately refer the patient to ortho or neuroservice. How about for the unreliable patients? So unreliable patients are patients who are intoxicated or what, you request again for the AP lateral and the open mouth. In the last instance, wherein a patient is intubated, definitely you will not be able to do your open mouth view. So you request for a thin cut eggshell CT scan of C1 and C2, and if there are possible suspicions or poorly seen areas in the entirety of the cervical spine. So personally, if you will request for this one, might as well request a CT of the whole cervical spine. For patients who are presenting with urologic deficit, immediately refer this patient to C spine because these patients might need to have an MRI. Okay. Now we go to several X-ray series. Okay. So what is the problem with the first picture on the left? The first picture on the left doesn't show a complete view of your C1 to T1. So you should be able to see the interface between C7 and T1, which when repeated, it showed a spondylolisthesis between C7 and T1. Okay, so if you request for lateral cervical spine X-ray, you should be able to view C1 to T1. Okay, don't settle for X-rays which doesn't give you a complete view of C1 and T1. Okay, so this one has dislocation of from the second dislocation of the vertebral body, separating the C2 and C3, almost a partial decapitation of this area. For this one, you have a spondylolisthesis at C5 and C6. I mentioned this earlier, Jefferson fracture, where there is a fracture of the atlas separating the atlas from the dens. So if you will get the ADI of this patient, this will be more than 2.5 millimeter. Okay. This X-ray shows us a fracture of the odontoid. Okay, so you can see in this radiograph, there's a fracture of the odontoid at the base, and this is classified as type C. Okay, this is a hangman's fracture, although not because of the gruesome name. The hangman's fracture is not actually caused by hanging. It is caused by hyperextension of the neck, especially from acceleration, deceleration forces applied in a motor vehicle crash. Okay. As you can see, there is a fracture of the pars interarticularis of C2 caused about by hyperextension of the neck. So at this point, maybe we have helped you on how to evaluate your radiograph, cervical radiographs. Okay, so by in the future, you might be needing to evaluate yourself, because there are times where your radiologist, especially at night, will not be available, or your consultants would like you to tell them what you see on your radiographs. So with this lecture, we hope that we have helped you how to evaluate your cervical radiographs. How about cervical spine assessment with regards to the bony level and the neurologic level? So the bony level of injury refers to the specific vertebral level at which the bony damage has occurred. Okay. The neurologic level of injury describes the most caudal segment of the spinal cord that has normal sensory and motor function. So if your sensory is at the T4, your neurologic level of injury will be at T4. That means you have still sensation at level of T4 along the knee or at the nipple area. For the neurologic level of injury, you still have your sensory level and your motor level. So your sensory level is used when referring to the most caudal segment of the spinal cord with normal sensory function. So if your sensory is 100% at the level of the nipple area, then your sensory level will be at T4. The motor level is defined similarly with respect to the motor function as the lowest key muscle that has a MMT or muscle strength testing grade of at least 3 on a 6-point scale. Okay? So hindi ibig sabihin 0 yung manual, doesn't mean yung motor level nyo is 0 yung MMT niya. So the muscle strength at the level of the motor level should be at least 3. That is movement without gravity, I think. Yeah. Because 4 is movement with gravity. Now we go to the effects of spinal cord injury. We have the neurogenic shock or the spinal shock, but sometimes we oftentimes interchange these two. So a neurogenic shock is a cardiovascular phenomenon due to the loss of sympathetic tone, and this is associated with injury to the cervical or high thoracic spine, where your sympathetic trunk is located. This is manifested with hypotension and slow heart rate, as compared to hemorrhagic shock, which will give you hypotension and tachycardia. Treatment includes fluid resuscitation, occasional use of atropine and vasopressors. The spinal shock is defined as neurologic, and it is not a hemodynamic phenomenon. It occurs shortly after cord injury, and the duration is usually variable. It usually presents with flaccidity, and this is followed by spasticity. I give you the Primos-Cone spinal cord syndrome. You have the central cord syndrome, the anterior cord syndrome, and lastly, your Brown-Séquard syndrome. The central cord syndrome is characterized by a disproportionately greater loss of motor strength in the upper extremity than in the lower extremity. So, mas mahina yung upper kaysa sa lower. So, with varying degrees of sensory loss. This occurs usually with hyperextension injury in a patient with a pre-existing cervical canal stenosis, which is usually found in elderly. And the mechanism is commonly that of a forward fall resulting in a facial impact. This can also occur with or without cervical spine fracture or dislocation, and the prognosis for recovery in central cord syndrome is better than with other incomplete injuries. The anterior cord syndrome results from injury to the motor and the sensory pathways in the anterior part of the cord. Okay, so usually these are the caused by spondylolisthesis injury. These are characterized by paraplegia and bilateral loss of pain and temperature sensation. And this, among the spinal cord syndrome, this has the poorest prognosis of the incomplete injury and occurs most commonly following cord ischemia. Lastly is your Brown-Séquard syndrome, which results from a penetrating injury causing hemisection of your cord. This consists of ipsilateral motor loss, from the corticospinal tract and loss of position sense with associated contralateral loss of pain and temperature 1 or 2 levels below the level of injury. Even when the syndrome is caused by a direct penetrating injury to the cord, some recovery is usually achieved. So in summary, for the evaluation of the cervical spine, if you have a reliable, alert, awake patient with a GCS of 15 with no complaint of neck pain, neck tenderness, and distracting pain, then you do not have to do your 3 views. If your patient who is reliable, alert, awake, with GCS of 15 but complaining of neck pain or neck tenderness with distracting pain, then you have to get your 3 views. If your 3 views are normal, you should request for dynamic CT. And if your dynamic CT is abnormal, then refer to your neuroservice. In unreliable patients, you get the 2 views plus CT scan of the C1 or the C2 or any suspicious area of the cervical spine. If a patient who presents on the onset with neurologic deficit, then request for an MRI. I think that is my last slide, Lams.
Thank you very much, Sir Jay. Let us check the Q&A box for questions from our residents. Okay, mukhang wala pa silang mga katanungan. Very clear ang lecture ni Sir Jay. So, wala na pong questions sa chat box. Maybe later po, may mga tanong po sila, sir. We will just it later for everyone to answer.
I'll just monitor for questions for my lecture.
Sir, may pahabol. Ito na. From
Okay.
Dr. Taganas, good morning po. Regarding application of tourniquet po, how long should you maintain it in trauma cases occurred away from the medical facility? Is it advisable to release the tourniquet after a certain time? Thank you po.
Okay, as mentioned earlier, you can maintain that tourniquet for 2 hours. Okay, you do not need to release that tourniquet from time to time. Okay, just maintain it for 2 hours until a professional assessment of that tourniquet can be done. If you receive the tourniquet more than 6 hours or more than 2 hours, like for example, you receive that tourniquet already applied for more than 4 hours, then maintain that tourniquet, because if you suddenly release that tourniquet, you will be circulating free radicals in the systemic circulation, which may crash the patient. Okay, so they should be professionally assessed prior to release of that tourniquet. So 2 hours is no problem with maintaining the tourniquet for 2 hours.
Salamat po, Sir Jay. No more questions in the chat box. Thank you po for the 2 lectures, Sir Jay. We will get back to you if there are more questions po to be raised. Maraming salamat po.
Thank you. Thank you.
Now let's proceed to our next lecture for this morning. Just a time check. It's already 11 o'clock. We will just have some short changes po for this morning. The trauma radiology will be moved to 1:45 p.m. instead of this morning. Then the penetrating abdominal injuries will take the lecture for the 11:30 this morning until 12:15. We will have a very short lunch break so that we can start at exactly 1 o'clock later this afternoon. Now let's proceed now to our next lecture to be presented by Dr. Abesamis, Acute Burn Care, Initial Assessment and Management. Take it away, sir. Thank you.
Hi, everyone. I'm Dr. Gerald Abesamis, and I would like to thank the PCS Committee on Trauma and the Subcommittee on Burn for inviting me to discuss about the initial management and assessment of burn injuries, so also known as the acute burn care. So I have nothing to disclose. So for today, I'd like to discuss about, let's do a quick review of the primary survey, especially in burns, and knowing how to assess burn depth, estimating the burn size, reviewing the recommended fluid resuscitation, also doing a review of the secondary survey, and things we need to remember when doing our initial management. And lastly, discuss some criteria for burn center referral and transfer. So burn injuries are one of the most common injuries worldwide, and although majority of these injuries are minor, there remains a significant morbidity and mortality associated with moderate and major burns. Um, in fact, according to the WHO, annually about 180,000 deaths worldwide um, happen due to burn injuries, and the vast majority of which happen in the low to middle income countries, such as in the Philippines. And burn injuries also is a leading cause of morbidity, especially with scarring, contractures, amputations, prolonged hospitalizations, with about 11 million burn incidents happening annually. And burn injuries are, of course, preventable, especially when we are able to identify those most at risk, especially children, females, and males, especially in the working class. But the quality of care during the first hours after burn injury is actually very important. And it has a major impact on the long term outcomes. So, the initial management of a major burn could affect whether, a patient who have suffered from a severe or major burn would actually live and, survive. So therefore, it is very important, especially for us surgeons or future surgeons, that we are equipped with the proper knowledge and skills in managing severely burned patients, especially in the early hours after injury. And this is also the reason why we should be compelled to think fast and act fast during this time, because the pressure and responsibility of affecting the long-term outcome for these patients is actually just it's very high. So, similar to trauma patients, managing burn patients should always start with your primary survey or your ABCs. And promptly, you should do this in order for you to recognize and treat life and limb threatening injuries. Next, of course, you need to do a quick assessment of at least the burn depth and also the extent of the burn. This would give you at least the proper fluid requirements and allow you to estimate the fluid resuscitation needs of the patient. And once a patient is more stable, you may then proceed with the secondary survey, which allows you to get a more detailed information, which are important in the other steps of management. So you need to get the ample history, perform a head-to-toe exam, and also assess the tetanus prophylaxis status of the patient. And once done, you can proceed with the initial management by, inserting tubes, ordering tests, giving analgesia, performing appropriate wound care. And then once you're done with all these, you can then decide or determine whether the patient needs to be transferred to a burn center or wherein definitive care and surgery can be done. So let's look at an example. So let's say that you're the surgeon on duty at the ER, and then you've received a 44-year-old male, 2 hours post-injury, who suffered from flame burns. A typical history of a patient setting fire to a pile of dry leaves using paint thinner, and this, of course, caused a sudden explosion, causing burns to his chest, back, torso, and upper extremity. So, what will be your first step for this type of injury? So, again, the first step is always to identify and manage emergent conditions by performing your primary survey, which consists of, A, for airway and C, spine protection, B, breathing and ventilation, C, circulation, compartment hemorrhage control, D is for disability and deformity, E, exposure and environment control, and F, this is more particular in burns, F is for fluids. No? So um, I'd like to offer you some tips, especially for in performing primary survey in burn injuries, um, in burn patients. The primary survey should be done in at least 2 minutes, and this could be done by doing the primary survey as a team. So you can do simultaneous assessment. For example, one of the team members is checking. Well, one of the team members is checking the airway and breathing. Another one should be palpating for the peripheral pulses, while another one inserts, the IV lines for fluids. And another tip would be to perform this while talking to the patient, specifically asking him or her, paano ka nasunog, so that while the patient is narrating how he got actually burnt, then you're able to assess the airway and breathing at the same time, get information on the mechanism of injury. So we'll go through each component one by one. So for airway and C-spine management, we should always check and secure the airway by doing the chin lift and jaw thrust maneuver. And also, it is important to protect the cervical spine or the C-spine by an inline cervical immobilization in patients with associated trauma mechanism. We have patients in burns who, had, electrical injury in the who's fallen from the height of a second floor, or the roof of a building, and also patients who suffered from motor vehicular crash and had sustained severe burns or cutaneous burns. And also, a C-spine immobilization should be done in patients with altered mental status. So, in terms of airway, when in doubt, always consider intubation, especially for burns of more than 50% TBSA, due to the possibility of laryngeal edema down the line because of all the fluids that you'll be giving the patient. And also, of course, for patients with suspected inhalation injury, intubation is warranted. Inhalation injury should be suspected for any signs and symptoms of the following. So if you have a patient with burns to the face, who has sooty phlegm, singed nostril hairs, hoarseness or stridor, history of burn in an enclosed space, or found unconscious at scene, and those with circumferential chest burns. And the gold standard for diagnosis of inhalation burns is, of course, performing fiber optic bronchoscopy, such as, and finding, sooty phlegm or even just erythema on the airways. This confirms the diagnosis of inhalation injury. So next, B. So check for breathing and ventilation, and you can do this by performing chest auscultation and verifying if there is, equal breath sounds on each lung, and also assessing the rate and depth of breathing. So you should make sure that the airway flow is okay, and also that the patient is able to expand and expand the lungs appropriately. You should also start high flow oxygen, 100% oxygen, using a non-rebreather mask, especially for those with suspected inhalation injury. And also, all patients, especially for moderate to major burns, you should also provide a form of oxygen support, like via a nasal cannula or a face mask. And this should help also the patient's breathing. Circumferential full thickness burns to the trunk and neck may impair ventilation and must be closely monitored and assessed whether chest escharotomy or incisions on the full thickness burns should be done in order to release the possible chest compartment syndrome that the full thickness eschar is the non-elastic skin is affecting on the patient's chest. No? All right, so let's proceed with letter C. So check for, of course, the vital signs and the central and peripheral pulses of the patient. And one of the most reliable gauge or parameter of adequate circulation in assessing circulation is actually the adequacy of the patient's urine output. And you should also check, aside from the circulation, is actually check for signs of compartment syndrome. So compartment syndrome is fairly common in patients with circumferential, deep, and full thickness burns, and also those with suffering from high voltage electrical injuries. So any suspicion or patients with the six P's, pain, pallor, poikilothermia, and paralysis. No? So all these signs and symptoms should point to a possibility of a compartment syndrome, and immediate escharotomy or a fasciotomy should be done. Um, and also, for patients with concomitant trauma, we should also check for signs of hemorrhage. No? So especially those who figured, for example, in a vehicular crash who suffered from extensive burns. So for D, or disability, deformity, and deficits, we should definitely check for the patient's sensorium via the GCS, or a faster way of assessing the sensorium is by uh, assessing the sensorium via the AVPU score or scale, wherein you assess if the patient is awake, has response to verbal stimulus, or just response to pain, or if the patient is generally unresponsive. And any signs of decreased sensorium, you should check whether the patient has other injuries or conditions, such as carbon monoxide poisoning, substance abuse. Is the patient hypoxemic? So check the oxygen status of the patient. Or also if the patient has pre-existing medical conditions, such as diabetic ketoacidosis, or is the patient a post-stroke patient, or is the patient suffering from a stroke? Any other traumatic injury should also be ruled in or out during the letter D part, whether the patient has other concomitant fractures or lacerations in the patient's body. So exposure and environment. So we need to expose and completely undress the patient, and this would help stop the burning process. Another thing that you can do is in letter E is that you should be able to cool the burnt skin. So you can cool the burnt skin um, by running water on the patient's burnt skin. The recommendation is about 20 minutes of cool running water, and this is adequate first aid. And this can help for about the first 3 hours of injury. However, we should be also worry about hypothermia, especially for pediatric patients. So we should also ensure that the patient is warm, and we could provide like clean, dry blankets for the patient, and avoiding exposure of the burnt areas all at the same time. So we could expose the areas, one area at a time, in order for us to prevent hypothermia for the patient. So F is very special for in the primary survey in the burn patient, because F is fluid resuscitation, and you should secure patent large bore IV lines, at least 2 large bore IV lines on the patient, in order for you to start infusing your fluid resuscitation. And placing the IV lines it is recommended to place them on unburnt skin if possible, or as much as possible. And once you've already estimated the percent TBSA on exposure, and also estimated the weight of the patient, you can then start estimating the 24-hour fluid requirement by calculating for the Parkland formula, which is calculated at 4 ml times percent TBSA times the weight of the patient. And you give the first half in the first 8 hours from injury, and the second half in the remaining 16 hours from injury. And for children less than 16 years old, we should remember to add the maintenance fluid. However, there are instances wherein you need to start your IV fluids, but you haven't actually estimated the percent TBSA. What you can do is you can start just eyeballing, and you start the IV fluids by using plain LR. And if the patient is less than 5 years old, this is you can start the fluid rate by 125 ml per hour. If the patient is 16 to 13 years old, at 250 ml per hour. And if the patient is actually an adult, you can just start fast drip, about 500 ml per hour, and just recompute and readjust the fluid rate once you're in your secondary survey already. And this is a recommendation by the American Burn Association. So a very practical recommendation. And one of the skills you need to know after you've done the primary survey, one of the skills you need to know when dealing with burn patients is assessment of the burn depth. By determining the depth, you are able to estimate the burn size and fluid requirements, determining whether the patient needs surgery, and also knowing the prognosis and treatment course of the patient. So burns are generally classified to either first, second, or third degree burns, or more accurately, we can classify them into either partial thickness burns and full thickness burns. Now, so first degree or superficial burns, these are your typical sunburn, and this only involves your epidermal layer. So just the top layer of your skin, and the usual characteristic of a sunburn or a first degree burn would be dry, red. It's very painful because the nerve endings are exposed. That's why it's very painful to touch. And the thing that we should remember in first degree burns is that there should be no blistering. Once you have blistering, that is usually a second degree burn already. So once you have blisters forming on the wounds, on the area burnt, that means that the epidermis and part of the dermis has already been violated. So you have two major types of second degree burns. You have superficial partial thickness burns, also called your SPT burn, and also your deep partial thickness burns or DPT burns. These two can be easily identified, where in your SPT burns have a pink or red or moist wounds, such as the picture here. It is very tender to touch because of the exposed nerve endings, and also it blanches, or the capillary refill time is less than 2 seconds. In contrast, the deep partial thickness burns here, although there can also be blistering in this type of burn, the DPTs are usually pale pink to white, such as in the picture here. It's waxy, sometimes dry, slightly anesthetic. So when you touch it or when you palpate it, sometimes the patient cannot actually feel it already because part of the nerve endings have already been injured. And again, the DPTs usually do not blanch. So if it blanches, it slowly blanches, unlike your SPT, which is rapidly blanches. And the last classification is your full thickness burns, such as here in the photo here, which is characterized by your leathery burnt skin. It's waxy white, sometimes brown or black. It is very dry. It is inelastic. It's non-blanching. It is very anesthetic. And also you can sometimes see thrombosed vessels, which means that almost the full thickness of the skin has actually been injured, and you can already see the blood vessels here on the subdermal plexus, where already also part of the injury. And management of these wounds would generally depend on the depth. And in summary, superficial wounds can be managed with just wound care alone, including your SPTs, and they usually heal within 21 days. But Your deeper wounds, such as your DPTs, your full thickness, and even your fourth degree burns, these burns are usually surgical in nature, and they require some form of excision and grafting in order for us to treat and in order for us to close these wounds. And aside from assessing the depth, it is also important to estimate the burn size to assess the severity of the burn. So when estimating the size, again, you should only consider those with partial thickness and also full thickness burns. One of the most widely used methods of estimating the size of the uh, wound would be the rule of nines, also called the Williams rule. So this gives a rough estimate of the areas involved by dividing the body surface into areas of 9% or multiples of 9%, with the exception of that in the perineum, which is 1%. So I guess all of you are familiar with this. You know, you have 4.5% on the anterior face and 4.5% on the posterior head, 9%, 18% on the whole torso, and 18% on the back and including the gluteal areas, 9% on each upper limb, and 18% on each uh, lower extremity. No? So this is actually fairly accurate and reproducible in adults. However, it is not accurate, and it's found not to be accurate in children, this type of rule of nines. So that's why the ABA, or the American Burn Association, has actually prescribed a special pediatric rule of nines by allotting 18% on the head of the baby or the infant, and about 14% on each lower extremity. And this is because pediatric patients have a higher body surface area on the head, has a bigger head, and also has lower surface area on the each lower extremity. So a tool that burn units actually use to have a more accurate estimation of the burn size is the use of the Lund and Browder chart, which it accounts for the changes in the surface area of the child and also the adolescent, and this gives us a more accurate estimation of the percent TBSA. And another for patchy and irregularly shaped burns, we can also use the Palmar method, wherein the palm of the patient and not the examiner, again, the palm of the patient and not your palm, with the fingers adducted and extended, approximates about 1% TBSA. So estimation of the burn size is again very crucial because, as we know, aside from the local effects of the burn wounds, such as inflammation, edema, and ischemia, as the burn wound becomes more extensive and severe, there are systemic effects that come into play with progressive coagulation necrosis, and then there's release of vasoactive substances resulting in increased capillary permeability and vasodilation, and later on progressing into hypovolemic shock and decreased cardiac output and cellular shock. And this phenomenon is also known as burn shock. So therefore, severely burned patients actually require fluid resuscitation in order for us to restore that lost intravascular volume because of that systemic inflammatory response. So and also to preserve, tissue perfusion and minimize tissue ischemia. And according to the American Burn Association, ABLS course, resuscitation should be started in children who have more than 10% TBSA, and also in adults who have more than 20% TBSA. So they found out that in these more extensive burns, that is where fluid resuscitation actually needs to be started in order for us to prevent burn shock from happening. So One of the most widely used formulas, as discussed earlier, is the Parkland formula. And this was formulated by Baxter and Shires, actually in the Parkland Hospital in Texas in 1968. And as previously discussed, the usual computation of the formula is 4 times percent TBSA times weight. And the first half is given in the first 8 hours from injury, and the second half in the remaining 16 hours from injury. And this formula uses plain lactated ringer solution. So that's very important. No? So, however, for children less than 30 kilograms, we should, or usually less than 16 years old, we should consider starting maintenance fluid or adding the maintenance fluid by using a D5LR side drip. So a D5 containing or any D5 containing fluid by using the 4:2:1 rule, or also known as the Holiday-Seeger rule. So by adding the maintenance fluid, you can prevent having the patient suffering from hypoglycemia, because children actually is at great risk of developing hypoglycemia in a traumatic state because of their limited glycogen store. So that's why you need to add that D5 containing maintenance fluid. Okay, so although the Parkland formula is instrumental or was instrumental in decreasing the morbidity and mortality in severely burned patients because it has prevented, the onset of burn shock in the last decades, more recent evidence has actually shown that it actually overestimates or sometimes overestimates the fluid requirements needed for resuscitation, thus having a risk of over-resuscitation. So, in fact, some recent recommendations by the American Burn Association through its advanced burn life support course in 2018, they have adjusted the fluid rates already by with the following. No? So if the patient has flame or scald burns in an adult or more than 14 years old, they just recommend using 2 ml of lactated ringers times the percent kilogram multiplied by the percent TBSA, and this gives you the 24-hour fluid requirement of the patient. For children, it's 3. For infants and young children or less than 30 kilograms, it's 3 plus the D5LR maintenance fluid as discussed earlier. However, for those with electrical injuries, they still maintain it at 4 ml per kilogram per percent TBSA, and also adding the D5LR maintenance for very young children or infants. Again, the reason for having a higher fluid rate for electrical injury patients is because this is to account for the deep tissue injury that can happen in electrical injury patients that are unaccounted for by its cutaneous burns. No? So sometimes the patients with electrical injury can have deep tissue injury that are not commensurate to the percent of to the cutaneous burns that the patient has. So, as emphasized as well in the ABLS course, fluid estimation is just a guide and it's just an estimate. So it should not be absolute. And a good rule of thumb is to actually have a range. So you can have a range from about 2 to 4 ml of plain LR times percent TBSA times multiplied by the weight of the patient. And this would give you the first 24 hours estimate for the patient, and just determine the factor according to your own patient's condition. So again, if you have not as major burn, you can just put it at 2. But if you have a larger burn or or a more serious burn or a patient that requires more fluids, then you can compute it at 4 ml per kilo per percent TBSA. The aim, the focus more should be at aiming the resuscitation at urine output that is adequate. So for adults, it is expected to have you're expected to have more than zero point 0.5 ml per kilo per hour of urine output. And for pediatric patients, it's more than 1 ml per kilo per hour. And you should titrate the fluids accordingly, and this should be done every hour. And you should either increase or decrease the fluid rate according to the hourly urine output. Again, the adjustments to fluid rates are based on the patient's response. So once you compute the formula or the estimate in 24 hours, you should not stick to that calculation, and you should titrate the fluids accordingly once you've assessed the patient's response to the fluids already. Okay, so again, I cannot overemphasize this enough. No, so fluid calculations are not absolute. UO monitoring should be done strictly at Q1. And if the UO is inadequate, you can give boluses of 5 to 10 ml per kilo or increase the total fluid rate to 150% of the planned rate for that hour and reassess after the following hour. If the UO is adequate, you can then start decreasing the fluid rate by about 20 to 25% every 1 to 2 hours and check always the response of the patient. So you should titrate the fluids according, again, to the urine output of the patient. In addition to the formulas stated, no, so we should also keep in mind that there are certain populations that may require additional fluids or those that will need careful hydration. Some patients, including those with a delayed start of fluid resuscitation, prior dehydration, chronic or acute alcohol use or abuse, methamphetamine uh, methamphetamine lab injuries or high voltage electrical injuries or inhalation injuries may require more than the estimated fluids. And also there are conditions that will need to be where you need to be careful in overhydrating these patients, such as cardiac patients and infants. No, so where we can just decrease the factor to about 1 to 2. So in summary, although it is very important that we want to avoid under-resuscitation, resulting in depletion of the intravascular volume and ischemia, resulting in ultimately in burn shock, we also want to avoid over-resuscitation because this can also cause significant morbidity and mortality, such as pulmonary congestion, developing compartment syndrome, and faster formation of tissue edema. Therefore, the goal of fluid resuscitation is actually to achieve that ideal balance between the two. And other pointers for fluid resuscitation include when you have minor burns, you can just increase the oral fluid intake. However, for moderate to major burns of more than 20% TBSA, an IV route of resuscitation should be done. And the fluid resuscitation should start as soon as possible in the ER, even before other diagnostic exams are done and facilitated. And you should start fluids prior to transfer, especially if you are transferring to a burn center, because we need to prevent burn shock from happening, because this is a significant cause of mortality, especially in the first 48 hours of burn injury. So once you're done with the primary survey and fluid resuscitation, you can now proceed with the secondary survey. So secondary survey, same with the trauma patient. You can do an ample history of knowing the allergies, medications, previous illnesses, last meal, and events surrounding the injury. And most importantly, in burn, you need to know the tetanus and childhood immunization of the patient, because you need to institute a tetanus prophylaxis for all burn patients. No? And another component of your secondary survey is performing a head-to-toe exam, where you do a comprehensive and complete physical exam, and where you also document the other injuries such as lacerations, abrasions, or if there are any penetrating or blunt trauma, and also doing a complete neurologic exam. Some principles that we need that can guide us when doing initial management for burns of more than 20% TBSA or major burns. No? We need to readjust fluid resuscitation accordingly, as previously discussed. Dressing or covering the wounds appropriately. Keeping the patient dry and thermoregulated, monitoring the VS hourly, inserting an NGT, which can provide gastric decompression and also facilitate early enteral feeding once the patient is more stable. Insert a urinary catheter um, to monitor the urine output hourly. Monitor the extremity perfusion, check for the development of compartment syndrome, monitor ventilation as well, provide adequate pain and anxiety control, elevation of the head and extremity, and eventually you'll need to provide psychosocial assessment and support. So some initial laboratories or routine laboratories for burns would be the following, CBC, serum electrolytes, BUN creatinine, glucose level, especially for children and diabetics, urinalysis, and performing a routine chest x-ray for all patients. And now in the time of pandemic, of course, a routine COVID-19 swab would be warranted, especially if the patient is for admission. Other special tests would be ABG with carboxyhemoglobin, especially for inhalation injury suspects, a 12-lead ECG for all electrical injury patients to check for any cardiac abnormalities and arrhythmias, urinalysis with urine myoglobin for all electrical injury patients to check for the presence of rhabdomyolysis, and for surgical patients, of course, blood typing and PT-PTT, just to check for any blood dyscrasias or coagulopathies. In order for us to guide us with classifying the severity of the burn injuries and deciding on the disposition of the patients, the American Burn Association actually gives us this classification. No? You can classify the burn injuries to either minor, moderate, or major. No? For minor injuries, these can actually be safely managed in an outpatient basis. However, for moderate or major burns, these are indications already for admission. Especially for major burns, the criteria here actually points towards transferring the patient to a specialized burn center, because this is where the patient can actually receive specialized and complete care for to treat and manage the burn injuries. To treat and manage burn injuries. So the ABA has actually prepared this burn center referral criteria to guide us, to guide everyone when to refer a patient to a burn center. So any patient who has partial thickness or second-degree burns of more than 10% TBSA, any full thickness or presence of any full thickness third-degree burns in any age group, burns that involve the primary areas or areas where any a compromise to these areas would result in debilitating functional problems such as face, hands, feet, the genitalia, perineum, or major joints. Those burn patients who suffers from electrical, chemical, and inhalation injury. Those with pre-existing medical disorders. Those with concomitant trauma. Burnt children in a hospital without qualified personnel or not qualified to take care of pediatric patients, and also burn patients who require special social, emotional, or rehabilitative interventions. So at this age, especially during the pandemic, when you want to transfer patients to a burn center, please kindly coordinate to the receiving hospital. No, so we do not want, or we want to prevent patients from hopping from one hospital to another. So in summary, burn patients are actually should be treated the same way as trauma patients. So a primary survey should be done. Airway, breathing, circulation, check for the neurological disability, perform an exposure, and also start your fluid resuscitation, and then go back and reevaluate everything again. And then perform your secondary survey, your ample plus your tetanus prophylaxis, perform a complete head-to-toe examination, add appropriate wound dressings, keep the patient dry and thermoregulated, perform adequate pain control, check the tetanus prophylaxis, insert tubes and monitoring, classify the burn injury to either minor, moderate, or major. And this would guide you to deciding whether the patient needs an admission or a transfer to a burn center. So with that, I thank you for your kind attention, and I'd be glad to answer any questions that you may have. Thank you.
Thank you very much, Je, for that updated and very comprehensive but short lecture on burn. Actually, for everyone who's attending, this is the first time, right, that we are launching that burn module as part of your best workshop. So, for the residents, medyo marami kang questions, Je.
Yes,
Lubos-lubos na ang pagtanong kay
Okay, no
Je
problem.
because most of the questions in your PBS will be coming from his lecture. So let's start off with the first question. Good morning, sir. Regarding the Parkland formula, are we going to use 4 ml or the revised formula using the 2 ml kilogram TBSA?
So I think it because the Parkland formula is most widely used formula, you can start by using that 4 ml per kilo per percent TBSA. But as long as you know that when using and calculating for the Parkland formula, that you'll be able to adjust your fluids accordingly after you've calculated. You don't need to stick to that 4 ml per kilo per percent TBSA. You can just adjust it and down titrate your fluids if the patient's actual urine output is responding not to your fluids. However, again, for the more updated recommendation from the ABLS, it's now pegged at 2, or it's just half of what was actually been prescribed before. So again, we cannot say like a definitive like recommendation to just use 2 or use 4. What I personally would do is I would assess what the patient would actually really need. If the patient has like a delayed presentation to your institution, then you can probably just go for 4 because that will give you a more intensive fluid resuscitation. But if you've received the patient early enough and you think that that the fluid is actually that the patient responding to the fluid resuscitation, then you can complete it at 2. So I think that's what we can do.
Okay, so I guess Sir Jeff's explanation is clear enough. Jeff, for the exam, what will they use?
For the
Ano
exam,
po?
I think they can use 4 at least. So that's
Okay.
the most that's a widely used Parkland formula. So any modification is really a clinical judgment, I think.
Okay, thank you. So residents, I guess that's clear. So we can still use the 4 ml per kilo in the exam, but when you apply it to your patients, you have to assess also clinically if your patient is responding to your fluid resuscitation. Next question is it prudent to do early fasciotomy in patients with high voltage electrical injury involving the limbs?
I think the call for doing an early fasciotomy is really a clinical judgment. If the patient presents with like full thickness circumferential burns or even high voltage electrical injury, but has the early signs of compartment syndrome, then an early fasciotomy for these patients is really, of course, warranted in order for us to save the limb. So it really depends on the clinical situation, and it's a judgment call. If you are not sure, can call the nearest like burn center in order for you to guide you in terms of decision making whether the patient warrants an early fasciotomy or not. No, so I think it's more of a clinical judgment. It depends on the picture of the patient.
Okay, thank you, Dre. Next question. Good day po, Dr. Abisami. Sikat ka na dyan. Regarding the Parkland and use of LR or lactated ringers in cases of burn patients but with AKI, or they have hyperkalemia secondary to AKI because they have CKD. So ano na to, burn with comorbidities, particularly CKD. Can we still safely use LR, or is there an alternative, or how do we start our fluid resuscitation for AKI patients or CKD patients?
Yeah, I think it is still safe to use plain lactated ringers for these patients, but we need at least guidance from the renal service, at least to monitor the status of the kidney, especially for patients with chronic kidney disease, because these patients might need hemoperfusion or hemodialysis at a later point in time. So the most important here is that we are able to adequately resuscitate and get that intravascular volume in place so that we'll be able to preserve more tissue perfusion in other areas of the body. So it's just I think maybe a careful hydration would be good for this patient.
Okay, so the next question is related to that, the risk of congestion, balancing your aggressive hydration versus congestion.
Yeah, so so I think I've said it in the lecture that if you are wary of overhydrating, especially for patients like with a cardiac disease or those like with CKD, you can do a careful hydration by just computing it at 1 to 2 ml per kilo per hour. Then you just adjust it accordingly. Although of course CKD patients they have poor urine output and their kidneys are not functioning well. You can also have other parameters to guide you in terms of your resuscitation, such as the use of your either CBC or your ABGs, so and also some other parameters like of course your vital signs, if the patient is responding to your fluid hydration.
Okay, thank you very much for that, Jess. So careful hydration and ask help from your renal partners, renal service nephrologists to help you when you're dealing already with congestion. But it's not an excuse, right, Jet, na hindi sila i-resuscitate just because you have renal problems. Next is, good morning, sir. Ito, very controversial. Is there a role for colloids in resuscitating your acute burn injury patients? Probably siguro to decrease the
amount of fluid.
Colloids. Yeah, so
right.
Go
so I think it is very controversial. There are two schools of thought. There are institutions that use colloid in the acute setting, but the more recent evidence actually still points towards the use of colloids for at least 12 hours after injury, because again, the first 12 hours after injury, that's where you get the leaky capillaries. No? So when you start colloids at this point in time, the colloids would just extravasate and would leak through from the vessels. No? So that's when you can start maybe thinking of adding colloids is at least around at the 12-hour mark, and this should be it should be a team decision, and also in a consultation with either your surgical intensivist and also your nephrology and colleagues as well, because this would the fluid computation that you've previously computed would actually be not usable at this point in time. So again, it will be your the response or the physiologic response of the patient that would dictate your fluid rates at this point in time when you start putting or introducing colloids.
Okay, so medyo controversial pa din, and you need a lot of help, a clinical judgment from other specialties, whether to start it or not. But at least you know that it can be part of your burn resuscitation armamentarium, provided that you understand the conditions that our speaker mentioned. During this time of pandemic, what hospitals po are the burn centers so they can probably refer?
Okay, so I think nationally, I think we have around 6 burn centers or burn units. Of course, in Metro Manila, we have 5. PGH is one, and PGH is actually handles COVID positive patients because PGH is a burn center. It's a COVID referral center. Other non-COVID referral centers who can handle burns are, of course, Jose Reyes Quirino, Jose Reyes Quirino East Avenue, and then Tondo Medical Center also has a burn center. In the north, I think Medical City Clark has a burn unit, and in the south, it's Davao. In Southern Philippines Medical Center in Davao has a burn center there as well. So all the other areas, I think as long as there's either a practicing burn surgeon or a plastic surgeon in the hospital, can also receive patients with at least moderate burns. But of course, for major burns, it's best to be transferred to a burn center or burn unit capable hospital.
Okay, so let's answer all the questions, Jeha, kasi first
Sure.
time SOP, the residents are excited. So from Sonaira, she's our incoming trauma and critical care fellow from May Pakpak. Ayan.
Wow.
What if the patient arrived 7 hours post-injury? How do you give the first half of the fluids based on Parkland, especially in children?
So I think we still need to give you just give your fluids like a fast drip. You just try to catch up with the fluid deficit that the patient has, and again just reassess. And after an hour, after 2 hours, you can just reassess and see whether you need to give all the fluids that you've calculated, or whether you can start down titrating or do careful hydration. But the most important thing here is that at least in the back of your mind, you're able to calculate what the actual fluid deficit is in 24 hours, and you try and see whether you'll be able to give the whole 24-hour fluid requirement in 24 hours, or just try and decrease according to the patient's response.
Okay, so medyo, I think, very challenging to do burn resuscitation for
Yes.
all the age groups. But again, sabi nga ni Jay, you have to have like that ballpark figure of the fluids na kailangan habulin in, then always reassess. So next is, good morning, regarding pain control in the OPD setting. What is the appropriate pain meds for our patients?
So usually for outpatient, kung if these patients have minor burns, the most common would be the use of paracetamol and sometimes NSAIDs. No? So ibuprofen or mefenamic acid can be given. So for pediatric patients, it's usually paracetamol and ibuprofen. But for adult patients, you can use any NSAIDs. You can also use mild opioids like tramadol for adult patients in the outpatient setting. So in the inpatient setting, those with moderate to major burns, of course, the use of opioid is the first line usually. So you can start with a mild opioid with tramadol, but most of the time they would require an IV morphine because of the significant pain that they would experience because of the burn.
Okay, thank you, Jess. So, wag magtipid sa burn pain medications. Next is, if you have a patient with greater than 50% TBSA, is it wise to start your nutritional support like your TPN?
I think it's better to start your enteral support as soon as possible. Do not go straight to TPN. So only we preserve the use of TPN if the patient's gut system is actually not functioning. So, for example, for multiply injured patients who has like an abdominal trauma as well, then that's a time that you can probably use the TPN. But most of the time, burn patients have an intact gut, so an enteral nutritional support is needed, and you can actually start this at 12 hours post-injury when the patient is already in the, for example, in the ICU. You can start doing your nutritional support at this time.
Okay, sir, when do we start the resuscitation, the computation from the time of injury or from the time when you see the patient?
From the time of injury. So please, let's emphasize this point. No, so it's from the time of injury. That's why you need to know the history of the patient, especially the time when the patient got burnt, because that is when you compute at least. Because the reason again for providing your fluid resuscitation is you want to maintain that intravascular volume because of that systemic inflammatory response. So that systemic inflammatory response happens from the time of injury. So that's why you need to map out and make sure that the fluids are actually inside that blood vessel. That's why you need to bombard the patient with that enough fluid.
Okay, so this is related to that, Je. The patient arrived 3 hours late. Do we give the first half of resuscitation in the remaining 5 hours since the injury, or do we still give it for 8 hours?
Yes, correct. So the usual thing that we do, especially for example in PGH, is that we compute the deficit. So that deficit of 3 hours, what the 3 hours is, we just run it at full blast, at full fast drip. Then once we compute the remaining like 5 hours, that's when we compute what the fluid rate is. So again, in ordering for the fluid rate, you do not order for the fluid rate for the next 24 hours. You're just ordering for the fluid rate, for example, for the next 1 to 2 hours, and then you need to readjust it accordingly after, depending on the urine output of the patient. So, for example, if your fluid rate that you've computed is around 350 cc per hour, then you need to readjust that according to the fluid rate of to the urine output of the patient. So, but again, that at least you know that in the first 8 hours, or at least in the remaining 5 hours, you need to give this amount of fluid at the back of your mind.
Next, how early post-injury, sir, can we start beta blockers or control the heart rate of the burn patients?
Right. So it's very common for acute burn patients to have that hypermetabolic response, especially in the first 24 to 48 hours. I think the safest that we can give this is in about the 48-hour mark, or at least 2 days after, when you see that there's persistent tachycardia, even if you've assessed the patient to have very good fluid resuscitation already. And that's the time then when you can probably say that maybe this is not just the dehydration of the patient, but probably another an effect of the systemic inflammatory response of the patient. So so I think that the safest time is to give it at 2 days after.
Okay. Our CVP lines, do you recommend them still, Je, for extensive burns?
Yeah, so central lines are good adjuncts to it's an access port, and it's a safe port for these patients. The only thing we should be worried about when inserting central lines on burn patients is that avoiding the insertion of these lines on burnt skin, because that would of course increase the risk of having central line associated bloodstream infection. So as long as it's in an area that's unburnt and it's safe, the use of central line, especially for severely burned patients, is a good adjunct.
Okay, thank you, Je. Last 5 questions, and the rest of your questions will be answered by Je in the chat box.
Yes.
But I guess talagang nawili sila, Je, sa burn. Your experience daw po with colloid dressing.
Okay, so colloid dressing, I think this is like hydrocolloid dressing. So this is very good in like superficial partial thickness burns or second degree burns. We usually use it as long as there are no signs of any infection. So for in the acute setting, because most of the burn wounds are actually um, sterile naman. So you can use these colloid dressings, especially for minor burns. But for moderate and major burns, because of the risk of these patients to um, uh, develop um, burn wound infections, it's recommended to use at least antimicrobial dressings for these patients to prevent any development of burn wound infection. So colloid dressings alone without any antimicrobial is only recommended for minor burns with just superficial partial.
Okay, next is what's the recommendation for patients complaining of pruritus due to their burn injury?
Right. So it's a fairly common concern of patients, especially once the wounds are actually epithelializing or healing already. So we can give some like cetirizine or loratadine to control to help control the pruritus. Sometimes by just giving a small like pain medication like paracetamol can also help with these patients. But most of the time, aside from these oral medications, you can also apply topical agents because most of the time the reason why it's actually very itchy is because the wounds are drying or it's very dry. So you need to moisturize these wounds with like an emollient like petroleum jelly, or you can also use like moisturizing lotions, that are hypoallergenic that wouldn't cause any reaction to these sensitive areas.
Okay, last two before Jet will answer your questions na lang po sa chat box in the interest of time. But I can understand no, your interest ninyo sa burn kasi yun nga yung
First
launching of
time.
this burn module. And we have very short, limited, konti lang talaga kayong plastics and burn, Jenna, in the Philippines. So talagang konti lang yung mapagtanungan siguro nila. So what is the usual timeline for appearance of ARDS and Curling's ulcer in severe burns? And antibiotic coverage, do you give it routinely? And why? And when do we do the culture insensitivity if we need to add more antibiotics?
Okay, madaming questions yan. So
Uh,
first siguro ARDS, it's usually associated with pneumonia, and usually this happens if the patient is actually either intubated or has ventilator associated pneumonia and then develops ARDS, so usually it's late at the stage. No, it doesn't happen in the early stages of injury. So usually at around day 5 to day 7. For Curling's ulcer, it can happen anytime. Again, Curling's ulcer is part of the gastric ulcers that happen because of the inflammatory response of the patient. No? And it's very common if there are no prophylaxis for these given. So we usually give our proton pump inhibitors to prevent Curling's ulcer from happening, but it can usually happen acutely and also even at a later stage in time. Antibiotic coverage, I would like to emphasize that antibiotics or systemic antibiotics is not indicated in any burn patient, except there are exceptions. So except for the very young, so less than 2 years old, you can give prophylactic antibiotics or systemic antibiotics to prevent any happening or to prevent like invasive wound infections such as toxic shock syndrome or the predominance of your staph aureus in the body. So those for the very young, for the elderly as well, prophylactic antibiotics are given. Third is those with who will undergo a surgical intervention. So, or example, the patient undergoes escharotomy or fasciotomy or a bronchoscopy. So, a prophylactic antibiotic should be given. And fourth, those with infections already from the community, for those with community acquired pneumonia or those with an infection already in the skin, then of course you need to get the antibiotic started. And lastly, those immunocompromised patients, so those with diabetes, those with chronic steroid use, these need your prophylactic antibiotics. So okay, aside from the prophylactic systemic antibiotics, what you need to start are antimicrobial dressings, because this would give that coverage for the burn wounds. Because for the first 24 to 48 hours, those burn wounds are actually sterile. When you dress it, it's actually sterile unless you've just left it open for the last like 5 to 10 hours, na walang dressing at all. So if you've received this patient in the acute setting within like 3 to 4 hours, these burns are actually sterile. So you should keep it sterile and you should keep it free from infection by applying these antimicrobial dressings.
Okay, second to the last, Je. And then you can probably drink your water.
Okay.
Sorry, ang dami talaga. Is plasmapheresis useful or is there a role for it in major burns?
Plasma, we haven't had any experience in the use of plasmapheresis, and I'm actually not familiar with its use and how it's used in burn patients.
Probably since ginagamit siya sa COVID to clean your blood of cytokines. But I don't think hindi siya ginagamit sa burn. It's an interesting idea.
Pwede nga siguro. Because of that systemic inflammatory.
The cytokine storm. Anyway, last question, Je, before you get to answer the questions on the chat box and then be live. What's in your practice, what is the most common cause of death in burn patients? So is it pulmonary or burn wound sepsis?
Okay, so currently, because we have increased, the education about resuscitation already, it's mostly because of it's not the burn shock already that's the most common now. It's actually the sepsis, so it's the wound infections, it's the pulmonary complications like pneumonia concomitant to like being intubated for a prolonged period of time. So it's mostly the infections that are causing that problem. Although there are still some patients, especially those being transferred to, for example, in PGH, who are transferred in a delayed manner, haven't had any fluid resuscitation for the last like 5 to 10 hours. Then we get these patients at the late time, and then it's too late to pull them out from burn shock. So.
Okay, thank you, Je. Probably the Mibo question, you can answer na lang po sa chat box in the interest of time. So for the residents who really wanted to ask questions but hindi po namin napagbigyan, there will be another best for us a review for your incoming PBS exams as well. And nandun din si Je for the burn module. So you just write down your questions and then tatanungin natin live in your next burn or best workshop. So probably, Je, the Mibo question. Sorry, sir.
Okay.
We'll answer the chat box. Okay, so thank you very much,
everyone,
Je, for your box office lecture with your box office questions.
Okay, thanks, ma'am.
So let's go on to our next lecturer. Sorry, it took us quite a while to answer all the burn questions. So we had changes in the schedule because of the availability of some of our speakers. So the next lecturer here na po, Dr. Wico.
Hello.
Okay, so our next topic will be the blunt and
Penetrating muna.
Yeah.
Penetrating
Okay.
muna.
Okay, so sir, we'll start with penetrating, followed by blunt abdominal injuries, and then after that, that's the time we will entertain your questions para dire-diretso na muna tayo. Okay, so are you ready po, sir, Dr. Rico?
Okay.
Okay, so thank you, sir. So I'll give the floor to Dr. Rico to discuss the penetrating, followed by the blunt abdominal injury, and then your questions. Thank you very much.
Okay na i-rin yung slides?
We can see it na po, sir.
Thank you.
We start po.
Okay, good morning. I will be discussing the penetrating abdominal injury. Now, the approach to patients with penetrating abdominal trauma depends on whether the injury is a gunshot wound or a stab wound that have penetrated the peritoneum or the abdominal cavity. As we all know, that gunshot wounds are associated with high incidence of intra-abdominal injuries, and nearly always mandate surgery or laparotomy. On the other hand, when you talk about stab wounds, in general, they are associated with significant lower incidence of intra-abdominal injuries, but still has the same effect. It can also penetrate the abdominal cavity. Therefore, in patients with stab wounds, a number of them can have this expected management, and that's usually indicated in patients that are hemodynamically stable. Now, many protocols have been developed for the determination of abdominal wall penetration of stab wounds to the torso. So, many imaging modalities can be used in the evaluation of a patient with penetrating abdominal trauma. And the imaging needs of each patient, the imaging needs of each differ from patient to patient, depending on the presentation, the clinical presentation, depending on the hemodynamic stability and associated injuries. Therefore, our objectives for today is to just interpret, as junior residents that will be manning the emergency room, interpret abdominal physical findings in penetrating abdominal injury, and we try to understand and apply the different diagnostic modalities used in penetrating injury to the abdomen. I will understand that there are protocols that have been developed in terms of in your institution. So we will be discussing a number of diagnostic modalities used in this particular situation. So we start with a case. A 30-year-old male came in 8 hours post-injury after sustaining multiple stab wounds in the abdomen. So at the emergency room, the vital signs are as follows: 100/70 millimeters mercury, a heart rate of 98 per minute, an RR of 18. The patient has pink palpebral conjunctiva, clear breath sounds, and distinct heart sounds. Now, looking at the physical examination of this patient, the patient has multiple stab wounds in the epigastric area, in the left lower quadrant area, and in the right lumbar area. Now, there is direct tenderness on the epigastric area, and there is no rebound nor guarding. So rectal exam is a negative for blood. There is also no gross hematuria. So if we're going to look at the physical examination during the secondary survey, when we talk about secondary survey, this is a complete head-to-toe physical examination in a hemodynamically stable patient. And this will include external inspection respect to the what we call anatomical landmarks. Initial assessment was mentioned earlier, that looking for abdominal evaluation in terms of tympani, percussion, balance of percussion, bowel sounds, and distensions, and digital rectal and also genitourinary evaluation is warranted. Of course, if patients with life-threatening injuries or hemodynamic instability, this secondary survey may be delayed for operative therapy. So, if we think this patient's abdomen, do you want to answer this? No? I want you to answer this pala. That, what is your interpretation of the abdomen of this patient? Is it surgical, non-surgical, or equivocal? So the question is, if the patient's abdominal tenderness, is it coming from the wound or inside the abdomen? So we still don't know at this point, because if this is a equivocal abdomen, meaning there are areas of tenderness and there are areas in the abdomen that is soft and non-tender. So there is a discrepancy between whether or not you're going to operate in this patient. So serial physical examination of the abdomen requires, for the same examiner, I'd like to emphasize the same examiner, to examine the abdomen every half an hour for about 2 to 3 hours. With this, if there is, let's say, areas of tenderness that increases in size, or if there is tenderness away from the stab site or the injured site of the abdomen, if there is diffuse abdominal tenderness or a florid peritoneal signs, these are already signs that this is surgical abdomen, that we may need to bring this patient to the operating room. But what if this patient's abdomen still remains equivocal? So you have a number of armamentarium to prove that there is penetration in abdominal cavity. One armamentarium that you can perform is a local wound exploration. However, if we're going to perform a wound exploration, it should be a single, anteriorly located, infraumbilical location of the wound. Because if we're going to perform a wound exploration above the umbilicus, we might be entering another cavity, like the thoracic cavity. And also, instruments like ice-pick are more difficult to explore. So, like gunshot wounds and thin instruments like the ice-pick may be considered intraperitoneal injuries. Now, for DPL, for diagnostic peritoneal lavage, in a hemodynamically stable patient with penetrating abdominal injury, DPL can be used to identify hollow viscous. While it is very sensitive and specific, this procedure requires a fair amount of time to perform, and this has already been supplanted. This procedure has been supplanted by in many institutions, just in our institution also, protocols using the focused abdominal sonography in trauma, or CT scan, or even laparoscopy. Now, the primary disadvantage of diagnostic of this procedure is its invasiveness and its inability to evaluate the retroperitoneum. It has a moderate specificity for therapeutic laparotomy and has a significant false positive rate. Now, the caveat here is that the lower the, in patients that have, let's say, if you want to perform a diagnostic peritoneal lavage, there are, depending on the mechanism of injury, the red blood cell count greater than 100,000 or white blood cell count of 100 to 500 millimeters cube count, 500 count, may be considered a positive in a stab wound. However, kapag you consider diaphragmatic injury, some physicians will lower this value of a positive test to about 5,000 RBC count. So if this is gunshot wound, if this is gunshot wound, we know that the serious nature of gunshot wounds. The clinicians always often use a lower value for a positive test if there is concern of a projectile that has entered the peritoneal cavity. So the caveat here is that in DPL, if you lower the threshold for positivity, the more sensitive will be the test. And the more sensitive will be the test, there will be a probability of higher rate of non-therapeutic laparotomy. So that is the DPL. Now for performing laparoscopy, laparoscopy is effective, and we're doing this in our institution to evaluate and treatment ng patients that are, first of all, hemodynamically stable. It actually reduces the number of non-therapeutic laparotomies performed. For thoracoabdominal, which is yung mga wounds higher up, laparoscopy aids in the diagnosis of diaphragmatic injury and other intra-abdominal injuries as well. So if you see, let's say, diaphragmatic injuries, you may actually perform, if you have ruled out, if there is, we always do a explore lap, if there is proven penetration, even with laparoscopy. But other institutions probably will do a therapeutic laparoscopy for this kind of injury. But again, in my opinion, at least in my opinion, is that when there is proven penetration, the protocol of our section is to explore the abdomen. We all know that when you do an outright explore laparotomy, hindi mo na work up mabuti. So when you open these patients, usually it has a higher rate of non-therapeutic laparotomy rate, about 80%. So you have to look at clinical signs and diagnostic imaging to help you decide whether there is proven penetration or not. And the last will be ultrasound. The ultrasound, well, later I will be talking on blunt. This is by the use. This has been widely used in the assessment of patients with blunt trauma. But it has its use in the assessment of patients with penetrating injuries. So while FAST has been found to be 94, about 98% specific for abdominal injury in penetrating abdominal trauma, yung sensitivity niya is mababa, or up to about 60%, 60%, 67%. That is a positive FAST. So meaning, if you have a positive FAST, and there is a equivocal abdomen, and you did your FAST, if it's positive, result, positive FAST result in the setting of penetrating trauma, is usually an indication for laparotomy due to a high positive predictive value for a therapeutic laparotomy. So when you open it, there is something that you have to repair or to address when it is positive. Unfortunately, if it is negative, it doesn't mean anything. It cannot rule out the need for laparotomy, and it cannot be relied on if it's a negative FAST. So you cannot rely on to exclude important intraperitoneal injury. So these patients may require further testing, further monitoring to rule out some injuries of the abdomen. So while doing one of the procedures, especially in the emergency room, the patient's BP went down to 80/60. So I would like you to answer this now. How are you going to resuscitate? And I think our earlier speakers mentioned about resuscitated fluid. You would resuscitate by transfusing pack RBC, transfusing with fresh whole blood. This was also mentioned, giving colloids while waiting for blood. And how about giving boluses of crystalloids? What do you think? So in general, I'll be just giving a general statement, for this. When we infuse, if we talk about shock, the infusion of greater than 1.5 liters of crystalloid has been shown to be associated with increased mortality in trauma. But that's the reason why the early use of blood products is advocated. And there is no place for infusion of large volumes of crystalloid fluid in trauma patients. So massive transfusion should be utilized if needed. And we define massive transfusion we defined it as a transfusion of more than 10 units of blood in 24 hours or more than 4 units of blood in 1 hour. So early resuscitation with blood and blood products in low ratios, 1:1:1, is recommended in patients with evidence of class 3 and class 4 shock. So just to give you some additional information regarding shock, there is a result following the results of several important trials, including the landmark, the one that is in CRUSH-2. In CRUSH-2 study, tranexamic acid is now recommended within 3 hours at a loading dose of 1 gram IV over 10 minutes, followed by 1 gram infused over 8 hours. So in some areas, tranexamic acid actually is also being used in the hospital setting. So after resuscitation, I think this will be the last slide. After resuscitation, blood pressure rose to 100/80 with a heart rate of 115 per minute. So these are the choices that you need to answer. And proceed with laparotomy, continue resuscitation and wait for blood, continue further observation, or proceed with further diagnostic workup. Paano ba nilang sasagutin to, Irene?
Bro, you can call the volunteer
You can call volunteer.
or ask the moderator to call one for you.
Irene, can you kindly call somebody to, sana mas maganda if they can, this should be kasi this should be sana interactive so that they can answer. Sana yung unang mga earlier questions be answered by the residents also. But anyway, we are already here. We'd like to ask the audience, what will be your plan when you have this kind of situation? Blood pressure, initially hypotensive, you resuscitated, probably with blood products. And then, of course, before we continue, I'd just like to mention there was also mention about colloids. There is actually evidence that colloids and plasma, there's evidence against its use. And because of the development of renal failure and worsening outcomes. So that's the reason why I think that was mentioned by the early speaker, that the protocol should be performed. Now we have to look at the data to come up with a protocol so that the recommendations of this protocol will give the best outcome for our patients. So I think that's my suggestion in giving the colloids. So anyone can answer this? If none,
Sir,
Walang
we are answering po sa chat box.
Sorry, hindi ko nakikita eh. Wait ah. Letter A.
Opo.
Yeah, that's correct. So why letter A? Can anyone answer that? Why did you choose proceed? Nag-improve naman yung kanyang blood pressure. Why don't we just continue resuscitation and just further observation and probably do some further workup? Okay, very good. And those are the answers, no? So, in general, immediate surgical exploration is warranted, no, for evidence of significant intra-abdominal injury, especially with probable vascular injury. That's correct. Your chat patient is a transient responder, surgical control of bleeding, the patient is ongoing bleeding. That is all correct. No? Maybe there is still an ongoing bleeding. That's the reason why this patient is still presenting with tachycardia. Just to complete some evidence of significant intra-abdominal injury, hindi lang siya tachycardia, but of course hypotension, with or without abdominal distension, narrow pulse pressure. You also have tachycardia and probably respiratory rate, and signs of inadequate and organ perfusion. Of course, with your clinical examination, like peritoneal signs, like pain, guarding, rebound tenderness, and peritonitis. And also, some patients will present with, diffuse and poorly localized pain, no, that fails to resolve. So these are all indications for you to bring this patient to the operating room to perform your exploratory laparotomy. All the other diagnostic procedures that I've mentioned will really depend on the capability of your hospital in terms of penetrating abdominal trauma. So, for example, if you have a hemodynamically stable patient with an anterior abdominal injury, you can do your initial assessment. First, your ABCs. After your ABCs, you perform your secondary survey, in which your abdominal examination is part of it. There will be your inspection, auscultation, percussion, and palpation. And if there is physical examination that will suggest that there are areas of tenderness, that it increases in size, that is away from the stab site, away from the original stab site with diffuse peritonitis, then that's already an indication for you that there is a significant intra-abdominal injury. However, in patients with equivocal abdomen, you can actually start using the ultrasound that I've mentioned to look for fluid. If there is fluid, then that's indication that there is proven penetration, that you may proceed with your exploratory laparotomy. Now, a negative ultrasound does not mean anything, and it requires further evaluation, maybe further imaging. And also, if you're going to look at a penetrating abdominal trauma, you always look at the mechanism of injury, whether it's a stab wound or a gunshot wound. I've already mentioned about when we talk about gunshot wound, it has a higher probability that this patient has a significant intra-abdominal injury compared to the the stab wound. And also depends on the gunshot wound, whether it's a shotgun or a bullet wound. If it's a bullet wound, is it non-tangential or tangential? If it's tangential, you may probably do a diagnostic laparoscopy. For a shotgun in the back, on the flank, on the anterior, you may proceed with celiotomy. For back and flank, I think there is a separate lecture for this, for the back injuries. But for stab wounds of the thoracoabdominal and anterior, some institutions still will use diagnostic diagnostic peritoneal badge. We're not using it anymore in our institution. I would like to ask lang the other participants if they're still using the DPL in their institution. I would like just to know kung may gumagamit pa, kung may nagpa-practice pa ng DPL. If you're going to use the DPL, no, for this is for penetrating, no. Kung thoracoabdominal, you want to rule out a diaphragmatic injury, you need to lower, no. Literature will suggest that you have to lower the threshold of the RBC to 500 or 5,000 RBC, or you may perform your diagnostic laparoscopy. So, kung anterior
Maybe we
naman
can
siya,
ask your boxer
not a thoracoabdominal, you can do your DPL with the threshold of 10,000 RBC or perform your diagnostic laparoscopy. So, depending on the institution that you have, and the capabilities of the institution, you may need to create your own protocol, with the evidence, still with the evidence, kahit na austere condition yan, kahit hindi siya perfect, the workup that you're going to do is still based on evidence to have a best outcome for our patient. I think that will be my last slide.
Sir Bok, are you online po?
Yes,
Sir, kasi Sir Dr. Rico floated po the question of of DPL, the current applications po of DPL, since hindi nila commonly ginagamit.
Oh. In our institution, we do less and less DPL. We are still using it, but most of the time we are employing na yung screening laparoscopy. So if for some reason yung laparoscopy hindi available, then we still do DPL.
Thank you for that, sir. So for the residents who are attending this webinar, meron pa ring use yung DPL, especially if you don't have laparoscopy and other diagnostic modalities to evaluate your patient, but it's being used less and less today because of advances in or the use of laparoscopy in trauma. Thank you, Sir Bok. Back to you, Dr. Rico.
Yes, thank you so much, Erin. There is a question dito. What is the role of DPL in hemodynamic stable patients without signs of peritonitis in penetrating and blunt in the trends of conservative management? Can DPL possibly increase the rate? Does a non-invasive option like serial abdominal examination in CT a better option to rule out peritonitis, especially in hollow viscous injury and retroperitoneal injury? Okay, so if we're going to look at the DPL, no, like I said, if there's a penetrating abdominal injury, you want to prove penetration. If the ultrasound does not say anything, it probably say I think one or two reasons why. Number one, operator dependent. Number two, the fluid is so low that it cannot be picked up by the ultrasound. So if you do your DPL, for penetrating, we're talking about penetrating injury. If it's positive for blood, then that is considered a positive DPL, and this patient is a candidate for Explore Lab. Now, for non-invasive options, of course, this depends sa institution. Sometimes we also do this. Negative ang ultrasound. Abdomen is soft. Serial abdominal examination, maybe after 24 hours. Then do a trial feeding, hindi sumakit ang tiyan. Then maybe you just observe the patient, kung walang talaga abdominal pain. CT scan, like I said, it's poor in picking up hollow viscous injury. You need to add yung contrast to look for the hollow viscous injury. Now, of course, CT scan it can view the retroperitoneal injury, but that doesn't mean that if you have let's say a perirenal hematoma, that's already an indication for OR. Hindi. It's just saying that the injury involves the retroperitoneal injury that also may require only examination or monitoring. So the next question is the patient PBS exam. If there is evidence of fascial penetration. Okay. When you talk about fascial penetration, no, you have to look at the yung posterior. You're going to look at the posterior rectus sheath. See, underneath the posterior rectus sheath, that then should be the question should be dapat mas clear. If you perform if you look at the posterior rectus sheath, no, that is a white white material there, posterior to the posterior rectus sheath. If you see omentum, no, or in that part in the posterior rectus sheath, that is already proven penetration, no? And it is mandatory for you to explore this patient. So you have to know what fascial penetration is. It anterior or posterior? It should be the posterior fascia. It should be the posterior fascia that should be involved. The next question is good known for patients with stubborn and deep flank. What is hemodynamic stable with soft tender pass positive? Is there room for conservative? Now, like I said, when we talk about flanks, anything, the rule here is that anything that is anterior, anything that is anterior to the posterior axillary line, you treat that as a anterior abdominal injury. So having said that, if that is positive for FAS, that is already an indication for you to operate. I think yun na lang yata yung last question, Irene. Hello? Irene?
Yes, sir.
Ay, okay na. Nasagot ko na itong dalawa.
You can move on to your next lecture po, sir. Kasi yung live na Q&A after both lectures na po.
Mamaya na lang. Sige.
Apo. You can now share your screen for your next lecture po, sir. Thank you.
Bakit wala lumalabas? Arin, saglit. Hindi ko makita yung isa.
Sir, pa-slideshow po nung presentation and then pa-unmute po ng mic. Yan. Hindi pa-unmute lang po, sir, kasi hindi po namin naririnig. Yan. Okay, thank you po, sir.
Thank you. Okay, I think this will be the second lecture. This will be the second lecture. No, I'll be talking about blunt abdominal trauma. Now, this is a different clinical entity, no, compared to the penetrating abdominal trauma. Now, evaluation of patients with who have sustained blunt abdominal trauma remains one of the, well, at least remains one of the most challenging and, shall I say, resource-intensive aspect of acute trauma care, no? Because blunt abdominal injury or blunt abdominal trauma produces a spectrum of injury, no, from a minor single system injury to a devastating multi-system trauma. And the surgeon and the doctor, the physician, must have the ability to detect the presence of intra-abdominal injuries across this entire spectrum. So having said that, our objectives, again, the same as the penetrating abdominal injury. Interpret, again, the examination findings in patients sustaining blunt abdominal injury. And also understand, no, the same, the diagnostic, they apply the different diagnostic modalities used in blunt trauma. Just like the penetrating trauma, I understand the principles also of non-operative management of blunt abdominal injury, because in blunt abdominal injury, trauma surgery is geared towards non-operative management, no, for blunt abdominal injury. So again, with the case we are presented here with a 23-year-old male driver with the seatbelt on, figured in a vehicular crash, and was brought to the emergency room 1 hour post-injury. So we're going to look at the ATLS criteria or important factors, no? Important factors that are relevant to the care of the trauma patient. Before I discuss this ATLS criteria, very important is the extent of, if we're going to get the extent of the vehicular damage, whether this patient is been prolonged extrication was required, whether there was a passenger space was intruded, no, or whether a passenger died, whether the patient was ejected from the vehicle, the role of safety devices such as seat belts and airbags, if there is a high-speed auto crash, more than 50 or 60 kilometers per hour, or a motorcycle crash, no, with separation from the rider in the bike, and falls, no, from 20 feet. And also, there are special populations that warrant special consideration, including children, pregnant patients, the diabetic, and those immunocompromised and bleeding disorders, because they have this ability to respond to injury is compromised, and it may affect outcomes in managing this patient. So we have a patient that came in 1 hour post-injury with a blood pressure of 110/70 millimeters mercury, a heart rate of 100 per minute, an RR of 20 per minute, and GCS score of 15. Patient has no neck tenderness, clear breath sounds, distinct heart sounds. So again, very important, relevant to the care of this patient with blunt abdominal trauma are your clinical examination. So this patient has a contusion hematoma on the right upper quadrant with direct tenderness on the right upper quadrant. There is direct tenderness in the right upper quadrant. Rectal examination is negative for blood, and there is no gross hematoma. Neurological exam of this patient is normal. Again, like I said, and these are important and relevant factors that are relevant. No? If there are significant, if you see this patient, there is a significant external findings on the anterior abdominal wall, like abrasions and contusions, then associated pelvic fractures, lower rib fractures, altered sensorium, and unexplained hemorrhagic shock or blood loss. No? We consider a significant, a significant injury, intra-abdominal. Again, unexplained hemorrhagic shock, history of abdominal impact, and I've already mentioned all of this. So, just like our objective, physical examination, tatlo. If your abdominal examination does not point out that there's no tenderness, no, negative ang abdomen mo, then you label this patient as negative. Negative ang physical examination mo as far as the abdomen is concerned. Of course, if it's generalized, no, if it is generalized, we consider it as positive. So equivocal, no, just like the penetrating, if there is only tenderness in one quadrant, and there is soft and non-tender other quadrants. But remember that physical examination still remains the most important method to determine the need for exploratory especially in florid cases, no? Especially in generalized tenderness. Although it also may be unreliable due to the effect of the altered level of consciousness as a result of head injury, no? Is another major confounding factor in assessing blunt abdominal trauma. So in blunt abdominal trauma, aside from hemorrhage, no, that can be treated non-operatively as long as the patient remains hemodynamically stable or normal. And another one is the hollow viscous injury that you cannot perform non-operative management on a hollow viscous injury. And hollow viscous injury should be ruled out, no, in all victims of blunt abdominal trauma. And physical examination in this slide, no, remains the initial step in diagnosing. But again, like I said, has limited utility under select circumstances. So, in this particular patient, can we ask someone, Irene, to interpret the findings, the physical findings of this patient? Just a tenderness on the right upper quadrant, tapos walang tenderness dun sa other quadrants. How do they interpret these abdominal findings?
So for the participants, you can write your answers in the chat box.
Okay, very good. So, in general, in patients, may seatbelt marks tong patient na to, no? Try to determine if there is tenderness or guarding away from the seatbelt mark, no, dun sa right upper quadrant. Kung soft, then that you can actually say it is equivocal, but if it is generalized tenderness, no, it is positive. So this one is actually a strong predictor. The seatbelt marks, no, these contusions, a strong predictor of intra-abdominal injury. And in some literature, no, it is associated with an 8-fold increase in intra-abdominal trauma compared to the patients without seatbelt marks. So indications to perform your laparotomy, like I said, you have findings of generalized peritoneal irritation, no, diffuse, florid, no, hemorrhagic shock. The patient came in shock, with an indication that the blood loss, no, is in the abdomen, whether the abdomen is distended, or if you have performed a point of care ultrasound in the ER, if you see a lot of blood in the abdomen, no, or an elevated right hemidiaphragm on the chest X-ray that suggests a injury to the diaphragm, are all indications for immediate laparotomy. So what are the diagnostic tests that we can use? Again, just like the penetrating abdominal. So diagnostic tests, first of all, yung other tests pala, yung mga plain radiography, not diagnostic, plain radiography. So I think this already was mentioned, no? Yung cervical spine X-ray, that's already mentioned by Dr. Pusong, no? That we do not clear the cervical spine. No? We just immobilize them until other services like the NSS or the orthopedic surgeon will be the ones managing it. But Ray also mentioned about in the initial management, chest X-ray and pelvic X-rays are the ones that will give us more information in terms of finding immediate and potentially life-threatening injuries, bleeding, no? Or in pelvic X-ray, in the chest X-ray, you'll see a lot of information. So that's the reason why if we're going to look at to choose diagnostic tests initially in this particular patient, please put in your answers, no? So that we will see. I just mentioned it. Well, skull X-ray, very limited ang information na bibigay sa atin yan because it does not, you may have a normal skull X-ray with a GCS5 or GCS6 of patient does not correlate well with clinical, maybe better is a CT scan later on if this patient is stabilized. Maybe for screening, if this patient also has a concomitant facial injury that may require management or further imaging, in that particular area. So the question here is, in the most ideal situation, what would you do in a particular case? So again, let's put on all the choices here, and I want you to answer. This is for us to help, to help the physician or the ones who's taking care of the patient makes the decision whether to operate on this patient or bring this patient to the ICU, or probably in most ideal situations, sa angiographic suite kung kailangan. It really depends on the capability of the hospital. So performing serial physical examination, that I already mentioned this, that is sometimes it's unreliable, but it's usually the initial examination that they're going to perform. Again, ultrasound, the ultrasound, particularly the focused abdominal sonogram for trauma, is based on the assumption, if you're going to do this, you look for fluid. This is based on the assumption that all clinically significant abdominal injuries are associated with hemoperitoneum. So, like mentioned about minimal threshold for detecting blood or detecting fluid in the abdomen, depending on the literature, depending on the authors, some will say 30 ml, 70 ml, but they have concluded that yung pagmaliit na anechoic stripe between the Morrison's pouch, if there is a thin line there, maybe less than less than 0.5, it usually represents about 250 ml of fluid. Whereas if you see a 0.5 based on literature, there's a 0.5 centimeter that represents 500 ml, or maybe a 1 centimeter will represent a 1 liter of free fluid. So that is just basing the assumption that all clinical significant abdominal injuries are associated with hemperitoneum. But again, it doesn't say as the patient is stable, no, you may still perform non-operative. Still, you have to look to rule out hollow viscous injury in these patients. So once you performed the ultrasound that is positive, you can perform a triple contrast CT to look for hollow viscous injuries. The triple contrast. And also, like I said, ang drawback lang ng CT scan, no, relates to need to transport this patient from the trauma resuscitation bay, an additional time to perform CT compared to a focused abdominal sonogram or a DPL. Again, like I said, they can still miss, no, yung mga injuries to the diaphragm, kaya nga up to the bowels, so that we need to have contrast dito sa mga sa performance ng triple contrast CT. And finally, CT scan is relatively expensive and time consuming and requires an oral and IV contrast, which sometimes in patient is there is an adverse reaction. So the best imagery, if you want to get the best imagery for a triple CT or for a CT scan, is you need to have oral and contrast. So diagnostic peritoneal lavage, like Boc had mentioned, that we are not doing it well in our institution. At least we're not doing it anymore. But again, just to review you, that the DPL, now there are two schools of thought dito. If you're going to look at if you're going to use yung 100,000, it's in the textbook, 100,000, 100,000 RBC, 500 WBC, yung amylase, yung fecal material, mga ganyan. These are the positive, no, for DPL. But for now, we recommend disregarding the RBC count as long as the patient is hemodynamically normal. You can perform a non-operative management, meaning when you perform a non-operative management, it has its requirements. Number one, you have to have a surgical ICU intensivist that knows the management. No? You need to have a SICU, no? Hindi lang siya structural but functional ICU. You need to have a efficient blood bank that if the patient needs transfusion, that it will be given to the patient immediately. And also, personnel, residents, nurses, that they know how to terminate. No? Upon monitoring this patient, they know how to terminate the non-operative management and do an operative management based on indications. Of course, when we talk about doing exploratory laparotomy outright, you are subjecting this patient non-therapeutic laparotomy rate as high as 70 to 80%. And of course, even a negative laparotomy, it has its share of problems and morbidities, no, that comes with doing exploratory on a negative or a non-therapeutic or even a negative laparotomy findings. And lastly, now the introduction of minimally invasive surgery in terms of diagnostic laparoscopy, it has no clear advantage actually in general over the less invasive modalities. In blunt, we're talking about blunt, such as DPL and CT scan. Of course, yung trocar placement, yung paglagay mo ng trocar, misplacement can also complicate. And also, we know that this blunt, the most common associated injuries in patients with blunt abdominal injury is the head injury. So if you have, let's say, blunt injury na may associated TBI, that's one contraindication for doing a diagnostic laparoscopy because if you increase the intravenous pressure, you want to have a space, no working space to do your screening laparoscopy. There is a concomitant also, based on literature, there's also an increase in the intracranial pressure that may give the worst outcomes for these patients. So in blunt trauma, it has no clear advantage over the less invasive modalities, such as the DPL or the CT scan and the ultrasound. So you requested this patient be ultrasound, and it has a moderate fluid in the Morrison's pouch and the splenorenal. So the patient remains stable. So I request the residents to answer this, in the chat box. So what will you do? If you can perform the DPL, kung nagdi-DPL pa kayo, do a CT scan with triple contrast, or you perform a outright EL, or you repeat the ultrasound every hour. So like I said, if you perform, let's say, a DPL, kung nagdi-DPL pa, if there is blood, you disregard the blood and look for hollow viscous injury. You know that the performance of doing a DPL, looking for hollow viscous injury, I think it's already mentioned, how to perform the DPL and bring the effluent to the laboratory for examination. Very important also, if you're going still to do the DPL, you have to discuss it with the laboratory for them to look, ano ba itsura ng vegetable fiber na sa enteric contents, that will say that your DPL effluent is positive. It's an indication for you to perform your operation or your explore lab. Doing a CT with the triple contrast, an outright EL, already I mentioned about this, and repeat ultrasound. So this is I had mentioned about the findings of gross and as well as the microscopic findings in diagnostic peritoneal lavage. Like I said, maybe most of us or most of you are not already familiar with this, but at least for our review, these are the gross positive findings. If you aspirate, you can aspirate 10 ml of blood. If you see feces, bile, urine, and food particles, that is a suggestion that there is a hollow viscous injury that performed exploratory laparoscopy. If you don't, let's say it's negative. If you did not aspirate 10 ml of blood, then you infuse 1 liter of warm saline or warm lactated ringers, and after you have given 1 liter of lactated ringers, lalabas siya dun sa catheter by gravity, take about an aliquot of about 250 cc and send it to laboratory. Now, microscopically, if you see more than 100 cc or WBC count of 500, so why 100,000? If you want to look dito, if it's 10 ml and if you infuse or 1 liter or 1,000 cc of blood, you got to extrapolate it, lalabas dyan, more than 100 cc RBC count. So, but like I said, the PCS, the best already advocated disregarding the RBC count. As long, the caveat here is as long as the patient remains hemodynamically stable and you have the capability of performing a non-operative management for this particular patient. But again, like I said, in my opinion, if you cannot perform, if you do not have the capability of a non-operative management that I have mentioned, maybe you can already follow this old guide for positive DPL. Okay, the next slide is you have aspirated 50 cc of gross blood. If the patient remains normotensive, one should manage the patient non-operatively and or do exploratory laparotomy. So I'd like to request the audience to answer the question. The questions na naman yan. Dalawang choices lang. As long as nag-remain hypotensive, no? Kahit, let's say, lagay natin 100 cc, 500 cc, 700 cc. As long as the patient remain normotensive, one should what? Now, while being observed in this patient, the BP dropped, no? Just like the other case na sa penetrating. You know already what is happening, or less have an idea of what is happening to this patient. He was resuscitated with crystalloids. BP went up to 110/80. So what would you do? Do you continue non-operative management or you do your immediate surgery? I've already mentioned sa inyo yung when to terminate non-operative management in this particular case. So again, these are the criteria to terminate the non-operative management. Like I said, hypotension that is attributable to the abdominal injury. When you perform your DPL, probably do the chest X-ray, you see a pneumoperitoneum, you do the CT, you see extravasation or edema in the area. That will all points you to the signs of hollow viscous injury. Then non-operative management is terminated. The patient that maybe you have observed about several days, no, that develop septic syndrome despite of normal abdominal findings, is also a criteria, no, to terminate a non-operative management. And what we call trending, no, a clinical deterioration despite during your monitoring, in the ICU, there is deterioration in the vital signs. These are all criteria to terminate non-operative management. I think that is the last slide. Any questions? I'm glad to answer. Thank you. Irene, that's my last slide. That's like a look. So equivocal, no? So tama, sir. To the we're talking about dun sa laboratory, sa X-ray. What we do is we do a chest X-ray and the pelvic X-ray because that is the one that has a source, no, of significant bleed or significant blood. Cervical, you can do this after you have already addressed the primary survey or treated the immediate life-threatening injuries of this patient. Like I said, for the neck, there was already mentioned by Dr. Poso regarding the indication to do the X-rays or the workup for cervical spine. But for initially, our role is not to clear the neck. What our role is to immobilize the neck. Okay, for Anna Carmi, yes. Explore. Okay. So questions? Okay. So what is the role of DPL in hemodynamically stable without signs of peritonitis? Yes, DPL, no? DPL, sandali, are we talking about, hindi ko alam kung blunt pa to or penetrating. If this is penetrating, yung una, if it is penetrating, that already is a sign that there is proven penetration. And that is an indication for you to operate. No? Now, sa PBS exam, if patients with abdominal penetrating injury with evidence of fascial penetration without signs of peritonitis, okay, a mandatory explorer is still an option. In the examination, well, I'm not an examiner, no, but if you're going to look at the question, you have to know if the question will be a posterior rectus sheath or posterior fascia, because posterior to the posterior fascia is already the peritoneum. So that's the white material there when you do that, when you do this. If you see, let's say, a momentum there, no, na nakalabas, then that is already indication for you to operate. So for patients with stab wound on the flank, like I said, pag flank kasi, you're going to look flanks, no? Anything that right flank and right upper quadrant, anything that is anterior to the posterior axillary line is to be treated as an anterior abdominal trauma or anterior abdominal injury. Having said that, when you perform in a hemodynamic stable, a soft tender abdomen with the FAST positive, that is already a indication for you to perform exploratory laparotomy. Stable patient, no peritonitis, abdominal trauma. If on DPL is positive, if this is blunt, I think baka blunt ito yung kay Dr. John Ray Faril, no? Stable, no peritonitis. If on DPL is positive for gross. When we talk about kung microscopic, kung if there is really vegetable fiber or signs of hollow viscous injury, no, you cannot observe this patient because sometimes we also see patients that has a history of blunt injury that presented abdominal pain after mga several days, no? So, and it turns out to be, when you operate on the patient, turns out to be that the small bowel was completely transected. No? Basically, nung pinii siya, relatively parang soft, parang the abdomen is not that really surgical. So how long do you monitor these patients managed probably in general? 24 to 48 hours or even mga after 3 days, no? Kung hindi naman siya nag-deteriorate. So that is the time for you to, after monitoring in the ICU, can bring this patient to the regular room. Pero mino-monitor pa din. But for ICU patients, you monitor these patients for about up to 3 days, 24, 48 hours, or even up to 3 days, no? To manage non-operatively. As long as wala siyang, yung binanggit ko na mga indications for you to terminate non-operative management.
Joseph?
Yes.
George? Yung
George, go ahead.
Yung dun sa question, dun sa Q&A, di ba, nakalagay kasi gross and microscopic blood, pero hindi niya sinabi kung blunt or penetrating eh. Pa-clarify na lang yung difference.
But I presume, sir, ano to eh. I presume ano to eh. Yung blunt ito, sir. Kasi ito 130 na eh. So mukhang ito yung blunt, sir eh.
Okay.
Okay, so thank you, sir.
Okay.
Tapos, good afternoon po. We had a patient with a Ball's rectal injury with profuse bleeding and pelvic fracture. Abdomen was unremarkable and FAST was even negative, but said patient was severely unstable. If EPEL warranted or dangerous to patients with pelvic fracture? Good question. Kapag na-abulse yung rectal injury mo with profuse bleeding with pelvic fracture, no? Number one dyan kasi is for you to decrease the volume of the pelvic fracture to stop the bleed. No? You have to stop the bleed on that particular patient. Now, also very important, no, it's easier said than done. Maybe depending on the pelvic fracture, no, if this is an open book, a lateral shear, or a vertical shear, no, depende. But an extraperitoneal pelvic packing may also be warranted in this particular patient to stop the bleed. No, now maybe doing an explore lap here, no, kasi if you have a rectal injury, no, a VOLS, no, you are already indicated to perform a diversion in this particular patient. Maybe in my opinion, no, doing a very important kasi dyan na yung pelvic hematoma, hindi mabuksan, hindi ma-open siya once you do your explore lap. So those are the principles that you need to be in your mind when you perform in these particular patients. Stop the bleeding by putting a pelvic binder. If none, no, at least in our institution, you can perform a extraperitoneal pelvic pack. Kung hindi, we can still call on the orthopedic to put on the C-clamp, no, depending on sa pelvic fracture mo. And then do a resuscitation and your diversion, your colonic diversion. Now, good noon, sir. Can an isolated hemoperiton from a spleen produce peritonitis? Now, I think your question maybe yung I think the question of Dr. Ko is, if you see, is there na injured yung spleen dito? If there is an injury to the spleen, usually ang blood kasi does not cause, in general, blood does not cause peritonitis. So it will not produce peritonitis kung blood lang yan. So if this is blunt, no, or spleen, stable ang patient, isolated blood around the spleen, no, and you have splenic injury, then you can perform non-operative management in this patient as long as this patient is hemodynamically stable. Ang tanong dito, is there a role, Dr. Ele Canal, Dr. Soledad, is there a role in conservative management in fast positive patient? If this is yung blunt, yes. If this is blunt, is there a role in conservative management? Yes, there is. Actually, ito ang recommended as long as you have ruled out hollow viscous injury by doing your CT with triple contrast and also your or DPL. No? Like I said, these are all this diagnostic armamentarium that is being presented to you. They are not perfect. They have their they have their share of false positives and false negatives. So very important dito na if you going to manage this patient non-operatively based on the evidence, no, the evidence na sinasabi, these are the ones that we use for for managing this patient based on the history, the physique of the patient, the clinical presentation of this patient, no, and then monitoring. How does this patient fare, no, during your monitoring? So fast positive for blunt, as long as you have ruled out hollow viscous by performing a DPL and a contrast, no, CT contrast, you may perform non-operative management on these patients. Thank you. I think that is the last. Irene?
Yes, sir. Actually, we can probably do a working lunch na lang po kasi in the interest of time. But Well,
Finish
can
na
I
ako.
ask the panelists if we can have a 30-minute lunch break before we proceed po with the lectures? Sir George, is it okay for us to have a lunch?
O para makapag-break din yung yung participants.
Makapag-wiwi and food break.
Yes. Oo.
Opo. So,
Okay.
yes po. For those of you na hindi na answer yung questions or you still have questions in your mind regarding blunt and penetrating abdominal injuries, you can type your questions, additional questions in the chat box, and we will address them po. Dr. Wico will answer them po sa chat box na lang po. So, I guess we can have our lunch break, but we will resume po in mga 30 minutes po para mahabol po natin yung time. So, yun po. Lunch break, and then we will proceed with the lecture of Dr. Agatmaytan po. Thank you. Enjoy your lunch.
Thank you.
Thank you, Sir Joseph.
Thank you, Irene. Thank you, Sir George.
Okay, thank you, Joseph.
So you can stay online naman po while you take your lunch. Hindi po namin i-off yung Zoom link. We'll just have some background music for you. Sir Joseph, can you unshare po?
Pwede pa, meron pa rito 3 questions kasi, Irene. Pwede ba natin sagutin na to?
I-answer na lang natin, sir, sa chat box. You type the answer na lang po, sir, so that they can have lunch as well kasi medyo 1:30 na po.
Okay, thank you.
Apo, sir. Pa-stop share na lang po ako, Dr. Wico. Sir? Thank you po.
When you switch to Premium, you unlock the power to explore and discover music ad-free. Once you find a playlist you love, listen to it straight through on any device with On Demand. Or download music and listen anywhere with offline listening. Plus, get unlimited skips, even on mobile. Step into Premium and get 1 month free.
Okay, so good afternoon again, everyone. I hope you have enjoyed your lunch because we still have 4 topics, I believe, for this afternoon session. So, but you can still get up, go get your coffee, go to the restroom. We'll proceed with the lecture proper. So I would like to call Dr. Beth Gaitmaitan to talk about trauma radiology.
Okay. Good afternoon po. Good afternoon to our panelists and good afternoon, Doc I. Good afternoon to our participants. So this afternoon, I will be discussing the trauma radiology. Permission to share, Dr. I.
Yes, go ahead po.
So my topic is on trauma radiology. So for this afternoon, we are not expecting everyone, all the our participants, to be radiologists after the session. No? So we just want you, number one, to be able to identify the different radiologic procedures that we commonly request for trauma patients. Okay, and also be able to identify the specific indications for requesting this particular radiologic exam or radiologic procedure. Okay, so we do not expect you to be calculating all the desired measurements in a specific bone. So meron lang tayong particular na we want to identify. So again, to review yung ating lecture kanina umaga, so you have to approach your patient, a severely injured patient in a systemic manner. So of course, you have to first do your primary survey, and after you have addressed all your immediate life-threatening injuries of your patient, and you have resuscitated, you go with your secondary survey, and so on. So with the primary survey, we have to remember the ABCDE. So I hope you have all remembered and put this at heart kasi dyan lang tayo magbe-base when you are going to assess your patients na in the future or probably later on kung naka-duty kayo. Then for our secondary survey, this is the time we request for radiologic exams. So why secondary survey? Of course, we have to be able to stabilize our patients first before we do our x-rays or our CT scan. Okay? In some journals, you may be reading na some hospitals do their x-rays or scans or other requests for radiology during the primary survey. But you have to take note saan ba galing tong journal na to. Kasi in some high-tech or first world countries, their trauma bay is already fully equipped and capable of doing certain radiologic exams such as x-ray while your patient is still in the trauma bay. Okay, so they do not need to wheel the patient into the next room to do their x-rays. So kaya nilang gawin yung x-ray during their primary surveys. But for us, in our setting, most of our institutions, we still have to wheel our patients to the next room to be able to do our scans or our x-rays. So safest for us is during our secondary survey, if your patient is already stable, all your immediate life-threatening injuries are addressed, tsaka lang tayo magpapa-x-ray or CT scan. Okay? So again, for your secondary survey, you have to remember your ample. So hopefully, our residents will remember this: the allergies, medications, past medical history, last meal, and the events following the incident. Okay, so you have to do your detailed, meticulous head-to-toe examination during your secondary survey, and this is when we do our adjuncts or radiologic requests or exams. Okay. Siguro naman, we are all familiar with this area in our hospital. So it can be very near to the emergency room, but although this is near to the emergency room, you must be certain that your patient is stable you have already addressed your immediate life-threatening injuries of your patient. Kasi there is no room for a hypotensive or unstable patient or trauma patient in the radiologic suite. Okay? So during the late 1990s, if you're given this type of patient, ano ba yung mga x-rays na you would request? Probably request. May I call a volunteer from the group? Saan ko ba siya pwedeng makita? Doc I?
Actually, so participants, but I don't think medyo
They-
allowed sila.
Sila okay. Sige, I will discuss it na lang as I go. So, thank you, Doc. So, during the late 1990s, we still request for the trauma series natin, no? So, we do the x-rays from the skull, yung x-ray natin ng skull, cervical, and then we also request for chest x-ray and pelvic x-ray. And if we note na merong fracture or deformity yung extremities ng patient, we also request for the x-ray of the extremities of our patient. So, minsan, pag may CT scan, yung facility nyo, you can also request for CT scan during those times. But of course, parang na radiation mo na siya from head to toe kasi sa dami ng pinagawa mong x-ray. So, if there will be a specific x-ray na gusto natin ipagawa at this time na nasa 2021 na tayo, siguro kung pipili kayo dyan, isipin nyo lang, pili kayo ng tatlo, yung mga participants natin. Alin dyan sa tatlo yung inyong pipiliin to be part of your radiologic test for this patient. Okay, then keep that in mind later on. Okay. So for the head, usually pag nagpa-request tayo ng skull x-ray, para siyang we are just given a picture na flat lang siya. We can see the skull of the patient, but we won't be able to see yung brain parenchyma ng patient natin. So we may find some instruments or impaled objects such as this one. So kitang-kita natin yung impaled na knife dun sa patient's head. But because we want to see further, nagpapa-request pa tayo. Baka kasi may fracture siya on the maxilla or on the mandible, we would request for certain views sa x-ray, such as yung Waters, Caldwell, and lateral view. But take note that these views actually would require patients to be in specific, very specific positions na pwedeng hindi magawa ng isang patient na intoxicated or with a GCS of let's say less than 8, hindi niya magagawa yung mga views na to. So that is why during also your neuro exam, nabanggit na ang gold neuro part ng lecture, nabanggit na the gold standard of examining our head trauma patients is to do a CT scan. Okay, kasi mas detailed, there is more detailed and views or picture na makukuha nyo from CT scans. So you can see the brain, you can see if there is bleeding, you can see if there is already compression of your ventricles. Okay, so you actually have a good idea. And also, CT scan will give you possible bone view para makita natin if there is, you can request for a bone view para makita natin if there is fracture of specific areas, lalo na yung mga minute bony fragments sa face or sa skull ng patient natin. So there is really limited use of our skull x-ray, particularly if you are trying to identify if your patient has intracranial problem. So ang ideal natin na request is a CT scan for head trauma, for if you are thinking that your patient has a neurologic problem brought about by the trauma. Now for the cervical spine, this was already also discussed a while ago, but if you are given a patient na sabi niya sa'yo, Doc, tumalon po ako 20 feet high Pero okay naman ako, Doc. May masakit lang sa talampakan ko. So what do we usually do to this patient? We just send them out or send them home. Wala na tayo ibang gagawin. Okay, so you must remember that patients who try to jump off a building or falls off from a building, hitting their feet first, so para silang Spider-Man nang bumagsak sila sa floor, pwede kang maging overwhelmed dun sa adrenaline na ibibigay niya sa'yo na baka isend mo na siya pa uwi. Pero you have to take note that there is a force of impact na pwedeng, that force of impact may have affected there can be a significant eggshell loading for your patient. Na because of the impact of the force, it has affected the joints of the knees, the hips, as well as the spine of your patient. Okay, so it is more prudent for us if we will do certain tests such as cervical, thoracolumbar, and lumbosacral, just to be sure that because of this force of impact, wala siyang naging fracture, compression, deformity sa spine niya, and even sa hip niya. Okay. Then for the chest is a very significant portion of our body. So most of the times during vehicular crash or fall, this is the part of our body that is really affected by the injuries. So it can be blunt or penetrating chest injuries. This will all be discussed in detail later on by Dr. Ai. But for injuries to the chest, either penetrating man or blunt, what we request is a routine chest X-ray. Okay, we do not request for a T-cage, but just a routine chest X-ray. Bakit hindi T-cage? This is the most common na naririnig kong pinapa-request ng juniors or even ng mga hospitalist is to request for T-cage, tas meron pa silang chest X-ray. What we recommend is for you to request for the routine chest X-ray. So this is the reason why. With your routine chest X-ray, you already have a very good view of what your patient's injuries might be. Ang kailangan lang is you have to be able to read it in a systematic way na wala kang mamimiss out. Okay? So this is an example of a chest X-ray that is adequate. Why adequate? Kasi kita dyan yung sa may shoulder niya, sa clavicle, sa glenoid fossa, and then also kita din dyan yung diaphragm ng patient. All complete. Okay? And then when you are assessing X-ray, chest X-ray of the patient, you have to do it systematically. So how systematic can we do it? So pwede nating i-follow yung ABCDE ng primary survey natin, which is airway, breathing, circulation, deformities, as well as environment or extras. So alin dyan yung airway? So here in this example of chest X-ray, you can see here the trachea. So may tracheal shadowing tayong makikita. Also up to the bronchus of the patient. Although not all X-rays are this kaliwanag or very adequate, you just have to try looking for the trachea in your patient's X-rays. Okay, so check for the tracheal shadow and the bronchus. If it's in the midline, kung meron bang shifting or what. And then if there is also ET tube in place sa trachea ng patient mo. And then move forward to your breathing. Ano ba yung mga parts that we use for breathing? So we have the lungs, which is bilateral, as well as the diaphragm, which is also bilateral. So you have to check for your patient's lungs. If your patient has a significant hemothorax or a pneumothorax, or meron ba siyang mga opacifications, pwedeng meron siyang contusion dito sa area niya bilaterally. So you always have to look bilaterally. Then also check the diaphragm of the patient. If it is elevated or parang may deformity kang nakikita near the diaphragm. Okay? And then for the circulation, which part naman ng X-ray natin pertains to the circulation? So you have the great vessels. the aorta, okay, and then of course the heart. So is your patient's heart widened? Meron ka bang loss of the cardiac silhouette? Or meron ka bang nakitang apical tap na pwedeng magbigay sa ng clue that your patient has probably a dissection of the great vessel? Okay, so these are the things na you might want to check on your patient pertaining to the circulation. Then for D naman, deformities or bones, yan na yung lagi nating hinahanap. If your patient has fracture, flail chest, or even sa clavicle natin, you have to check if there is already fracture or deformity of your patient. Remember, if your patient has a clavicular fracture, it's a vehicular crash, meron siyang clavicular fracture or fractures of the second to the third rib ng patient, it connotes that your patient experienced a significant force na kaya pati yung clavicles niya nag-break or nagkaroon ng fracture. Okay? And then for the E, you have the environment or the extra. So what do we look for here? Yung soft tissue ng patient natin bilaterally. Okay, so look if there is any subcutaneous emphysema. Also, dito mo rin i-check if your patient already has a thoracostomy tube. Okay, baka meron na siyang mga naka-insert na mga decompressive procedures na nagawa sa kanya. Also for the ET tube or the cables of your ECG. Okay, now for the chest, this is the single most important X-ray lang. So we don't need to request for additional TCAG kasi you can already identify that dun sa initial natin na routine chest X-ray. So in this example, ganda sana kung natatanong ko kayo individually, no? But you can actually type in your answer dun sa sa slides natin, no? So for this slide, if we're going to look at it, ma-overwhelm ka dun sa amount of fluid that is already on the right chest of the patient. Okay? So kung bago ka ma-overwhelm dyan, i-remember mo lang, mukhang meron siyang hemothorax. Pero I have to check also the trachea. The trachea here is deviated. And then you have to check for the contralateral lung din kasi breathing na tayo, no? So contralateral lung, mukhang meron siyang, pwedeng meron siyang pneumo. I-check mo rin yun sa kanya. And then you also have to check for the C circulation. Is the heart, cardiac silhouette, maganda ba siya? Or baka mukhang twisted na yung heart niya because of the compression of the fluid that is inside your right chest. Nako-compress na yung left side of the lungs natin. Also look for deformities kung meron siyang fractures, and also baka mamaya may thoracostomy tube na pala siya, post-CTT na. Hindi lang natin nakita. There are times nangyayari yon na hindi natin nakikita yung tube, na-visualize, yung pala may CTT na siya. Hindi lang siya, probably hindi siya in or nag-kink yung CTT natin or yung thoracostomy tube. So these are the things that you want to look out for. So sometimes you will be given x-rays na parang may blunting lang siya or opacifications or fluid sa costophrenic angle. So blunting of your costophrenic angle will amount to about 250 to 300 cc of fluid. And then if you're going to count the interspace from below, from the side of the costophrenic angle going upwards, kung saan yung level ng fluid mo. So bibilangin mo siya from here, going to the level of the fluid na meron ka per interspace is equivalent to 100 to 200 cc. So at least you have an estimate of the fluid that is already accumulating in your patient's chest. Now for this slide, again, you will look for the airway. Tingnan natin yung trachea. Is it straight line? Mid-deviated ba siya? So for this, medyo deviated siya to the right, no? And then also your, obviously you have problems with your patient's breathing kasi mukhang meron siyang air fluid leveling dito, no? Sa left side. While sa right side, mukhang okay siya. Then you have your C circulation, your cardiac silhouette, medyo push siya to the right side. Okay? Then your diaphragm is intact on the right, but sa left, medyo di mo na siya ma-appreciate. Okay, then go on with reading your bones kung merong fracture, then the tissues or soft tissues surrounding your chest, if there is any subcutaneous emphysema, up to the level ng neck. Okay, so for this x-ray, there is air fluid level, probably a pneumohemothorax. Again, as a resident, you have to be able to identify nasaan ang pleural line. Okay? Pleural line will tell you if your patient, kung very obvious siya na hindi siya adjacently close to the thoracic cavity, then probably your patient has pneumothorax. So this is just an example of a spot view or a spot film ng patient's x-ray. So the pleural line, you can identify here. So kung na-identify mo siya sa location na to, very far from your the margin of your ribs, then you can say your patient has pneumothorax. So hindi naman, although it is quite nice if a resident knows how to estimate yung pneumothorax, but for us at the level of the resident, at least identify ano yung pneumothorax at ano yung hemothorax. Okay? Then this is an example of a chest x-ray. Again, very overwhelming for us, lalo kung medyo mataas na yung energy sa emergency room. But you have to read it again systematically. You don't want to miss anything. Okay? So for this patient, meron siyang obviously ET tube na sa trachea. And then your left and right lungs are obviously has contusions and hemopneumothorax bilaterally. Also given the clue na meron kang thoracostomy tube bilaterally. Okay, if the tubes are already in, you have to check nasaan ba yung sentinel hole pala ng patient's thoracostomy tube natin. Okay, you have to identify if it is in or it is inside the thoracic cavity. Again, you have to check for the bones if there are fractures or deformity. And obviously here, meron siyang multiple rib fractures. The diaphragm is intact, and then the cardiac shadow, can we say that this is normal or this is widened? Okay, you may type your answer, but this is a widened mediastinum already. So remember, at the level of the angle of Louis, more than 8 cm na width ng cardiac shadow is considered already a widened mediastinum. Now, also consider yung or take note of the subcutaneous emphysema ng patient natin. Very significant kasi meron siya sa chest wall and also up to the level ng neck. Okay, this is an example naman of a chest x-ray with obvious pneumoperitoneum. Okay, so nabasa mo na siya using your ABCDE ng reading ng x-ray, pero nakita mo yung significant amount of pneumothorax on this side. So for these types of patients, you don't require you na to do the plain abdominal x-ray just to identify a pneumoperitoneum. Okay, so a pneumoperitoneum can be identified using your chest x-ray. As long as your patient is positioned upright or high seating. Kasi kung chest x-ray siya na nakahiga, baka medyo hindi rin siya makikita. Yung pneumoperitoneum mo will not be very obvious. Okay. So for flail chest, take note, lagi tinatanong to sa mga exams, even with in-service exam, ano yung meaning ng flail chest, ilang ribs, ilang segments. So reviewin nyo na lang siya. Just take note that in flail chest, there is a floating segment of rib that is yung breathing mo nagiging asynchronous siya. Okay? So kaya nagkakaroon ng difficulty yung patient mo clinically sa work of breathing niya. Okay, so there is a floating rib, kumbaga. Okay, so makikita rin sa chest x-ray yung mga segments of ribs na affected if you have a frail chest. So this is an example naman of a contusion or pulmonary contusion, probably a patient na VA or fall. Makikita mo rin dyan the fracture, rib fractures ng patient, multiple, from 2nd, 3rd, 4th, 5th, 6th, 7th. Okay. Also, in this x-rays, ang sarap tanungin, ano ba yung nakikita niyong kakaiba with this x-ray? So, you can see the trachea are both midline. So, mukhang wala tayong problem dyan sa part na yan. But obviously, yun, napindot ko na siya. It's an acute diaphragmatic injury because of the nakikita niyong figure dito sa part na to ng left side ng chest. Nawala na yung blunt na yung costophrenic angle niya sa left side. There is actually a bubble of air on this side sa left na napupush up niya ng onte yung the shadow of the heart. Also in this part ng slide natin, there is no of diaphragm on the left side. There is a bubble of air inside the thoracic cavity. Tapos ito yung lungs natin is already atelectatic. Okay, occupied na siya ng intra-abdominal organs. So this is an example of an acute diaphragmatic injury patient. Okay, so for X-ray, again, we only do routine chest X-ray. We don't need to do a T-cage during your secondary survey. Just a routine chest X-ray that is adequate. Mas maganda kung makuha niya lahat. And then you have to read it on your own and then read it together with your radiologist. Okay. Limited use of your plain abdominal X-ray for trauma patients except for locating slugs or foreign body trajectories. Okay? Sana may gumagawa pa rin na naglalagay ng marker when you have gunshot wound patients. So sa point of entry or any area where you identify the gunshot wound, you place a marking so that when you do your X-ray, you already have an idea na saan ba yung trajectory ng patient's probable trajectory of your patient's injury. So you have your patient's anterior and lateral view ng abdomen. So you have the idea sa anong parts of the abdomen are probably injured with the gunshot or with the impaled object. How about IVP? Is there a role for trauma patients ng IVP? So they still use, some of them still use just to identify if there is functioning of your contralateral kidney for patients who you are contemplating to probably remove the kidney because of a severe injuries of your kidney. So as you can see here, very translucent or kitang-kita mo yung renal pelvis ng left, but sa right, you can no longer identify. So what else can we request during the initial assessment of our patient? We can do the FAST or the focused assessment, sonography for trauma, then also the EFAST. So just briefly, these are the areas being examined when you do your FAST. So hopefully lahat ng hospitals meron ng point of entry or point of care na FAST and EFAST. So we look for the pelvic area, both sagittal and horizontal views. We look also at the thoracic. Yan yung sa EFAST natin, left and right thoracic. Then we have the left upper quadrant, right upper quadrant, and of course the pericardial area. for any cardiac tamponade. Okay, so the details of this may mababanggit din mamaya with the discussion on abdominal injuries. So pelvic rock. Does any one of you still hear the pelvic rock, kung paano siya ginagawa? Okay, so as you can see here, ang pelvic rock, they do it to assess the integrity of the bony structure of the pelvis ng patient, especially for vehicular accident cases or patients who fall. We want to identify if your patient has injuries in the pelvis. But as you can see here, you are actually applying a significant amount of pressure or force on the patient's pelvis. And if this patient really has a fracture, then ma-aggravate lang natin, or yung stable fracture niya, baka maging unstable pa, kakarak natin. Okay? So for these patients, we do not recommend doing the pelvic rock anymore because most of our patients will really present with abdominal tenderness, and pag sinabi niya tender or talagang hindi niya ipapagalaw sa iyo yung pelvis niya, ayaw niyang gumalaw, ayaw niya ipagalaw, that should already be a clue for us na, or the patient probably has a pelvic injury. You have to do your pelvic binder or immobilization of your pelvis so that you will prevent further injury or additional bleeding dun sa pelvis ng patient. Take note that your pelvis can actually contain at around 4 liters of blood, kaya we need to address it or immobilize it as early as possible. So rocking your patient's pelvis is dangerous. It may aggravate the fracture and cause further bleeding of your patient. So your patient will bleed from the artery, from the vessels, from the bone. So refrain from rocking your patient's pelvis. You just do your routine pelvic x-rays. An example of this is this one. So, paano naman natin babasahin yung mga pelvic x-ray natin? So, we still follow algorithm. So, we check for adequacy and quality of your x-ray. So, yung x-ray ba ng pelvis ng patient mo, is it adequate? Does it show you the pelvic wing, the pelvic bone, the acetabulum, bilaterally, the femur or proximal portion of your patient's femur? Hindi ba siya cut or baka inadequate yung pagkaka-view ng pagkaka-place ng x-ray. Also now you check for the bones, of course. Check for the cartilages or the joint area of your patient, and then check for any deformities and soft tissue edema or any findings sa soft tissue area natin. Okay, so an example of this, you have to take note your pelvic ring. So your pelvic ring should be symmetrical as well as your obturator ring. You have 2 obturator rings and you have 1 pelvic ring. If it is not symmetrical, then you already have a clue na probably meron siyang fracture. Okay? But syempre, depende rin yan sa position ng patient during the x-ray. Kaya nga, when you're reading x-rays, you have to always read it together with your radiologist. Okay? Then another line to look for is the Shenton's line. This is the line ng medial part of your femur, proximal femur, and your superior pubic rami. So it has to be also symmetrical. Okay? So hindi broken yung dotted line natin. Also, the ring of the acetabulum, it has to have a significant or at least a space between your socket. So the teardrop line here should also be symmetrical with the other side. And of course, your sacroiliac joints, this one, yung dark line here. So most of the open book fractures, makikita nyo na widely open or displaced yung pubis, symphysis pubis natin, ito nasa A. And then nag-override yung sacroiliac joints sa posterior. So open book fracture, or in at times, if patient is a victim of fall, pwedeng mayroong shearing forces, nagiging disjointed yung sacroiliac joint from the whole area. So, pwedeng may lateral shearing force applied because of the accident. Okay? So, yun yung tatandaan natin sa pelvis. So, if your patient is a vehicular accident or vehicular crash patient, ang request lang natin for the chest is the routine chest x-ray, and then for the pelvis, you don't do the rocking anymore. You just, if the patient tells you meron siyang pelvic tenderness, then you have to immobilize that, apply a pelvic binder, and then request for a pelvic x-ray. You don't need to request for a frog leg position or kung ano pang position, just a plain pelvic x-ray. Okay. For the extremities naman, you have to still assess the patient for any signs and symptoms of serious injuries to the extremities. There is pain, if there is tenderness, if there is swelling or discoloration, obvious deformities, and if your patient is unable to move or use the limbs. Of course, if you're going to assess patients in the incident itself or yung sa area of the crash, hindi niya talaga ma-move yung isang part, do not try putting it back into place, lalo na if you're not an orthopedic surgeon or you're not really adept at doing it. So you just splint them where they lie. So don't attempt in reducing, lalo kung hindi ka sigurado with the placing ng bones or paano siya na accident. Okay? You splint them where they lie. Mag-apply lang ng split. It can be a wood or any hard object on the area of the injury. You have to cover bone, if it is a fracture on the long bone, you have to include the joint above and the joint below. If it is a fracture on the knee area, such as this one, parang malapit siya sa knee joint mo, then you have to place the splint that will include the long bone above and the long bone below. Okay, then apply the split. You have to also splint your patients kung nasa ER na sila before you do any x-rays to your patients' extremities. Make sure that your patients' injured parts or injured extremities are immobilized or splinted before moving them to the x-ray room. Okay, any movement kasi pag you're going to wheel your patient into the x-ray room, pwedeng ma-aggravate yung fracture or deformity. Now, this is an impaled object. So what do we do with this type of patients? So sa sobrang excitement natin, dinala agad sa operating room. So is there anything that we want to do radiologically? So we can request for, or we should request for an AP, a lateral view of your patient's part na impaled. As for this case, impaled siya sa torso. So you have to do a chest x-ray AP lateral. So dito lang tayo magkakaroon ng additional view na x-ray for the chest if there is an impaled object. So in summary, for the use of the skull x-ray, very limited na siya. So for injuries of the head or you're considering neurotrauma, the standard is you do your CT scan, ideally for these patients, because you can also request for a bone window para if you want to see the details of the fracture of the bone, readily available na yun. You just have to request for the radiologist to do it. Evidence-based guidelines for cervical spine injury, ang dinagdag lang natin is if your patient is a victim of falling from a height of more than 20 feet, falling feet first, then you have to consider that there is a significant axial loading, and you might want to request for a cervical x-ray, a thoracolumbar, and a lumbosacral x-ray, just to check if there is no injury, compression, deformity on your patient's spine. Also, your pneumoperitoneum is better visualized on an upright chest X-ray, and your plain abdomen X-ray is useful to locate any foreign body and to predict the trajectory of your slug, provided you mark the patient's open wound because of the gunshot. And then your IVP is primarily done to assess the function of your contralateral uninjured kidney. Then again, all radiologic films should be officially read by a radiologist. So you have to at least know kung ano yung mga important na kailangan malaman as a resident, as a surgical resident. Then if you have the idea, you discuss it with the radiologist, give them a good picture of how the patient presents to you para na-discuss nyo together ano yung possible injuries. Kasi some of the radiologic findings may be very minute or very small na pwede nilang ma-miss out kung hindi ka magbibigay ng accurate or magandang history dun sa radiologist. I think that's my last slide, Doc Ai. Thank you.
Thank you,
If there are any
Beth.
questions, Doc?
Yes po. Any questions for Dr. Gatmaitan? Busog na busog pa yata sila sa lunch.
Nakakamiss lang magtanong, Doc Ai, sa mga...
Oo nga, medyo difficult to call them one by one because of the limitations of the ano. Anyway, probably we can arrange for that next time. Any questions po for Beth before we continue on with the lectures? We only have 3 more lectures to discuss in the afternoon before we call it a day. So, pwede naman po humabol while ayan. I think meron ng questions.
When do
doing with to do
To
TKH?
do TKH. Okay, so as we have discussed kanina, for patients na on our initial assessment ng trauma because of the trauma, we recommend to do the routine chest X-ray. That is your AP view ng X-ray, because with this view you will actually be able to identify na yung mga rib fractures. With TKH kasi, ang pinaka gusto lang natin makita, ma-identify is kung may fracture ba or hindi, di ba? So, we are actually going to request a view kung saan makikita mo na lahat. Not just the bones, but also the condition of your thoracic cavity, kung meron ba silang pneumo or hemothorax. Kasi with TKH, hindi mo siya ma-identify. Iba yung lalabas na picture, hindi mo makikita masyado yung lungs ng patient mo. As opposed to or as compared to an AP view. With an AP view, you already have the view of your bones. So when do we do TKH? For most early part in your initial assessment of a trauma patient, kasi gusto natin fast lang and then complete yung makukuha nating idea kung anong condition ng patient. We will be satisfied with an AP view lang ng chest X-ray or your routine chest X-ray. The TKH, we don't routinely request or recommend at this stage ng assessment ng trauma patient. But for example, if you identified sa initial X-ray mo na on routine, meron kang you think fracture, then you can do other succeeding test. Kasi ang nire-request natin ngayon is on the acute phase ng patient na dumating siya sa'yo, very ill, may mga immediate life-threatening injuries siya. Ano ba yung test or adjunct na pwede mong ma-request na mabilis pero mas marami kang makukuhang information? So, yun yung gusto natin makita. If after your primary survey, secondary survey, na-identify mo on initial x-ray na meron kang suspicion ng fracture, hindi siya masyadong na-view dun sa unang routine x-ray view mo, pwede kang mag-request sa succeeding na yon. What we are recommending to you to do when initially assessing our patients is ito lang munang dalawa, because they are the fastest, these are the views na mas marami kang makukuhang idea on what your patient's injuries might be. Sana nasagot ko yung tanong mo, Asoy. Thank you.
May follow-up lang na similar to that question. What's the indication daw po to order a chest AP Bucky film?
Bucky film? Sorry, Doc.
Bucky. Sorry.
Bucky film. Chest AP Bucky film. I have no idea ano yung Bucky film.
Chest X-ray bonding is an important part of human body.
Yes, sir.
Oh, I think Bucky film is indicated if you're considering fractures, because that would actually focus on the bony parts of the chest. So if you're considering a fracture that can't be seen in a normal chest, you can actually request for a Bucky film.
So it's similar with the TKage, I think.
Correct.
It's just your X-ray that you use a Bucky stand. So tama si Sir Bok and si Dr. Rabet na it will allow you to delineate yung Bucky stand, kasi if you place your film on a Bucky stand, mas better ma-delineate yung bones in your film. So if you're considering a fracture, as they mentioned, so hindi yung just using your Bucky means you're using a special stand para mas makita lalo, maalis yung parang frame niya around the film, na makikita mo mas better yung bony structure. So as mentioned by Doctora, hindi siya routinely ginagawa during the primary survey. But if you're later on, if you're really considering or is highly suspicious of multiple fractures na hindi initially nakita, or yun yung purpose mo to look at the bony cage, then this is what you usually request for. So any questions pa po? Ayan. Should all pneumothorax undergo tube thoracostomy patient even if the patient is stable and asymptomatic? Probably we can reserve this
Yes,
question.
magandang question yan, Doc, pero mas magandang ma-discuss yan later.
Also, our chest, injuries to the chest already.
Yes.
So
excited na sila sa part mo, Doctor.
We'll just reserve. We will just answer your question, Dr. Sanggalang, after the we will ask. We have a very good panel of experts here. We have Sir Bok. We have I think Dr. Rico is still around, and Sir George, Dr. Jade, Sir Jay Pusong. So they will help us answer all your questions later on. So you will hear from the experts. So any more questions for Beth before we let her rest? Sorry, we should thank her kasi masakit talaga yung ulo ni Beth, but she still managed to give us a lecture. Thank you so much, Beth.
Stay naman, Doc. Thank you, Doc.
Any more questions po? If none, well, you can probably type them while I start to share my screen, if okay lang, Beth.
Yes, Doc. Thank you.
Ma'am Michelle, can you see my slides po?
Wala po siya, doktora.
Yan.
Yan, okay na po.
Okay, so before we start, I would like to pose this question to the experts here in the room. No, Sir George, are you online po? Probably not. Sir Vok, sorry sir.
Yes,
Sir, meron po kasing question dito regarding open book pelvic fractures. Do you routinely use urethral catheterization po?
Of course not. You should not attempt urethral catheterization in any pelvic fracture unless you're sure that the urethra is intact. I think the best way to rule that out is to do a retrograde urethrogram. Of course, there are telltale signs of urethral injury and na-enumerate naman ni Beth lahat yun. Ano? And just an update, alam mo naman ito ay yung high-lying prostate is not one of them. Diba? Parang hindi na siya kasama based on sa new ATLS. So, blood in the urethral meatus, perineal hematoma are just some of the signs that you need to look for. Of course, in the absence of that, doesn't mean there's no urethral injury. So ako, that's a no-no to put a urethral catheter unless you perform retrograde urethrogram first.
Okay, thank you, sir. So I hope that answered the question of one of our participants. Yung for the other questions, we will try to answer, especially sa pneumothorax when we go to your chest injuries already. Thank you, Sir Bok. So let's start with penetrating neck and then chest, and then we go down to the back. So you're already done with your penetrating abdomen lectures a while ago with Dr. Rico. Okay, so why study and discuss these penetrating injuries to the neck? Again, we have a lot of structures that we need to be careful with and we need to think of when we consider penetrating injuries to the neck. You have your great vessels, you have your trachea, you have your esophagus, as well as your thyroid and your nervous system. So it's all there. That's why it's quite important that we evaluate the penetrating injuries to the neck properly so that we won't miss anything. So again, it's the anatomy of the neck is really unique because all these vital structures that I have mentioned, they're confined in this small space. Now, for our purposes, we divide the neck into different zones for better evaluation, and we use this delineation po, ano? So we divide the neck into 3 zones, and as shown in the PowerPoint. And zone 1 extends from the clavicle to the sternal notch. And then, well, your zone 2, ito po siya lahat. So from your clavicle up to the angle of the mandible. And zone 3 covers the area from the angle of the mandible to the base of the skull. So, so hanggang dito lang po yung zone 1, clavicle to here. And then all the rest from your sternum up to your angle of the mandible, that's our zone 2. That's where as general surgeons, we have to be very familiar with kasi dyan yung maraming structures in that area. Dapat competency natin to be able to manage penetrating neck injuries. Now, according to the study done by one of the trauma grades, 83% of the injuries that are sustained in the neck are located in zone 2. and 15% for zone 1, and then a small percentage belongs or are attributed to injuries to zone 3. Now we can divide your SEM rather divides your neck to form your two big triangles. You have the anterior as well as your posterior triangle, and the back of the neck that we loosely know as the nape is composed of muscles in the cervical spinal cord. So for our purposes, we don't consider the back of the neck having any zones. So the back of the neck is defined as posterior to the posterior triangle. So always remember this, ang nape is posterior to the posterior triangle, and we don't consider it to have zones, but your anterior and posterior triangle, we can allocate the zoning or use the zoning for evaluation purposes, but beyond that, sa likod, we don't have zones anymore. Now, it's quite important to understand. So if you notice best lectures, we present studies, landmark studies that help shape the guidelines that PCS is using for trauma, so that we will be able to understand na yung best ay evidence-based and papers were considered, and how the algorithms evolve after considering the studies in the different injuries. So for our penetrating neck, let's look at how the management evolved. So from a historical perspective, so before, the 1960s up to the present is known as the era of selective management. So hindi na siya mandatory surgery for all injuries to the neck. So usually we take into consideration the physical exam, and this includes your signs and symptoms pertaining to bleeding, as well as to your aerodigestive tract. Because before the 1960s, the tendency was to explore all. So, and then eventually nag-evolve po yung management, and then in the 90s, early 1990s, so ang goal, ang parang trigger nila to do neck exploration, from a mandatory neck exploration, they looked at the studies and said na baka sobrang dami naman ng negative exploration, incurring more morbidity. So what if we set an indication when to explore? So the indication that they set at that time was platysmal penetration. So it's if there's a break in the platysma, then that's the time they explore. So parang hindi na sila explore all, but now they only explore when there's platysmal penetration. And then they looked at the studies kung anong impact. So based on this indication, to explore based on platysmal penetration, studies have shown na mataas. So you have a high rate of negative exploration, as high as 60%. The morbidity rate is quite high, 25 to 50%. Parang hindi na masyadong acceptable yung 50% morbidity rate. There's increased length of hospital stay as well as higher hospital costs. So they figured that there must be a better way, a better indication, a better trigger for neck exploration to avoid all these negative outcomes from the morbidity to negative exploration to higher costs. So probably there's a better way of doing these things para mas better yung outcomes for our patients. And then they started to look into the hard and soft signs. So this is what we presently use now po, looking into the hard and soft signs. And later we will dissect what we mean by hard and soft signs. Now, hard signs usually pertain to vascular injury. This would entail active and or profuse, persistent and ongoing bleeding, pulsatile hematomas, expanding or a huge expanded hematomas, if you have absence of your carotid pulse, bruits and thrills, and you have central neurologic deficit, hemiplegia, hemiparesis, aphasia, and coma, that usually would tell you that there's compromise in your carotid artery because of the stroke symptoms or manifestations. And the question is that how about for, sorry, let me go back to that. So yun yung kinonsider nila na hard signs. Mostly, they belong to vascular, or they would point to a vascular injury. So what about the following signs? No, yung air bubbling from the wound, stridor, pneumomediastinum, pharyngeal blood, hemoptysis, hoarseness, subcutaneous emphysema, odynophagia, dysphagia. So most of these signs are pertaining to the aerodigestive tract. So do we still consider them as a hard sign? Yan. So side-by-side list of your signs and symptoms for penetrating neck injury. So as you can see, natali dyan or natabulate that for the bleeding pertaining to a possible carotid or vessel injury, yun yung kina-consider na hard signs. Now, for those that pertain to an aerodigestive tract injury are considered as soft signs. So for why is this important that we try to differentiate? Because for hard signs, the management will be more aggressive because our aim is to control the bleeding. Whereas for soft signs, since hindi naman bleeding yung problem, then we can probably do our workups if there is indeed an injury. The question is, as mentioned before, for hard signs, this would entail immediate operation. Kasi gusto mo nang ma-stop yung bleeding because the signs that you get are pertaining to a vascular injury. Also, when you have hemodynamic instability, then this is our ticket to immediate operation, as well as your impaled foreign objects, such as shown in the picture, kasi hindi po tayo encouraged from the previous lectures to remove impaled foreign objects unless it's in a controlled environment like the OR, for example. So, kung wala naman pong hard signs, ibig sabihin we're dealing with the soft signs here, then we can probably safely work the patient up. So what workups do we usually request? These include your x-rays, your cervical films for gunshot wounds, your scopes, your rigid and flexible esophagoscopy, as well as your contrast swallows, and of course the gold standard to check for vessel integrity is your arteriography or your angiography. But the color flow duplex can suffice if wala po tayong angiography or arteriography, with the following sensitivity and specificity shown in the slide. Also, you can request for a CT scan of your neck if we're only dealing with soft signs. Again, our indication to immediately go in is if we have hard signs pertaining to vascular injuries, we have hemodynamic instability, and may penetrating, or there's a foreign body that is lodged in the neck. Now, for soft signs naman pertaining to your aerodigestive tract injuries, we can do our workup. Hindi natin siya agad-agad dalhin sa OR for neck exploration. So what's controversial is air bubbling from the wound, and this usually points to a tracheal injury. Naka-open na yung naglaslas sa leeg, you can already see your trachea, you can see air bubbling from the wound or yung mga midline neck penetrating injuries. Would we opt to immediately go to the OR kasi para to repair the trachea? ang consensus from the experts in the panel when this lecture was given is that if you're very comfortable, no, ang dami mo ng neck exploration, ang dami mo ng nagawang neck surgeries, then probably pag sobrang stellar ka na, then probably pwede siguro, but if you're not very comfortable with doing the neck exploration, then it's better to do your workups first, so that you will have a more directed approach. So kung negative yung workups mo, then you can go up, bring the patient up to the OR and repair your trachea. So again, if for tracheal injuries, if you're very comfortable, if you've done a lot of neck explorations, then you might as well bring the patient up right away to repair the tracheal injury. But if you're not very comfortable in doing the neck exploration, then it's better to do your workups. Para pag inakit mo na siya, alam mo na kung saan pa yung ibang injuries aside from the trachea, then your surgery will be more precise because you know where you are going, you know which structures to repair. Kasi if you're not comfortable with doing neck exploration, a lot of studies have shown na mas madaming ma-incur na morbidity from iatrogenic injuries. Again, as mentioned earlier, your neck contains a lot of important structures. And for pag we're dealing with trauma, hindi masyadong clear na yung anatomy because you have hematomas, you have distorted anatomy already. That's why if working up the patient can help you make a more directed neck exploration, then by all means do so, as long as your patient is stable. And very important to secure the airway. Kasi baka mag-toxic yung patient habang wino-work up because hindi na secure yung airway with a tracheal injury. Now, why is this backed by, let's look at studies that backs up our guidelines. So this landmark paper examined at least 1,000 penetrating neck injuries. And 4.6% of all these neck injuries that they looked into, merong aerodigestive injuries. Now, this is important. You have to listen to this very carefully. 15% of patients with aerodigestive tract injuries presented, or 15% of these patients who presented with the soft signs, proved to have injuries on neck exploration. Ibig sabihin, even if may symptoms yung pasyente, only 15% have injuries on neck exploration. This means sobrang taas. 85% have negative exploration rate. And you have to think of it, no? Meron na nga silang signs and symptoms pertaining to a possible aerodigestive tract injury, but on exploration, walang nakitang injury. So again, we have to take all these soft signs with a grain of salt. We have to use our clinical judgment and do our workups because we don't want to end up with a very high 85% negative exploration rate and an even higher rate of morbidity and prolonging the patient's hospital stay. So ayaw natin yung negative exploration rate, especially on the neck. Now, this is another landmark paper looking into patients with pharyngeal injuries. And the conclusion is that patients with pharyngeal injuries can be managed non-operatively. So for stab wounds na nakita ninyo, pharyngeal yung injury, then you may opt not to do any suturing in your pharyngeal injury. So again, this is another landmark study looking into pharyngeal injury. So they concluded that if your injury is above the arytenoid, later on, let's look for that arytenoid, then these injuries can be managed non-operatively with a lot of success. And if below, we treat it already as an esophageal injury. So ayaw naman natin mag-conservatize ng ng esophageal injury because of all the morbidity rates. So again, we remember, no, ang landmark natin to say if we can conservatively manage a pharyngeal injury is the arytenoid. Above the arytenoid, we can manage non-operatively. Below the arytenoid, then that's the time we treat them as esophageal injuries and manage surgically because of the late complications and morbidities if we miss those types of injuries. See, there's no room to conservatize esophageal injury because of the very high morbidity rate. So again, we try to decide, no, when we see our injuries. Kung above the arytenoid, we don't need to do anything. Pag below it, we consider it an esophageal injury and then do our surgical intervention. Why? Because we don't want to manage esophageal injuries non-operatively because of a very high morbidity rate of around 74%. Now, this is another landmark study involving 405 patients with penetrating neck injuries. Half of the patients have injury in the cervical esophagus. 1/3 had injuries in the thoracic esophagus, and then followed by the abdominal esophagus. So 27 patients in the study died in the ER or at the OR, and then half of the patients underwent neck exploration by virtue of 87 of them having hard signs and 114 of them did not have hard signs, but they all went through neck exploration. So let's see what happened. So this table shows you the result of that study na pinapakita yung esophageal related morbidities. Again, going back to the study, mas marami talaga yung injuries, no? Half of the patients reported in this study had injuries in the cervical esophagus. So let's see what happened, no? For those who underwent immediate exploration, yung infection between the two groups, the ones who underwent immediate operation, but this is for let's remember that this is for esophageal injuries. So yung wound infection for both, no, yung naoperahan kaagad and na workup is not statistically significant. For fistula, not statistically significant as well. But if you look at mediastinitis, medyo mataas masyado yung rate for those na na-work up muna when there's a consideration of esophageal injury as opposed to immediate operation. So what does this mean? It means that if there's delay, significant delay in esophageal injury, then based on this study, no, around 13 hours, nag-increase yung morbidity. So for centers practicing selective management, so dapat mabilis tayong gumalaw because we want to rule out the presence of an esophageal injury so that we can do our definitive repairs earlier and prevent the morbidity or the delays causing morbidity as part of the outcomes for our patients. So again, for esophageal injuries, we want to look for them as soon as possible and do our definitive repair para po hindi siya maging morbidity. So that's how we ought to manage our esophageal injuries. So again, for neck injuries, dapat mabilis tayong gumalaw. Kung walang hard signs, work up kaagad so that we can detect the significant injuries. And then especially for the esophagus, we can make our definitive repairs earlier. So this should be made as a priority. Another landmark paper including for moving on naman to vascular injuries. Now, this is another landmark paper involving almost 500 patients penetrating injuries to the carotid. So most of them gunshot wounds, no, and then followed by stab wounds, and then in the carotid artery, and then 0.5% is attributed to vertebral artery injuries. So anong what else can we get from the study? No? So again, most of the injuries are from the carotid, and then most of these injuries, 10% of the injuries are gunshot wounds. So kailangan din talaga natin ma-rule out ang vascular injuries in the neck, especially the carotid vessel. So do we routinely use arteriography, no? Or do we have to request it for all our patients, especially those with zone 1 injury to the neck? Compared to your zone 2, na nakikita mo if there's a huge expanding hematoma, or you can feel the crepitations, or your patient can tell you kung masakit mo lumanok, or you can feel the subcutaneous emphysema. For zone 1, it's quite difficult to directly do your physical examination, especially for the vascular structures in zone 1. So nandun yung great vessels nyo. And kailangan din natin i-plan because you want to have better visualization of the great vessel. So kailangan natin i-plano how do we surgically approach the injury, no? And mataas yung mortality for zone 1 injuries. So in this study by Eddie et al., they had 21 patients with zone 1 injury with normal PE and normal X-ray. And they also did arteriography. So no abnormal findings on all patients, and none developed sequelae after 3 months after follow-up. So is it really mandatory to require all patients with zone 1 injury to the neck to do arteriography if you have normal PE and chest X-ray? So yun yung question, no? So let's look at another study. So you have continued experience. This study is on the penetrating injury naman of zone 2 neck injury. So let's look at, they had for 145 cases, 31 had hard signs. So inakyat na agad to sa OR with 28 of those 31 patients having major arterial and or venous injuries. 114 did not have hard signs. So since wala silang hard signs, arteriography was requested, and let's see what the results are. So yung isa na operahan without complications, 91% of the patients were observed for a week and followed up for 2 months. And then the missed injury rate with PE was 0.7%, which is comparable to arteriogram in accuracy but less costly and non-invasive. Ibig sabihin, for zone 2 patients, we can safely use the hard signs as an indication of whether to open up our patient or not, or to detect if there is a vascular injury. Kasi nga, it has a very low missed injury rate with PE. And yung accuracy ng PE ninyo, especially if marami na kayong penetrating neck injuries na nakita, is comparable to arteriography and less costly, and of course non-invasive, especially kung nasa government hospitals ka, medyo limited yung resources. But for zone 1, as mentioned earlier, mahirap ma-PE yung zone 1. That is why the standard, or the what we want to request for when gusto natin i-work up is an angiography or an arteriography. So this is another study looking at major vascular injuries at the base of the neck. So we're looking into zone 3 already. So it's a review of retrospective review. They had 146 patients with normal PE and X-ray. So titingnan natin kung sa zone 3, our PE and X-ray will suffice. So none of the patients had arterial injury after 6 months of follow-up. Yeah, so probably we can for this injuries not at the base of the neck, it's quite difficult to rule out an injury without even a good follow-up and without workup. So even if a normal PE and X-ray will not necessarily mean na walang injury, especially for the base of the neck. But yung 36 na normal yung PE and X-ray, walang injuries after the 6 month of follow-up. But then again, you still have to contend with the rest of the patients that underwent further workups and with major injuries or arterial injuries as well. So what do we usually use? What do we usually do when we encounter major vascular injuries, no, such as carotid artery injury? Do we repair or ligate? So what are the recommendations in the studies? If you have a normal, for patients with normal neuro exam, or you have mild neurodeficits such as weakness of your upper and lower extremities, or for those patients with severe neurodeficits such as aphasia or hemiplegia, patients in coma, or patients with indeterminate neurostatus because they are in shock or they have probably a concomitant traumatic brain injury, what is the recommendation? So for all these types of patients, outcomes are always better if we do primary repair and revascularization, except for patients already in coma. Kasi itong mga pasyenteng to, I guess they're too far gone. Even if you ligate, wala nang consequences kasi your patient is already in coma. But for the rest of the patients, our goal is to always repair and revascularize for better outcomes. Now, how do we approach penetrating neck injury? So, hindi siya dito lang magpe-prep because we can be using the saphenous vein, no, to use as grafts, especially kung malaki yung defect, hindi natin magawa yung primary repair. So, we have to prep from the face down to the thighs. Hoping that if kailangan natin mag-harvest ng graft, hindi na tayo magre-redrape because syempre trauma yung surgery natin. Ayaw natin ng mga unnecessary delays. Again, when we try to prep and drape, we prep from the face down to the thigh para madali na lahat, hindi na natin siya i-prep or drape. Again, kasama lahat from the chest, the abdomen, i-prep na natin yan para hindi tayo mahirapan when we need to harvest the vein for grafting. Now, how do we position the head of the patient? It's usually extended and rotated away from the injured side. And the incision is made along the anterior border of the SCM as shown in the figure. Yan. Now, for bilateral injuries, no, or you have a through and through na sa penetrating neck, na sa lateral side yung entry, and then nag-cross ng midline, then we can do your collar incision for such injuries. Now, again, airway, if needed, should be secured early, because expanding hematomas can rapidly occlude the airway. So for patients na that we are considering a vascular injury, that we need to, especially if you have a huge expanded hematoma or a rapidly expanding hematoma, again, when we manage these patients, we go through our primary survey first. And then it's more prudent to secure the airway early kasi baka habang tinatakbon yung pasyente to the OR, nag-expand ng husto yung hematoma, na-compress yung airway, and then your patient becomes compromised na kasi wala na siyang airway. Now, we don't really want to put NGTs during the primary survey kasi it may cause retching and may result to active hemorrhage. So sana ilalagay natin siya at the OR already when the patient is placed under GA. So I remember patient referred to me na wala pa silang nakitang neck hematoma at the ER level, so they were able to insert the NGT, and nung nasukan na yung pasyente, biglang parang nag-bull neck. So lumaki yung leg. So again, as much as possible, especially if we're highly considering we're looking at a hard sign or considering a vascular injury, then it's better to insert our NGTs at the OR already pag tulog na yung pasyente. Now, cricothyroidotomy, ano bang, what's our stand on this? As much as possible, we want to secure the airway via your endotracheal tube. We don't want to proceed right away with the surgical airway, as this may be dangerous because once you open and violate the fascia containing the hematoma, pwedeng magdugo na yung pasyente. So we don't want to perform cricothyroidotomies left and right, especially when we are dealing with penetrating injuries to the neck, because nakakontain na yung hematoma eh. Mas gusto natin buksan pag nasa OR na tayo, we already have our proximal and distal controls in place before we open up the hematoma and look for where it is bleeding. We don't want to do blind clamping and or probing because it is considered a mortal sin in trauma. So if for example, nalaslas yung leg, you can see the structures, or you may not see the structures kasi maraming subcutaneous tissue. Again, we don't encourage you to do your blind clamping and or probing. So wait for the patient to be brought to the OR, and then we try to look for the bleeding in a more controlled and safer environment for the patient. Again, in summary, as mentioned by one of the pillars of trauma management for patients na walang hard signs, don't be afraid to do your selective management and have faith on using your multiple diagnostic tests. Again, these are for patients with no hard signs. Pag may hard signs, wala na masyadong argument pa on this, then we need to do our operation, immediate operation right away, as mentioned kanina sa earlier part. Yung patients with hard signs, patients with hemodynamic instability, and patients with impaled foreign objects, wala na tayong pag-uusapan pa. We bring these patients up to the OR for surgical management right away. But for those who present with soft signs, again, we can safely use our conservative management and do our multiple diagnostic studies. Again, I would like to quote one of the studies that made this lecture or the guidelines one of the basis for the guidelines is that even with all the soft signs, 85% of these patients still presented with a negative exploration rate. Imagine that. Sobrang taas ng negative exploration rate for patients who presented with soft signs. So again, meron talagang room to do our diagnostic studies if we are just dealing with soft signs, so that we won't have to contend or deal with negative exploration rates, high morbidity rates, as well as prolonged hospital stay. So any questions for our penetrating neck injuries? I'll just try to look into the chat box now. So the question is, how about the CT scan of the neck with IV and oral contrast in soft signs? So again, we are in the process of updating the best guidelines. Scans of the neck and with contrast can also be very useful, especially in soft signs, because maganda na kasi yung we all have the benefit of having CT scans na kasi na lot of our hospitals, no? So the CT scan of the neck with IV contrast affords a higher sensitivity and specificity compared to your Doppler or your duplex scan of the great vessels of the neck. So if you have this in your hospital, then by all means you can do this. Yung suggested workups kasi in this algorithm or this guideline mas oriented towards resource depleted situations or ano no, kaya mas cheaper kasi yung scans, yung duplex scans compared to your CT scan with the IV contrast. For the oral contrast, no, if you look into studies, for oral contrast alone, meron pa ring missed injury rate. For esophagoscopy, you can also have a missed injury rate. But if you combine your oral contrast and esophagoscopy, the missed injury rate goes to very low, no, even less than 1%. So kung mag-work up ka, and you want to eliminate all the possibility of having this missed injury, together with your oral contrast studies, then if your hospital is capable of doing the esophagoscopy, then it's better to request them together para wala po talaga tayong ma-miss na injury. Kasi nga, if you combine the two modalities together, then the missed injury rate goes to as low as less than 1%. But kung ano yung meron tayo sa hospital, pag may limitations, then that's the best workup that we have. Kasi kung ano yung meron tayo, mas better na yun kaysa sa walang workup at all, especially for soft signs. So the next is, should an ENT and TCVS be also involved? Of course. As mentioned earlier, no, although in the zone 2, kumbaga, ang sabi nga ng mga boss, territory siya ng GS. Ibig sabihin, it doesn't mean we will not ask for help, no? But we should at least be comfortable with exploring the zone 2, or at least have a semblance of may alam tayo on how to deal with penetrating injuries in the zone 2, kasi more or less yan yung territory natin kasi meron naman tayong mga head and neck surgeries. TCVS, yes, really need them, especially for the zone 1, kasi nga exposure is very important. We need to expose the great vessels, no, the great vessels in your zone 1, and we might need to use the sternal saw, or most of the time we have to use the sternal saw for better exposure. And we need the help also of TCVS as well, especially kung hindi kayo usually or comfortable doing your or hindi tayo masyadong comfortable with exploring especially the great vessels in the zone 1. Kasi kailangan natin unang-una ng sternal saw, and malalaki yung vessels doon eh. So hindi pa tayo masyadong comfortable with doing our repairs or managing or handling our proximal and distal control in that area, especially that area, zone 1, then a referral to TCVS is warranted. For zone 3 naman,
sorry.
Also, yes.
Dok, hindi yata nakikita yung slides.
Talaga? For all the lecture? For the entire lecture?
I think just ngayon lang, yung arrow nakikita.
Wala talaga siya kasi end na siya.
Okay.
So, ayan, wala talaga siyang nakalagay dapat na slide. So again, for zone 1, call your TCVS friends, but ang important is the approach. You can probably, depending on the trajectory of the injury, you can probably combine your incisions, and then diretso siya to account for or to accommodate your median sternotomy for zone 1 vascular injuries. For zone 3, we need the help of NSS, lalo na pagka papunta na tayo sa base of the skull. But yung approach as well is dapat alam natin, competency natin as GS, kung how do you approach, like your you have to dislocate your mandible to be able to get in and look for the bleeding in that area. And you might you will be needing the help of NSS. But for zone 2, dapat very comfortable tayo with that. That's why we're doing all this workup so that selective yung approach natin. We don't have a high negative exploration rate, and directed. Kung alam na natin kasi yung injuries, mas directed yung approach natin kasi alam na natin kung anong hahanapin. Yun. So, again, for trauma, no, kailangan, of course, we need the help of the other services. Hindi naman tayo, no man is an island. The more inputs ng subspecialty, especially for areas where we're not very comfortable with, syempre, mas maganda yon, especially with the help of TCVS. But ang importante is, you know the approach, you know where to make the incisions and which services to call, as well as the diagnostics to request for when we are dealing with penetrating injuries to the neck. So any more questions? So I guess wala nang. Anyway, if you have any more questions, you can just type them in the chat box, and then we'll try to address them later on kung meron pa kayong naisip. Again, what's important in penetrating injuries to the neck is, number 1, be familiar with your zones. Pag zone 1 na kagad, then call your alert your TCVS already for the possibility of having to open the sternum. Or if sa zone 3, then alert your NSS because you will need help in accessing the base of the skull. Now, and then we assess kung meron bang hard and soft signs. For hard signs, pag meron ka ng plus hemodynamic instability and or an impaled foreign object, then that's your ticket to immediate exploration. But if you have soft signs, again, we don't want that very high negative exploration rate. So work up. What you will need to work up are, 1, the great vessels. So if you have angiography, arteriography, CT scan with IV contrast, then great, kasi they are more sensitive and specific to locating injuries in the vascular, in your carotid and your jugular vein. If for workup of your esophagus, you can do your esophagoscopy as well as your contrast swallow. Again, they're better together. If we combine them, then the chances of missing an injury is even lower. Again, we don't want to miss injuries in the esophagus, remember, because of that 74% morbidity rate. So medyo priority natin next to the bleeding or the great vessels to look for that injury in the esophagus. Again, by combining your esophagoscopy and your swallow, you will decrease the missed injury rate to even less than 1%. So they're much better if we request them together. And for the rest of for the management of your injuries, especially for trachea, midline injuries, you see bubbling from the wound, you ask yourself, am I confident with doing my neck exploration? So if the answer is yes, sobrang dami mo nang na neck explore, very confident ka with doing your neck exploration, then you can probably bring this patient up right away to repair the trachea. But if hindi ka confident, hindi ka ganun kadami yung volume of penetrating neck injuries in your area or in your institution, then it's safer to just secure the airway first and then proceed with your workup. That way, when you bring this patient up to the OR for repair of your trachea, dun ka na lang mag-concentrate. Hindi mo na kailangan pakialaman pa yung structures to check whether they have an injury or not. So that, yes, for esophagoscopy, it was mentioned in the slides earlier that you can either use a flexible or a rigid scope. Kung ano yung meron kayo in your institution, whether it be a flexible or rigid scope, then you can use either. So you can still type your questions while I will try to present the next lecture. Okay, so the next topic that we will discuss, so this is the second to the last topic na po, no? For this best workshop, we don't actually have, we removed some of the lectures na sa tingin namin hindi na masyadong useful at this point because one of our main purposes ay ma-review po tayo sa inyong upcoming or exams, na especially your RITE as well as your what do you call this, your CERES exam. So before we move on, I'll just address this question in the chat box. Can chest CT contrast substitute for aortogram for zone 1 injuries? Again, if you examine the sensitivity and specificity, syempre the gold standard is your aortogram. If you want to do your chest CT with contrast, then include the neck. So neck and chest CT with IV contrast, you will have a better picture of all the structures that you will be interested in, especially because you're looking for great vessel injuries. And a lot of studies mentioned na kasi yung penetrating injuries, hindi naman siya parang iba yung entry, iba yung exit, pwedeng combine zone 1, zone 2, hindi siya nagbe-behave in a particular manner na maraming patterns of injury. So if to get a better view, kung combined or nagko-cross siya ng different zones, and then better to have a complete picture of the vasculature of the neck. So next is the so bababa na po tayo na from the neck, we go to the chest, and then lastly the back. So last na po natin yung back. Now, at the end of the session, we want you to understand and manage the lethal conditions in the penetrating chest injury and define an optimal diagnostic strategy and appropriate management or treatment plans for patients that we suspect of having cardiac injury. So like your other best modules, let's start off with the case. You have a 25-year-old male stab wound on the 5th ICS, mid-clavicular line with the following vital signs and the following PE. And then you have your chest X-ray showing no significant chest findings. So how do we define the chest for trauma? So this, if you look at the picture shown before you, ito po yung nagko-comprise ng what we call as, what we define as chest in trauma. So again, you can see that it includes your right and your left, your clavicle down, your subcostal margins, and this includes your heart. So this is what we refer to as chest when we talk about chest injuries for trauma. And we all know the physiology already, so we will not dwell into that. But let's look at the potentially, or we call this the big three, the deadly triad of chest injuries in trauma. And this would include your na-mention na rin kanina ni Beth and your other lecturers, include your tension, your massive, and your cardiac tamponade. Because if you don't address them, actually dapat sa primary survey na medyo nadidetect na natin sila. Because what's unique about trauma is as you go along your initial assessment, pag may nakita po tayo na injuries, kailangan i-address na natin kaagad. We don't wait for a complete diagnosis before we do something about it. Especially, after airway, next would be your breathing and ventilation. And this is where your potentially lethal conditions come in. And once you recognize them, we try to manage them as soon as possible. So I'm not sure if this video will play. Well, hindi siya ma-play. So anyway, tension pneumothorax is a serious complication that can develop. So pwedeng from a simple pneumothorax, naging tension pneumothorax siya eventually. So sometimes, especially for blunt or a very large penetrating or an open chest wound, it will slowly creep up on you. So pwede tayong na okay po yung patient, may blunt trauma to the chest, tapos later on biglang nag-tension pneumothorax. So it can develop with any pneumothorax. So what happens in tension pneumothorax? Because of the injury, and this will result to a lot of air inside your chest, and eventually it will lead to the collapse of your lung because of that pressure in the chest. And then the pressure will push your structures to the other side, causing your tracheal shift because you're dealing with a lot of air, hyperresonantia if you do your percussion. But I don't think a lot of the residents still do the percussion, especially since maingay sa ER. Yun. So what happens? Because of this pressure, mahirapan umakyat yung blood from the IVC. Kasi mataas nga yung pressure sa intrathoracic pressure. And therefore, wala nang ipapump out yung heart mo palabas. Kasi nga mahirapang pumasok yung blood into the heart from the IVC because of this great intrathoracic pressure, great enough to push your mediastinal structures to the other side and collapse your lung. Now, again, we get all these consequences because of your decreased cardiac output. Yan. And this will lead to hypotension. So ito yung mini-mention kanina ni Sir Ray na obstructive type of shock. You're not actually dealing with blood loss causing hypotension, but the obstructive type of shock. Yan. So this is a picture, an X-ray of a patient with a simple pneumothorax that could eventually progress to a tension pneumothorax. Now, we don't want to see X-rays of tension pneumothorax kasi probably this patient already died after X-ray. Kasi if you look at the X-ray, wala na talaga, na-push na yung structures to the other side. Again, as Beth mentioned, walang room for workup yung hypotensive patients. So before we try, when we're dealing already with tension pneumothorax, then the management, then we actually have to manage before anything else or moving on with our primary survey. So how do we manage our tension pneumothorax? Again, we'll just, the initial approach would be the second ICS of where the injury is. But if it doesn't work and your patient has very well developed pectoralis major muscles or probably of Caucasian, then your next area of choice, the next recommendation is your 4th to 5th ICS, anterior to mid-axillary line, kasi yan yung area where the muscle is thinnest, your auscultatory window, and mas manipis yung muscle dyan. So if you try to put in your needle, then medyo mas sure tayo that papasok siya, especially when we are sure or mataas talaga yung ating suspicion that we are dealing with a tension pneumothorax. Now, this slide, next we move on to the massive pneumothorax. So this slide tells you the areas kung saan pwedeng mag-bleed in the chest to cause such massive pneumothorax. So pwedeng sa rib, pwedeng sa lung, pwedeng sa intercostal vessels, pwedeng sa heart and the great vessels, pwedeng ang sa liver tapos pumasok lang doon. So especially if your injury is on the right side. For the left side, again, we have your aorta, your great vessels, your heart, pwede ring from the spleen if there's a break in the diaphragm and your injury is thoracoabdominal, pwede sa intercostal, sa lung parenchyma, as well as the rib fractures. So maraming pwedeng sources of pneumothorax in the chest. Again, for massive pneumothorax, the same pathophysiology applies, but we're dealing already with blood loss. So this time around, we will not be hearing hyperresonance or percussing hyperresonance kasi blood na yung laman So usually dull to percussion na siya, and you won't get to see your distended neck veins already. Why? Because you already have blood loss. So it's hypotension from blood loss, as you can see in this X-ray. And our initial management when we deal with massive hemothorax in the primary survey would be a closed tube thoracostomy to buy you time so you can run to the OR and do your definitive management, which is your thoracotomy, especially for massive hemothorax. Now, putting in your chest tube at the ER can allow for lung expansion, and lung expansion alone can augment the bleeding, or can stop the bleeding temporarily, and allow for decrease in the intrathoracic pressure para makaakyat yung dugo nyo to the IVC. But the definitive management will still be a thoracotomy, kung saan yung injury natin. Now, for massive hemothorax, you see in your books yung definition is 1.5. But for our guidelines, we consider massive hemothorax if we're dealing with 1 liter of blood already in the chest, or if you have your best manuals with you, now we look at the output, the succeeding outputs after the initial drainage, if it will constitute or it will account for a massive hemothorax. Now back to your diagram of the chest, no? So let's, now I'm trying to show you the boundaries of the cardiac box. So from the nipple to your clavicle to your subxiphoid area. So again, this is what we define for trauma as the cardiac box, and we say box because ipo-project natin siya sa likod po, hindi lang yung harap, hindi lang siya cardiac square, a cardiac rectangle, or one-dimensional lang. So try thinking of or projecting it 3-dimensionally to include yung sa likod, kasi even pwede kasing penetrating injury to the back pero pasok pa rin siya sa cardiac box. So again, try to imagine na 3D yung box ninyo hanggang sa likod. So ipo-project natin siya hanggang sa likod. So I will show you examples of injuries to the cardiac box, no? So you've already seen this picture earlier. So ito, pasok sa cardiac box, as well as yung stab sa likod. Because again, we try to project the box from the front to the back. Now, what's the normal volume of pericardial fluid? So mahirap kasi kayang tanungin kasi it's hard to get you to participate. But usually when we give this lecture, interactive siya dapat. So we get to ask the participants the normal volume of pericardial fluid, but it's just enough na walang friction rub or walang friction between your two structures. So pagka more than that, then it will cause restrictive or physiology, mahirapan yung cardiac filling, pag-pump out ng blood, and then therefore mag-decrease yung cardiac output. So para din siyang tension yung thorax na it's more of an obstructive type of shock. Mahirapan mag-pump yung heart ng blood because of your blood filling up the pericardium. So this will usually produce hypotension as well. Now, this is the algorithm that we use for PCS for how to manage penetrating injuries to the cardiac box or suspected cardiac injury. So first, we have a normotensive patient. So we define a normotensive patient having a systolic BP of 90 or above versus a hypotensive patient having a systolic BP of 90 or below millimeters per mercury. So with the two subsets of patients, anong kailangan natin gawin? Now, if your patient is normotensive, then you have the option to work up. Again, we're talking about normotensive patients with injuries inside the cardiac box. So, pa-X-ray po natin, followed by our pericardial ultrasound or a 2D echo. Now, kung wala naman tayong na-identify na injuries, then probably we can admit the patient and treat for other injuries as well. But if you have a positive pericardial ultrasound, then we try to to classify, no, kung sobrang dami ba ng fluid. If it's minimal, it's moderate and massive. If it's minimal, then the recommendation is to do your subxiphoid window. And then depending on the fluid that you get, no, kung blood siya, then we already need to proceed with thoracotomy. But if hindi, kasi why do this? No, because local studies have shown that we get a lot of TB fluid in the heart because TB is quite endemic in the Philippines. So kung minimal lang yung fluid, then do your subxiphoid window. If the fluid is serous, then you can snip up a small part of the pericardium instead and send for TB studies. If the output is blood, then we proceed outright with thoracotomy. But in the background of trauma, if you have if you have massive or moderate to massive fluid in your pericardium on pericardial ultrasound, then the next management would be proceeding with your thoracotomy already. Again, the indication only to do your subxiphoid window if your patient is normotensive and you have minimal fluid in your pericardial ultrasound. And then that's the time we do our subxiphoid window and a TB biopsy of the pericardium, a small piece of the pericardium. But if it's moderate to massive already, even with a normotensive patient, then it's blood until proven otherwise. So we proceed with thoracotomy, especially because our injury is in the cardiac box. Now, what if your patient is hypotensive? Then wala na po tayong pag-uusapan pa, no dilly-dallying in the ER, we proceed with thoracotomy. So what's the role of our pericardiocentesis sa mga ganong klaseng pasyente? Again, pericardiocentesis is not a diagnostic procedure for to tell you if there's an injury to the heart. Rather, it's a therapeutic measure that dapat na medyo na-clench mo na yung diagnosis of cardiac tamponade, and your pericardiocentesis is a therapeutic, para siyang needling, a therapeutic maneuver that can buy you time as you run to the OR to perform your thoracotomy. Again, yung purpose mo is na mabawasan yung fluid in the pericardium to allow for a better cardiac output at hindi mag-arrest yung pasyente. Again, it is not diagnostic na to-check mo, ay baka may tamponade, but rather it is a therapeutic procedure to help you buy time as you rush to the OR and bring this patient up for definitive surgical management. One thing to note about pericardiocentesis kasi, especially since marami ding studies na nagsasabi, if you don't have an ultrasound, you do it blindly, you don't know your landmarks, pwedeng iatrogenic, malacerate mo yung ventricle or dun ka mismo nakatusok sa ventricle. So may makukuha ka talagang blood kasi nasa loob ka ng ventricle. That's why, but if meron ka talagang tamponade to begin with, then this is a very useful therapeutic maneuver that can buy you time kasi you will be able to aspirate the tamponade and there will be improvement in your cardiac output. Again, let's summarize our algorithm for penetrating injury to the cardiac box. No, if you have a normotensive patient, you can opt to do your workup kasi normotensive yung pasyente mo, and these workups will include an X-ray and an ultrasound. If negative, then you can admit and treat further injuries or observe for 24 hours. If it's positive, you classify if you have minimal, moderate, or massive. So usually per hospital, they have a cutoff. No, yung radiology has a cutoff for telling you if it's minimal, moderate to massive. So it depends on the cut-off set by your radiology department. Now, again, kaya natin sila napapa-ultrasound kasi normotensive sila. If your fluid is just minimal, then go ahead and do a subxiphoid window. But if your radio tells you it's moderate to massive, then or your TCVS fellow, if they're with you, then we can proceed with an outright thoracotomy kasi there's a way of measuring the fluid kasi in the pericardium. Now, if your patient is hypotensive, then we go directly to the thoracotomy and you can opt to do your pericardiocentesis along the way, especially pagka medyo crashing na yung pasyente and you want to buy some time para maakyat pa yung pasyente, especially when you're dealing with an injury to the cardiac box. If again, hindi siya diagnostic therapeutic siya so that you'll be able to remove some of the tamponade and temporize na allow for better cardiac output habang tinatakbo natin yung pasyente to the OR. Now, paano if your patient is hypotensive, tapos you did some maneuvers, nag-resuscitate tayo ng fluid, and then the patient becomes normotensive. So, ikaw mismo when the patient arrived, ikaw yung nag-determine, ikaw yung nag-BP, kasi syempre cardiac box. So, dapat usually it's the resident, hindi natin inaasa yung BP sa interns. So, na-BP mo ay hypotensive siya, 80-60. And then your co-resident or you gave 500 cc's of crystalloid and then nag-improve yung BP to 90/60. What then will we do next? Pwede pa ba can we treat the patient as normotensive? Can we request for a diagnostic procedure such as an ultrasound? Can we proceed right away with subxiphoid window? Or diretso na ba tayo sa thoracotomy? So let's look at what our algorithm says. No? So the answer is to proceed directly with thoracotomy. Again, nag-hypotension na kasi siya. And based on the injury na napasok sa cardiac box, syempre mataas na yung index of suspicion natin. Nasa heart yung injury. Therefore, hindi na po tayo magtagal pa doing all these workups. Our algorithm says that we need to bring these patients up already for thoracotomy, especially since hypotensive sila initially and may yung injury nila ay nasa cardiac box. So pwedeng nakakompensate pa ang patient ng bahagya na naging normotensive, but it's safer to proceed right away with the thoracotomy rather than request for all your diagnostic procedures. Now, this slide will tell you na kung yung injury mo ay nasa left or nasa right, or kung marami kang injuries, ano yung compartment na bubuksan natin, no? Especially kung bilateral chest injuries, penetrating chest injuries. So like for example, ito, mas marami siyang tama sa right than yung tama niya sa left. So ano yung guide natin for us to say na, I'd open the left first, I'd open the right first, or median sternotomy will be better. Yan. So again, if your injury is on the left, then common sense tells us that we need to open on the left. If our injury is on the right, then we need to open on the right. Paano kung bilateral, no? As shown kanina, maraming tama, meron sa left and sa right. Then we try to open the left chest first. That way, pwede tayong makapag-aortic cross clamp to shunt the blood to our brain and heart, especially when our patient is crashing or hypotensive. And then, pag nakita natin na or do your or release the tamponade kasi most of your heart na naka-rotate siya, tapos doon siya naka-position most of the structures on the left side. Now, if pagbukas ninyo, very minimal bleeding, the heart looks okay, then extend na lang to the right. If bilateral yung chest injuries, kasi baka yung bleeding ay nasa my right side. So you can do your clamshell already. At this point, again, left side first kasi mas marami kang magagawa with the left and most of the structures of the heart are on the left. Pag wala doon yung bleeding, then you can use naman the left opening the left chest approach to do your aortic cross clamping or do your manual cardiac massage, and then you extend your incision up to the right to look for the bleeding. But this is given for bilateral chest injuries. So paano kung negative, naka-clamshell ka na, wala ka pa rin nakitang bleeding? Then that's the time to open the abdomen already. Kasi baka sa abdomen siya nag-bleed. Again, remember that if we have injuries below the nipple line, we should consider thoracoabdominal injuries already. So pag negative yung chest na nabuksan mo, then proceed with your XLAB. Now, this table just shows you ano yung usual na clinical set of findings when we are dealing with tension pneumothorax. Distended yung neck veins mo because it's an obstructive type of shock. Yes, you presented hypotension, of course, and you have decreased breath sounds, which is hyperresonant if you try to percuss because air is what's contained inside your chest. For massive pneumothorax, pwedeng hindi na distended yung neck veins kasi meron ka ng blood loss that's amounting to at least a liter. And you have hypotension already. And when you do your percussion, dull siya kasi blood yung laman, fluid. Yan. So now when you deal with tamponade, because of its restrictive or obstructive type of physiology causing your shock, distended yung neck veins, you present with hypotension, you have muffled heart sounds, or if hindi masyadong marinig yung heart sounds, if you have good breath sounds on your bilateral lungs, then chances are yung injury ay sa cardiac or you're dealing with a cardiac tamponade. So at this point, we will try to answer your questions if you have any. Yung question ni Dr. Sanggalang regarding pneumothorax, no? Should all pneumothorax undergo a tube thoracostomy placement even if the patient is stable and asymptomatic? Meron pa bang online po na panel, Sir George? Para hindi sila masawa sa akin. Dr. Wico? Yes, sir. Si Sir Bok na lang po.
Yeah, what's the question?
Should all pneumothorax, sir, I guess this involves penetrating or blunt, undergo tube thoracostomy placement even if the patient is stable and asymptomatic?
Well, the answer is not all pneumothorax should be addressed by putting in a tube. Alam naman natin, di ba, merong tayong criteria, sinabi niya na yung asymptomatic, di ba? Of course, the patient should be asymptomatic and it depends kung sino yung nagsasabi, but I think overall if it's less than 15% and on repeat X-ray 6 hours later the pneumothorax is not progressing, then that pneumothorax can be managed non-operatively. Of course, once the patient develop signs and symptoms of distress, then you might need to repeat the X-ray or you might need to put in a tube.
Irene, can I
Yes,
say
sir.
something?
Yes, sir. Go ahead po.
Yeah, I agree with Bok regarding the observations of patients with less than 15% pneumothorax. However, if this, I just want to reiterate that if this patient will be transferred to another facility, with let's say with especially the air transport, I would probably put in a chest tube because atmospheric changes might increase the pneumothorax of this patient. So better safe na malagyan ng chest tube yan in those kinds of situation. Thank you.
Yes, sir.
Buti nasagot ni Joseph kasi meron pang isa pala. When this patient will undergo an operation under general anesthesia, then the tube should be, you should put the chest tube kasi there's a big chance that this patient might develop tension pneumo.
Okay, so I hope that Dr. Sanggalang that answers your question. So as mentioned by Sir Bok, not all pneumothoraces warrant insertion of your tube, especially if your patient is stable and asymptomatic. But as mentioned by Sir Bok, if there's progression clinically or by radiograph, then it's safer to put in a tube. And as mentioned by Dr. Wico, if you're going to transfer this patient, especially kung air transfer, syempre may changes in altitude, which could alter your pneumothorax, so also put in a tube. Or kung ita-transfer mo siya sa ibang hospital, malayo, baka mag-develop ng tension later on, di ba mentioned in the lecture, pwedeng from a simple pneumothorax, mag-develop into tension. So safer to put in a tube. And lastly, yung point ni Sir Bok, if your patient has to undergo surgery for another indication, for example, kailangan niyang i-XLAP or a neurosurgical operation, and your patient has to undergo a positive pressure ventilation, then put in a chest tube. Okay, so the next question is, Dr. Wico, tawagin kita ha, since nandito ka naman. Sir, any experiences, sir, with your tube pericardiostomy, and when do you usually use it, sir, other than or more than, say, just you putting in or just doing your pericardiocentesis?
Thank you so much, Irene, for that question. Number one, before I answer that, regarding the pericardiocentesis that you mentioned, I agree with you that this is not a diagnostic, it is not for diagnosis. It is actually, like Irene had mentioned, that you have to be very, very sure that this is cardiac tamponade. Because when you put in your pericardiocentesis tube, the probability of hitting the myocardium is less, compared to just asking yourself if this is really cardiac tamponade. Now, for pericardial window, I usually follow still, and still as fellow, and up to now, I still follow the algorithm given by the PCS. Is that the question, Irene? Sorry, yung ba yung question mo?
Yes, sir. Kasi sabi niya, ano bang role ng tube pericardiostomy versus just doing your pericardiocentesis? Kailan siguro, ang ano niya siguro, sir, is kailan natin i-convert into a tube pericardiostomy if you have a cardiac tamponade after or before the pericardiocentesis?
Now, let's say if you did your let's say pericardiocentesis, even your pericardial window, I'll try to answer in that context. If there is blood, ang indication kagad din is to do a thoracotomy and try to repair it. Now, tube thoracostomy, the tube pericardiostomy, for that matter, actually ang experience namin dyan with working with the TCBS. The tube thoracostomy was usually inserted after the repair of the myocardium. After the repair, it was nilalagay nila yun. But for tube for pericardiostomy tube, naiiwan mo lang doon without a repair. For me, it's dangerous. So you need to repair it, by doing the subxiphoid pericardial window. If there's blood, that's already an indication for us to repair. That's already an indication, an indirect indication that there is already injury to the heart. Thank you.
Okay, thank you for that, sir. I'll call also Sir George to share his experiences with this pericardiocentesis and tube pericardiostomy. Sir George?
Hindi ako naka-respond dun sa ano mo.
Sorry, sir. Gusto kong i-tap yung inyong mga brain so that the residents can learn from you as well.
The question mo, diba, sabi nga natin, yung pericardiocentesis therapeutic dapat yung indication. That's basic, no? Yung issue ng ng subxiphoid pericardiostomy, yung question, pagka halimbawa hindi tayo capable of doing no? Yung 'di ba yung recommendation ultrasound guided yung yung pericardiocentesis para less yung injury, then subxiphoid pericardial window yung susunod na best option. Remember, meron kasing subset tayo ng patient due to TB pericarditis na pag akala natin secondary to trauma yung parang tamponad niya dahil merong fluid dun sa pericardium. Kung serous lang yung fluid, hindi siya blood, then definitely baka dun meron yung putting in tube pericardiostomy. But as Joseph stated, usually ginagamit siya post repair kung merong cardiac injury.
Okay, sir. Thank you po for that. Sir Bok, anything more to add, sir?
Yeah. If they actually listen to your lecture, yung limited indication ng pericardiosynthesis is reserved for hypotensive patients suspected to have cardiac tamponade. So, and I think kaya nilagay yung pericardiosynthesis niyan kasi siya yung pinakamabilis na gawin to evacuate the pericardium para mapataas mo yung BP while you're en route to the operating room. And I think you need the limited resources to do that. And you can actually do it at the ER setting. I think parang may confusion every time na po-pose itong question na to is about the medical tamponade. Medical tamponade kasi can be addressed two ways. Either you do pericardio or you do tube pericardiostomy. I don't think there's a role of tube pericardiostomy in a patient having tamponade. Pero nilalagay siya ng TCBS after a cardiac repair. That's what I know. But at the outset, I think nobody can beat pericardiosynthesis.
Okay, thank you for that, sir. So you've heard our experts, our panel of experts. First, the role of pericardiocentesis, and then when to put in our tube pericardiostomy. And now, I would also like to float this question. Let's ask Sir Dr. Rico first habang nandito siya. Sir, yung kanina we talked about pneumothorax, na pwedeng i-conservatize, especially if your patient is asymptomatic or stable. But for penetrating injuries naman, sir, na pneumothorax, and then our patient is stable and asymptomatic, how can we safely do conservative management, sir? And hindi ba tataas yung chance na magkaroon ng abscess, lalo na since penetrating siya and nagkaroon po ng pneumothorax? Dr. Rico?
Irene. Yeah, I always follow naman yung what the best mentions, that any form of pneumothorax, especially for penetrating, might develop or might end up this patient into from a stable patient to unstable patient having a tension pneumothorax. And with the you mentioned about the chances of infection, maybe antibiotic coverage. For me, I would put in a chest tube. Para sa akin, for me, that's already an indication for me to stabilize kagad yung patient kahit na asymptomatic pa siya, because there is this clinical pwede siyang mag-develop into attention pneumothorax later. So yun lang. Thank you.
Thank you, sir. How about you, Sir George? Minimal pneumothorax, sir, tapos stable and asymptomatic yung patient. Pwede ba may room ba siya natin, sir, i-conservatize po?
Penetrating, di ba? Kung penetrating kasi minimal pneumothorax, usually ako, I do agree na chest tube insertion. Remember, pwedeng hindi natin makita concomitant minimal hemothorax as well, and that's a good liability for infection. So remember, yung chest tube will be therapeutic, and then you will limit development of complication. Kasi mas malaking surgery yung kailangan pag nag-develop siya ng empyema compared to if you will be treating a penetrating chest injury outright with chest tube insertion. Thank you.
Okay, thank you for that, sir. Sir George. Sir Bok?
Yes,
So how about you, sir? Pag minimal hemothorax,
okay. So
symptomatic,
we answered the minimal pneumothorax
Okay.
earlier, no? So
Apo.
think of the indication for doing non-operative management of pneumo, and all of those are applicable here. Asymptomatic, minimal. Ang minimal kasi yung blunting ng costoprenic. Actually, yung TCBS sa amin is as much as 1/3, no? So, well, of course, you need to repeat the X-ray. The repeat X-ray should show na hindi nagpo-progress yung hemo. Otherwise, that's already an indication to put in a tube. Of course, yung mga binanggit din natin kanina na if the patient will be transported by, or should undergo a procedure that needs positive pressure ventilation, then you need to put. Medyo controversial kasi ang hemo, but even the division of trauma in PGH is 50-50, ano. But wag mo kami pag-away-awayan, ano. Pero of course, this is personal for me because if I'll put myself in that situation, I don't want a tube if I have a minimal hemo. And I think studies will show that the presence of hemo actually can really cause empyema, but I think the studies will also show that the most frequent cause of empyema is inserting a tube. So if you have a hemo there and then you insert a tube, then the empyema rate would be much, much higher. So if it's just blunting and on repeat X-ray it's not progressing and the patient is asymptomatic, I might opt not to put in a tube.
Okay, sir.
Irene, excuse me.
Yes po, sir.
I thought you said pneumothorax. Hemothorax pala, sabi mo. Sorry.
Ito na po, sir. Apo.
Hemothorax, my answer there is kung minimal, I would observe this patient. Kung stable.
Apo. Okay, so you've heard our experts, no? So some would advocate for putting in a tube. Sabi nga ni Sir George na you don't want the bigger surgery of having to deal with empyema if you have the chance of draining it right away at the ER. Especially siguro kung mas marami talaga or minimal to, basta as long as the hemothorax is present and you have concomitant pneumothorax as well. And yung some of our experts also say na well, if you have the luxury of repeating your workups and medyo stable naman and just give your antibiotic coverage, may or may not develop empyema. So parang watchful waiting, especially if we opt to do it non-operatively para we watch out for the development of empyema. So whether we put in a tube or not, the risk of the development of empyema will be there. So I guess it will be the clinical judgment that will come into play when we have these types of patients. You can either be aggressive and put your tube already, or you can wait for development or progression of symptoms, then put in your tube. So you can go different ways na when we try to manage. So pag ganon, then we assess the patient properly, and then kasi there are pros and cons for each route, no, whether you go aggressive at the onset or be conservative in putting in your tube. And you have to be just aware of the consequences na kailangan bantayan whether you go tube early or not. So I guess yun na lang po yung yun po muna yung questions that we need to answer for chest. So thank you, Sir George, Sir Bok, and Sir Joseph, our trauma experts. So hindi talaga natin papantayan ng kanilang experience. That's why they're here, not to help us out. So they have been handling trauma cases for a really long time. That's why their experience and their knowledge and their wisdom would really make a great difference sa pag-manage ng trauma patients. They're considered the pillars of trauma surgery in the Philippines. That's why you're very lucky that they're here and pwede natin ma-pick yung kanilang mga brains. So thank you very much, sirs, for your answer, for graciously answering our questions. So lastly, we will talk about penetrating injuries to the back. So our definition of back in trauma would mean that it is under the tip of the scapula, along your posterior axillary line, and the lower boundary would be your iliac crest. So ito yung definition natin ng back when we talk about trauma. And yung flank naman is, as you see in the picture, no? And the flank is usually considered po as part of the anterior abdomen in trauma. So yung back lang po na pag-uusapan natin na algorithm is just this area. For the flank, then we proceed with how we manage the anterior abdomen, penetrating injuries to the abdomen, as discussed by Dr. Huico earlier in the webinar. So let's start off with the case. You have a 22-year-old male who came in 1 hour post-injury after sustaining an injury to a stab wound to the back, with the following physical examination findings as well as your vital signs. So mukhang stable naman po yung pasyente natin na if you look at the vital signs. Now your abdomen is soft and non-tender, and you have your stab wound at the L1 level, left mid-scapular line with normal active bowel sounds. You have no blood on your rectal exam, with no gross hematuria, and with a normal chest X-ray. So what will we do next? So again, medyo mahirap to ask you guys to speak up kasi maraming Zoom participants, and I think you're not allowed access to the microphone. So when this lecture was presented, if I'm not mistaken, in one of the PSGS or PCS conventions, and they asked the participants po on what they will do. So majority of the surgeons who attended that convention would opt to admit and work up the patient, while a small minority would prefer to discharge. So the patient tells you na, Doc, meron po akong urinalysis in the previous hospital. Meron daw pong microscopic hematuria. So, and now that you have that information, what will you do next? So parang choose your own adventure ito. Will we discharge the patient knowing that the patient has microscopic hematuria? Should we do wound exploration? Or request for an IVP? So kanina nag-discuss si Beth, no, about the indications for doing your IVP. Or perhaps do an ultrasound. Or maybe request for a CT scan, no? Kung madaling mag-request ng CT scan sa hospital natin. Or how about the DPL? Or can we go to explore the patient right away, or just be happy with our PE and observation? So later on, as we continue our discussion, we will know what to do with this patient. So obviously, mukhang hindi muna natin talaga i-X-lap kasi medyo aggressive yung X-lap, since malambot naman yung tiyan ng pasyente natin. But let's see kung ano yung what's best to do. So when this question was floated, no, in that convention, as you can see, a lot of the majority of those who attended would do an IVP. So let's see. Let's move on with the case. Now that they wanted to do an IVP was done for this case, and it revealed extravasation of your dye. So as you can see in the picture po, no, nag-extravasate. Ito yung extravasation. So ito yung renal pelvis banda, as shown in your right and left. And then ito yung parang oblong structure here. That's your extravasation of your dye. So what will you do next? Your patient is stable, may microscopic hematuria. An IVP, may extravasation of the dye. So is this enough to compel us to open the patient up already? Should we observe or X-lap na ba, or request for a CT scan? So again, the most popular answer at this point, dahil nagkaroon na ng extravasation of contrast, is they wanted to explore the patient already. Fortunately for the patient, na CT scan muna siya bago yung Explore lab. And the CT scan revealed a grade 2 renal hematoma. And the PE remained stable. So even with an extravasation in IVP, sa CT scan, nakita nila ay it's just a grade 2 renal hematoma. And the patient is stable with the abdomen remaining soft and non-tender. So will we still proceed with the XLAP na kanina yun ang parang majority of the decision? So should we just continue our observation in serial PE? Do we need to repeat our abdominal CT scan, or should we explore this patient already via a lumbotomy incision, no? Or an Explore lab via midline incision, or we can safely discharge the patient? So again, the most popular answer at that time was to explore already. But let's see. So yun ang napagdesisyonan nila at that time, probably because they considered the IVP results na may extravasation of the dye. That's why yung decision nila was to do an XLAP, even when the CT scan tells you that it's just a grade 2 renal hematoma. So what should be the best answer? So let's now move on to our discussion. Again, let's look at the management of penetrating back injuries in a historical perspective. So let's look at landmark papers, no, that deal or that tells us what to do with penetrating back injuries. So all these papers before 1970, no, the tendency parang sa NET is to explore all penetrating, but this is for penetrating abdominal wounds. And they extended the indication to the back, no? So before 1970, pag nasaksak ka sa likod, diretso na mandatory exploration. Now, after that, merong nag-publish ng paper about this negative laparotomy rate for abdominal trauma. And it showed a very high negative exploration rate if the stab wound is to the back. So it's 70 to 89%. So imagine that nasaksak ka sa likod tapos negative naman yung Explore lab. So the question that they asked themselves back then was, pwede ba, can we avoid operations on these types of patients na nasaksak sa likod but the patient remains stable and the abdomen remains soft? So they revised their algorithm based on the studies that they conducted, and they opted to do selective management already for penetrating injuries to the back. Okay, so how about stab wounds to the back and flank? So they compared mandatory exploration with selective exploration, and they now factored in yung abdominal PE. So pag positive yung abdominal PE, they go with outright exploration. Siyempre, acute ab na kasi. But if negative yung abdominal PE, then they proceeded with exploring that penetrating injury to the back. And then when the exploration is negative, they observed. And when it's positive, they do DPL. So may tatlo silang dinagdag sa algorithm. Pag negative ang PE, then they do further maneuvers, no, such as wound exploration and DPL to check for abdominal injuries. But if it's already positive, then common sense will tell you na bubuksan mo na kasi nag-acute ab yung penetrating injury to the back. Yun. And then they had a study involving 109 patients. They followed this algorithm, and they found out that if you're out of the 109 patients, yung nag-positive sa PE, 32 had injuries. Now, for those na nag-negative sa PE, yung 33, they underwent wound exploration. So yung 33, walang nakita sa wound exploration, in-observe lang. Yung 76 patients nag-positive sa wound exploration, therefore they underwent DPL. So yung half sila. So 36 had negative DPL, tapos yung nag-positive DPL in-explore nila. So let's look at their injuries. So yung sa mandatory XLAP, so if you look at the gathered data, if yung sa mandatory side, no, lahat syempre mandatory So lahat sila na XLAP. So the negative EL rate is 85% kung mandatory XLAP. So 13% lang yung may positive EL, and the rest na 3% were observed. Now, if the selective management study if you look at the selective management study, di ba, 109 patients initially, only 40 were explored because of the algorithm that they used na yung positive, yung abdominal PE plus yung DPL and yung wound explore. So, ang baba ng negative EL. So, from 85, they were able to bring it down to 7% just by having this selective management and not operating on all the patients. So, in conclusion, pwede natin palang mapababa yung negative exploration rate by doing selective management. So, check na yun. Okay, selective management na tayo. Because no mortality or morbidities were seen in patients who underwent selective management. Therefore, the conclusion then was selective management is safe. Now, in the 1980s, they did more studies for the stab wounds. They looked at retrospectively the patients in USC. And they looked at 465 kasi sabi nila invasive kasi yung wound exploration in DPL. So are there diagnostic procedures that we can use that are non-invasive and will help us decide, especially since we are doing selective management. So for this study involving 465 patients, they used urinalysis and IVP. Pinalitan nila yung wound explore and DPL as both procedures were deemed invasive. Kasi selective management nga yung goal. So again, for positive penetrating injuries to the back who had negative abdominal PE, they opted to do urinalysis and instead of DPL, IVP ang pinalit nila. So let's look at the results. So 400 patients, 372 had negative urinalysis. So inobserve lang sila. 93 yung nag-positive, therefore sila yung na-IVP. And 33 had positive IVP results. And all 33 had renal injuries. No other associated injuries were mentioned. 5 yung na-delayed EL because of injuries to the colon, stomach, liver, and spleen. So what can we get from this study? So the use of invasive procedures such as wound explore and DPL should be questioned kasi selective management nga baka may option naman na not invasive but could augment the selective management algorithm for penetrating back injuries. So ang ginamit nila, urinalysis and IVP should be made routine for all patients with penetrating injury to the back. So na-revise na nila yung algorithm. Ito na yung ginamit instead of your DPL and your wound exploration. So let's see what happened. So after that, 2 papers came out on penetrating injuries to the back, as well as another one in South America. So all in all, with a combined patient of almost 100 plus. So if we look at the recommendation of both papers, all patients with gunshot wounds should have mandatory laparotomy. So dinagdagan nila yung algorithm na. So pagka gunshot, hindi stab, diretso na XLAP. So yan ang bago na dinagdag nila sa algorithm. So let's see what happened. So another study came out with 230 patients. So mas marami yung stab wound, 97%. Out of the 97% or the 230 patients, 35 had a positive PE, therefore na-XLAP sila. Now, 33 out of the 35 had positive injury. So, wow, you have 95% detection rate of your PE. Now, 195 were initially observed, no? And 5 developed late signs, therefore they underwent laparotomy, and out of the 5 who developed late signs, 100% may injury. The rest of the 190 were not explored at all. So what do we gain from this study, ni Demetriades? So PE is reliable in detecting penetrating injuries to the back with an accuracy of 95%. And local wound explorer is no longer considered, no, kasi it's a poor screening procedure, and DPL has no place in the management of penetrating injuries to the back. So these are the conclusions made from that paper. So the role of IVP is not clear. So all penetrating renal injuries should not be explored routinely. So if you look at our example case earlier, no, meron siyang penetrating renal injuries, but based on that study, medyo malabo yung indication ng IVP because we don't routinely explore all renal injuries kahit penetrating pa sila. So when do we explore renal injuries na penetrating? So operative intervention is reserved for pedicle injuries, so that would include your injuries to the vessels in sa hilum area, no? And uncontrollable bleeding. The rest can be managed non-operatively na safe naman. So ni-revise na naman nila yung algorithm, no? Because of the results from that study. So again, pagka negative yung PE, so mas nag-rely na sila heavily on the abdominal PE. But for gunshot wounds, ini-explore pa din nila lahat. Now, next study is on CT scan naman in the management of penetrating injuries to the flank and back. So this study involved 119 patients. So na-EL nila for patients who have positive that are positive on PE, maraming RBCs on DPL as well as hypotension. Pag walang findings na mentioned here, they opted to do a CT. So ganito yung itsura ng algorithm at that time. So pag negative yung abdominal PE, they opted to do CT scan. Pag positive yung CT scan, so now the diagnostic that they chose, no, to check kasi negative naman yung PE, so ang further diagnostic that they based their decision to do XLAP is the CT scan. So let's see what happened. So again, for that study, 50 patients had positive PE, 40 had injury. So maganda pa rin ang detection rate ng PE alone. For those naman na negative yung PE, na 65 yung na CT scan, and then 4 patients ang nag-positive sa CT scan. So out of the 4, dalawa yung negative laparotomy. So 60%, 50% rather yung negative laparotomy rate. If we just use CT scan to base our decision on whether we proceed with an XLAP or not. So this study concluded that PE, so the previous study gave us a sensitivity of 95, dito naman 80%. So based on CT scan, 65 out of 69 are managed non-operatively. And yun. So again, this study concluded na okay ang PE to manage penetrating injuries to the back. But the role of CT is still medyo hindi pa masyadong clear, no? Because a lot of patients on CT were managed non-operatively. And for those na naoperahan, 50% had a negative laparotomy rate. So hindi siya din masyadong magandang tool to base our decision on whether to explore the patient or not. Now this study naman, kasi di ba dati, if you go back to the algorithm, lahat ng gunshot to the back, mandatory XLAP. So this study challenged that. Kailangan ba talagang operahan? So this included 188 patients, but only 30% had gunshot wounds to the back. So let's look at that 30%. No, Yun. So, out of that 30%, no, pag nag-positive yung abdomen on PE, sila yung naoperahan. And all the patients na nag-positive ang PE, mataas ang detection rate. So, maganda pa rin ang PE to check for significant intra-abdominal injuries. So, 67% were managed non-operatively because of the negative PE findings. So as a conclusion, mandatory laparotomy is not, I repeat, it's not necessary for gunshot wounds to the back. So binawi na nila, sabi nila, pwede palang mag-selective management even with gunshot wounds to the back. Again, this is the third study to show that clinical exam is safe. Your PE is a safe method for selecting patients for non-operative management. So inalis na nila yung mandatory gunshot so nilagay na nila na whether it's for stab or gunshot, we can safely rely on our PE to decide whether or not we open the patient up. But nandun pa rin yung CT scan sa algorithm. Now later on, this study was based on the CT scan, a contrast-enhanced CT with colon opacification for patients na stable naman and with injuries or stab wounds to the back and foot. So again, here's another study also involving 145 patients, and sabi nila, since hindi pa masyadong clear kung paano yung sa CT scan, kasi diba the earlier studies showed na even with findings on the CT scan, it's not a good basis for deciding na operahan yung pasyente kasi nga mataas din yung negative laparotomy rate. So now they said, but why don't we classify as low or high risk based on CT scan? Let's operate only on patients na high risk on CT scan. So how did they classify high risk or low risk? So low risk is no injury based on CT and no subcutaneous injury. For the high risk, ito yung nilist nila. So any patient na may one of these characteristics, yun yung kinakonsider nila na high risk. But stranding, hematoma near a major vessel, renal extravasation, retroperitoneal free air, hollow viscous extravasation. So let's see, no? So out of the 145 patients that they included in the study, 92 were low risk. Therefore, hindi sila na-operahan. Almost half, yung 53, one half of the low risk, almost half of the low risk, only 53 were considered high risk based on the qualifications that I mentioned earlier, and sila yung na-operahan. So if you can see, only 4 had injuries, even with high-risk features on CT. And that just accounts for 7%. Yung isa, non-therapeutic laparotomy pa. So sabi nila, pag low-risk discharge, pag high-risk, pwede pang i-observe. Kasi, di ba, ang daming 7% lang yung nag-positive on XLAP. So even with high-risk features, may room pa rin pala to observe. Hindi kailangan i-outright laparotomy. So, even pag high-risk siya, nag-factor in pa rin yung BE. So, what does that tell you? Before we go to our the final algorithm, I will just show you the PGH experience on this penetrating injuries to the back. So it involves 99 patients in a period of a year. They came in 15 to 30 hours post-injury, most of them from stab wounds. Out of the 99 patients, 66 had negative PE. So they requested for CT scan for some of the patients. So out of the 66 na negative PE, 25 lang yung na-scan, and 4 out of the 25 had positive CT scan, therefore they underwent XLAP. And as you can see, all of the patients na positive sa CT, which was used as the indication for XLAP, resulted to non-therapeutic laparotomy So what does this tell you? So let's look at the other subset of patients. No, yung 33 na nag-positive PE na XLAP. And 31, so ang taas talaga ng detection rate ng PE alone. 31 had injuries, and this include injuries to the kidney, liver, colon, jejunum, duodenum, pancreas, spleen, IVC, and diaphragm. Only 2 had non-therapeutic laparotomy. So maganda ang batting average ng PE alone compared to your CT scan. So, ano nang mangyayari sa algorithm natin? No? So marami nang ma-erase. So mas lalo na siyang naging simple talaga. No? So we've gone across a lot of studies just to explain to you the algorithm to show you na hindi din madali mag-decide. No? There's a lot of studies to consider. Even local studies for PCS invest to give you the algorithms on how to manage these trauma patients. So pinag-aralan talaga siya ng husto. And it's in the process of updating. So pag meron kayong mga studies na alam na bago, then we are welcome to share it with us as well. No? Kung gusto ninyong magsalita, we can probably arrange for that. So for penetrating injuries to the back, then parang sa dami-dami natin dinaanan, no? From DPL, from urinalysis to IVP to wound exploration to CT scan, from all the studies that we considered, dun tayo mababagsak sa PE. So PE is enough, no? So this is our algorithm that we follow now. If your PE is positive from stab or gunshot wounds to the back, then that's the time we proceed with the XLAP. Pag negative, we can observe safely for probably for 24 hours, no? Pag wala pa rin nangyari, pwede natin i-discharge. Pero kung nag-develop ng positive signs later on, then that's the time we do our exploratory laparotomy. So in conclusion, after all the studies that we went through, abdominal PE is still reliable in detecting significant injuries to the back with a sensitivity reported from the studies of 80 to 95% and a specificity of 95 to 100%. So huwag na natin pahirapan pa yung mga sarili natin requesting all these types of diagnostics since PE naman talaga ang recommended sa present algorithm. Now again, let's go through one by one lahat ng na-mention natin ha. Local wound explorer is a poor screening procedure. It's invasive, inaccurate, and may be hazardous. DPL is unable to evaluate the retroperitoneum, therefore because the logical focus of investigation is in the back. Hindi mo siya masasample accurately with your DPL. Kasi retroperitoneum ang likely na injure with the back injuries. Therefore, DPL has limited use in the evaluation of penetrating injuries to the back. Again, walang correlation between the amount of hematuria and extent of renal injury, as shown in the studies. Although IVP is accurate in detecting renal injuries, it doesn't tell you of the associated intraperitoneal injuries. And majority of your renal injuries detected by IVP, like our case kanina, can be managed conservatively. And not all penetrating injuries are routinely explored. So kailan nga tayo nag-opera ng renal injuries? Unang-una, pagka pedicle yung injury, or pangalawa, there's uncontrolled bleeding. Otherwise, kahit may extravasation ng dye, hindi po natin sila ina-operahan routinely. So yung answer ng question natin sa ating case, hindi natin siya dapat i-XLAP kasi stable yung patient. Even if may extravasation of the dye, the abdomen remained soft and non-tender, and we have a CT scan that showed just a grade 2 renal injury with hematoma. So in part of the conclusion that we need to discuss are gunshot wounds to the back are amenable for selective management. Diba? Nakita ninyo yung process kung bakit tinanggal yung mandatory exploration for gunshot wounds to the back, because PE still suffice to detect that there's a significant injury for gunshot wounds to the back. However, if you're even with a clinically benign abdomen, when the projectile is located intraperitoneally based on your radiograph, laparotomy is warranted. Anong ibig sabihin? Malambot yung tiyan, but yung slug ay nasa loob ng abdomen, or yung projectile ng injury ay nasa loob ng abdomen based on your plain ab AP lateral, then laparotomy is warranted. For severe visceral injuries due to penetrating, severe injuries based on penetrating trauma to the back is infrequent, no, as you can see in the studies mentioned earlier. And if they are severe, they will be detected by your serial PE. Therefore, if there are no significant injuries, your PE will most likely be negative, and the majority of clinically negative abdomen will have negative findings on CT. Paano kung positive CT findings, like the PGH experience? Will this be enough for us to proceed with laparotomy? So if we just base our findings on CT alone, mataas ba din ang non-therapeutic laparotomy rate? Therefore, we should not base our decision to open the patient up on just by CT scan alone. So CT is not an efficient screening tool. It should not influence our decision to open up a patient or not, and our decision should be based on PE alone. Or if nakapag-decide na tayo na mag-XLAP based on our PE, tapos nag-CT scan tayo, benign lang, then dapat we should follow what our PE tells us, because CT is not an efficient screening tool. Walang further increase in mortality and morbidity associated with delayed. So in-observe natin yung pasyente dahil initially negative yung PE, tapos later on sa ward nag-acute ab, tapos sa kanabuksan, again, wala namang increase in mortality and morbidity kasi late sila nag-develop ng physical sign and symptoms. So dapat serial PE pa din para makatch mo sila agad once they develop already the clinically significant acute abdomen. Again, clinical exam or your PE or your serial PE is a safe method for selecting management in patients with penetrating injuries to the back. Therefore, the need for surgical intervention should rest upon your PE alone. So let's now, that ends the lecture. Let's now look at your questions in the chat box. Okay, so I'll answer the question of Dr. Alfeche, or we can also ask our experts here. Sir Jay, are you still around? Anyway, yung question ni Dr. Alfeche is, ano po yung experience ninyo after you discharge the patient 24 hours, after 24 hours observation, nag-develop ng PE. So, nag-acute ab. So, ibig sabihin, may cases ba na na-discharge na yung pasyente bago nag-develop ng acute ab? And how often does this happen? Sir Jay? Sir Jay?
Yes, can I repeat can I have the repeat question?
Ano daw, sir? May experience kasi, sir, parang ang ending doon sa penetrating injuries to the back, PE talaga, and then serial PE and observation. So may experience ka ba, sir, na kunwari after your serial PE and observation, napauwi na yung patient, pero bumalik pala kasi nagkaroon ng abdominal symptoms after na discharge. So madalas ba itong nangyari sa'yo, sir?
Actually, I have several experiences with injuries to the back, but those who were discharged did not have symptoms even on follow-up.
Okay, sir. Thank you for that. So, Dr. Alfeche, So yung designed na 24 hours, I think, is ample time to detect the significant injury. Sabi nga, no, pag significant yung injuries, magde-develop talaga siya ng clinically na acute abdomen within 24-hour period. And as mentioned by Sir Jay, he has quite an experience on this, and wala namang nag-develop ng clinically significant abdomen after ma-discharge and even on follow-up. So again, this only proves even more na safe yung PE to decide whether to discharge or observe the patients for those who have penetrating injuries to the back. And the follow-up would also tell you na okay naman yung mga pasyente. Wala namang bumalik after na pauwi because of acute abdomen. Any other inputs from our experts? Sir George?
Dun sa sa halimbawa yung utilization ng kung abdominal PE, di ba? Makikita natin din may 24-hour admission, and dun sa mga institution kasi na they can perform yung CT scan outright, then may chance kasi na ma-discharge yung patient in the emergency department kung walang significant injury. Yun lang yung input ko on that aspect.
Okay, sir. Thank you for that. Itong next question, tatanungin ko si Sir Bok, kasi si Sir Bok talaga yung author nitong best na guideline. Sir Bok?
Yes, I.
Sir, ang sabi ni Dr. ko, sa Schwartz po, the algorithm that they presented is for stab or gunshot wound to the back, CT daw po talaga yung decision ang ginamit whether to decide to bring the patient to the OR or not. So Dr. ko is asking, since okay naman yung PE to detect significant injuries, can we do away with CT scan na lang?
Okay. So siguro let's settle some issues about back. Irene explained it well, but I think we need to reiterate that since we're relying solely on physical exam, the one who should perform the PE should be the most senior member of the team, and that most senior will be the one deciding yung interpretation ng PE. Again, just to reiterate a point, dahil lang stab sa back, there's no way na magpa-positive yung PE mo sa anterior abdomen unless meron ka talagang injury. So at siguro, we've been adapting this protocol for, I don't know, alam mo naman yan, baka 10 years na, no? And it works well with us without requesting any CT scan. But again, we are vigilant and extra conscious on doing our PE, and the slightest change would trigger an explore lap. Alam mo rin yan, ay, di ba? Meron tayong binuksan. And ang maganda, pag binuksan namin, meron naman talagang findings. Some of them may be a retroperitoneal hematoma. Some of them might have a renal injury. Most of them will have a psoas muscle injury. So if we do a CT, ito rin yung mga makikita ng CT na magiging indication to explore, I think. But if you use the CT as a tool, as a trigger for explore lab, I think you will open more patients than what we're doing. Kasi marami kang makikita sa CT na most of them will have a negative PE. So my answer is, well, based on this protocol, maybe you're right. Baka kailangan na itong i-update. But as of now, I won't recommend CT scan. You just rely on your ever reliable PE done by the most senior member of the team.
Okay, thank you, sir. So I hope, Dr. ko, that answers your question, no? Marami namang studies that were presented na if we rely on the CT scan alone as the basis for surgery, sabi nga ni sir, maraming nakikitang hindi naman kailangan buksan, no? And the studies I presented showed na mataas yung negative laparotomy rate kung ang basis lang for opening the patient up is the CT scan, which you mentioned in the algorithm sa Schwartz. So very useful pa din yung clinical, yung PE, especially the serial. So dapat i-emphasize yung serial, no? Hindi one-time PE lang, tapos hindi mo na binantayan, tapos pinauwi mo na. So done by the most senior member of the team. So most likely, this is your 5th year na marami na siyang nakapang-abdomen na makakadetect na siya whether nag-develop ng acute signs later on. If you have a CT scan or naka-request kayo ng CT scan sa back, then you can probably document yung mga injuries, but using it as the sole decision maker for you to open up the patient, medyo hindi as discussed by Sir Bok and presented by the studies, marami kang mabubuksan na negative naman. Because yun nga, pwedeng psoas hematoma lang siya. And again, PE has time and again been proven, no, by the experiences of our experts and evidence na can detect significant injuries by as high as 95%. So, okay pa din yung PE natin for this matter. So, kung wala kang CT scan sa institution mo, huwag kang malungkot. Just be very vigilant and ask your senior members to do the PE for you. So, PE pa din ang ating ini-encourage, no, in the algorithm in deciding whether or not bubuksan natin yung pasyente. Last question po from our participants. Good afternoon. For non-operative management of renal injuries, what would be the restriction among the patients? When can they return to work? So let's ask Dr. Wico, sir. Sir, are you still here?
Hi, Rin. Yes.
Sir, anong advice mo, sir? Kasi di ba sabi sa best, hindi lahat ng renal injuries kailangan operahan. Only those who have higher injuries or those with uncontrollable bleeding. So sa mga hindi natin inoperahan, sir, meron bang mga restrictions sa work or activity?
Okay, thank you so much for that question. Una-una, for the acute care of this patient, no? Let's say na discharge na siya. Ang meaning nun lang, ibig lang sabihin nun that these patients, there is no acute problem in this particular patient. Now, if this patient will be discharged, it will really depend on the degree of injury of this patient. Ano ba tong patient na to? Did this patient underwent other procedures like an angiogram or piniil lang siya? So it really depends, no? And I would always suggest, since this is kidney, no, in my opinion and also in my practice, no, I usually get also the help of a urologist outside, no, para meron kaming collaboration in terms of what will be the best care for this particular patient. Thank you.
Thank you for that, sir. Also, if you try to look into yung urologic guidelines, the AUA, regarding conservative management of renal injuries, meron silang sinasabi na usually the significant bleeding would happen within 10 days from injury kung talagang significant yung injury, and would sometime kaya bantayan yung ihi ng patient. Yun. So as mentioned by sir, no, you also involve the help of your urologists. They have all these guidelines for the non-operative management of kidney injuries, and you can also browse it as well. And it will help you decide na kung madidetect ko yung significant bleeding in 10 days, then probably I can advise my patient na after sending them home, no, na magbantay po kayo kasi pwedeng magkaroon pa po ng bleeding within 10 days. Hindi po natin ginalaw yung kidney injuries. So I guess that would be the any more comments po from our experts? Beth, are you raising your hand?
Yes, Doc, sorry. Yung in addition lang dun sa nabanggit ni Dr. Ocampo, the physical examination, if we are really going to do the physical exam, siguro tama na senior would be the one. You're going to do it with your senior, most senior in the team, and then yung succeeding physical exam ng abdomen should also be done by the same team. Kasi minsan nagkakaroon ng iba-ibang decision. Like when I was still a resident, junior resident, iba yung opinion ng unang nag-PE sa sumunod na senior na nag-PE. So siguro to have a comparison, mas ideal kung senior, then yung susunod na PE siya pa din yung kasama mo para mag-guide ka rin. Tapos may continuity of care tayo for the patient. Yun lang, Doc. Thank you.
Thank you, Beth. So, very important yung ni-raise din ni Beth na syempre magkaiba yung assessment if you're looking into two different seniors. So, mas maganda kung sino yung nag-assess nung una, siya pa rin yung titingin para yung judgment niya whether may developments, siya talaga yung makakasabi ng if there's development of peritoneal signs kasi siya yung unang nag-PE. So again, thank you to our experts who are still here and graciously answering all our questions. Thank you po sa inyo, Beth, and our trauma experts as well, sila sir. Before we call it a day, alas 5 na po, I would like to ask Dr. De La Cruz, he is the president of the Asian Collaboration for Trauma, to give us a teaser for the upcoming webinar for ACT. So very active yung Asian Collaboration on Trauma for their webinars on the different topics. So I'll give the floor to Dr. De La Cruz to share with us the teaser, and then followed by the closing remarks of our boss in the Committee on Trauma, Sir George.
Thank you, The Asian Collaboration for Trauma webinar on October 22 will deal about leadership. And I think even for residents and fellows, leadership values and leadership traits are very important in the development of their career. So may I share my screen? Can everyone see my screen?
Yes, po, sir, we can see it.
Thank you. Thank you, everyone. And we hope that you could also participate in this webinar, though it is at 9 p.m. Philippine time, Manila time. But this will be an exciting webinar with John Files. I know everybody knows him, Raul Coimbra of the World Coalition for Trauma Care, Karen Basin, and Andrew Pitchman is the author of the Trauma Manual that most of the training institutions are have as their reference. Thank you, I.
Thank you very much, sir, for the invite. And sir, free po ito, di ba?
Yes.
Okay. So for the residents, take advantage of this international trauma webinar from our international experts for free. Medyo gabi nga lang, but I guess mas free kayo sa gabi. So thank you, sir, for the invitation. And to close this best online workshop, I would now give you our boss, our head of the Committee on Trauma of the Philippine College of Surgeons, Dr. George Concepcion. Sir?
Thank you. Thank you, I. Before I close, I would want to really invite the residents to participate in the leadership webinar by the Asian Collaboration for Trauma. As you all know, it is one part that we see is not standard in the training programs of general surgery. Some programs still does not have any activities pertaining to leadership. So take advantage of that. So before I formally close this day's activity, yung workshop natin on basic emergency skills for trauma, let me thank the subcommittee on BEST for devoting yung whole day today for this workshop, and of course our panel of experts for sharing their experiences, the PCS staff for facilitating, and our partner yung the telemedicine network of the Philippines. We started early, but midday, I think parang mga more than 600, close to 700 yung participants, and we are very happy for that many took advantage of the virtual basic emergency skills for trauma workshop that we presented. So as stated, hopefully we were able to help you out in reviewing for your CERES and RIT examination. And thank you for actively participating by your questions, because your questions really are too important for us to be able to clarify issues and concerns. With that, I'm formally ending this this day's workshop.
Thank you so much, Sir George, and thank you everyone for attending. The registration pala for the ACT is in the chat box, so pwede na po tayo mag-register. Thank you po. Enjoy your weekend.
Thank you po.
Thank you.
Thank you, Doc Ai.
Thank you.
Thank you po, Doc George.
Recording stopped.
Thank you, I.
Thank you, sir.
Thank you.
Thank you, Ms. Dean.
Thank you, Sir Alvin.
Haba, ma'am, no?